Allow them to present. Your time starts now.
Good morning, everyone. Thank you for giving me this opportunity, and I'll be speaking on the mismatch of short straight PFN with the anterior bow of femur. So we are all aware of the fact that the short PFN is straight in the sagittal plane, and it's available in 3 sizes. Now, what was the reason that we did this study? We saw in our OPD patients that patients post PFN coming with anterior thigh. Thank you for giving me this opportunity, and I'll be speaking on the mismatch of short straight PFN with the anterior bow of femur. So we are all aware of the fact that the short PFN is straight in the sagittal plane, and it's available in 3 sizes. Now, what was the reason that we did this study? We saw in our OPD patients that patients PFN coming with anterior recording. I don't know. Yeah, my recording. So we'll start from the beginning. Reset, go to timer to reset. So good morning, everyone. So my topic for today is mismatch of short PFN with anterior bow of femur. We are all aware of the fact that short PFN is straight in the sagittal plane, and it comes in 3 standard sizes: standard, small, and extra small. Now, why we did this study is that we found patients coming post-surgery in our outdoor clinic with the complaints of anterior thigh pain. We started to wonder why, and when we took the lateral x-rays, we saw that the nail tip was impinging against the anterior cortex of the femur. So the aim of this study is to analyze the radiographs of the patient with trochanteric fractures, which are operated by a short PFN, and to ascertain whether the functional limitation had anything to do with the high degree of mismatch. So the study was conducted in Sri Ramachandra University in Chennai. So this is a retrospective and prospective study from 2019 to 2021, and sample size of 80 patients. We included all patients with trochanter fractures AO31A2 and 31A3, aged between 40 to 80 years, and done between 2019 to 2021. Any patients with any pathological fractures, open fractures, inability to walk, or degenerative arthritis were excluded from the study. So use the AO classification to classify the fractures and use nail sizes ranging from 170 to 250 mm for fixation. We did standard AP and lateral x-rays on post-operative day to 1 month and 6 months. We ascertained the radial reduction quality using the tip apex distance and the neck shaft angle, and radiological analysis done at 6 months on lateral view x-rays. So the radiological assessment used 2 parameters. We used the nail tip position and the angle at the distant axis. Now, based upon the angle at the distant axis, we divided the patients into 2 groups, that is less than 4 degrees and more than 4 degrees. How we calculate the angle at distant axis is that from the nail tip, we go 2 centimeters above, and we draw perpendiculars on the anterior and the posterior cortex, and 2 centimeters below, draw perpendiculars on the anterior and the posterior cortex. And the midpoint of this 2 gives the line, and another line that is parallel to the anterior, that is parallel to the longitudinal axis of the nail, and the angle that is formed, that is the angle at the distant axis. Nail tip position has been given based upon this grading on the chart, that is from 0 to +5. It is basically the position of the nail tip based upon the central canal axis. And the functional outcome was scored on the Harris-Sipp score at 6 months. A generalized pro forma was done based on which the details were taken. So this one example, the 31A2 fracture. operated by a Halifax nail, 170 mm, diameter 10 mm, at 1 month post-op X-ray, 6 months post-op X-ray, acceptable reduction parameters. And if you see the 6 months, the area was 3.64, nail tip position, grade 0. The Harris-Hip score came out to be around 81. Another case where 3.1A2 fracture was operated by a PFN. It was 1 month post-op X-ray, acceptable parameters, 6 months post-op X-ray, a 240 mm nail was taken. And if you can see, there is an impingement on the anterior cortex. The ADA came to be around 6.12 degrees and grade 3 nail tip position. The functional Harris-Hip score was around 60. Another case where 3.1A2 operated by a PFN-A2 helical blade, 1 month post-op, 6 months post-op, acceptable reduction parameters, radiological analysis, the angular distant axis was 6.16. This nail size was 240 mm and the nail diameter was 10 mm. Functional Harris-Hip score was 55. This patient had complaints of anterior thigh pain. Some of the complications, this patient had a peri-implant fracture, if you can see, around the distal tip. Radiological analysis came out to be around 4 degrees and grade 2. Another case of a lag screw cutout, another complication where a helical blade cut through. So we analyzed total 156 patients and included around 80 cases. The range, mean age was 68.4 years. The acceptable parameters of the reduction, the nail size most commonly used was the 200 mm nail and the distal diameter most commonly used was the 10 mm. So if you see that the mean area was 4.19 degrees and the range of area ranged from 1.41 to 7.5 degrees, with the nail diameter 10 being the most commonly used, 49 cases, and the nail grade tip position was 3 and 4 on radiological analysis. So when you see that 19 patients complained of anterior thigh pain on follow-up, but however, no of the patients had anterior cortex penetration. 1 patient sustained a peri-implant fracture and 2 patients had failure cases, so the helical blade cut through and sealed. So coming to a discussion, we have cases that 71 cases showed anterior location of the nail tip and 49 cases showed abutment against the anterior cortex. A similar research was done in Shanghai, where 118 cases had anterior location of femur nail and 55 cases showed abutment against the anterior cortex. The mean area in our study was 4.19 degrees and the number of patients with area more than 4 degrees were 43. Another study which was done on Caucasian population, which was done in Turkey, showed that the ADA was mean ADA was 4.5 degrees. And ADA more than 4 degrees in our study had an increased incidence of anterior thigh pain, which was again found to be statistically significant. When he correlated the nail tip with the different grades of the size of the nail's length, we found that as the nail length increased, the percentage of the anterior nail tip abutment also increased. And this was in conjunction with the study which was done in Shanghai, which also showed that similar cases, that as the nail length increases, the anterior tip abutment percentage also increases. So 25 patients had the nail tip grade 3 and 4, out of which 16 had anterior thigh pain. 55 patients had nail diameter 10, which had again anterior thigh pain, and 53 patients nail length 200 and above that again complained of anterior thigh pain. However, we ascertain certain limitations, acknowledge the limitation, sample size was not adequate. All the x-rays were evaluated by the principal investigator, so definitely an issue with blinding. And however, we didn't take into account the height, age, and the bone mineral density, all of which does affect the morphometry of the femur. My take-home message is that if you are going to opt for a PFN, go for a short PFN, go fix it with 170, 180, it doesn't matter, and use the shortest nail length that is possible. Thank you for your audience. And this is the paper that we have recently published in the Journal of Orthopedics. And the study was done in Ramachandra University in Chennai. Thank you, sir.
Discussion.
Yes, sir. That is not a complication with a nail tip. That's what I said, sir. There was no anterior cortex perforation. That patient that happened, actually, it was a complication from our part. When initial surgery was done, the screw was not through the nail. The screw was outside the nail. When he started to revise it, then it fractured.
Locking was not proper.
Locking was not proper. But in our cases, there was no peri-implant fracture. Only patients came with anterior thigh pain.
This fracture was again fault.
Yes, yes.
Any more question?
You have studied only, you have recommended only short PFN.
Yes, sir.
So your study does not apply to when we use long PFNs.
Yes, sir.
Is it
Yes,
right?
sir, it's true. Because long PFN already having a curvature, sir. Short PFNs are straight. The issue happens when you are using a 250 nail. Because recently, 2 days back, we used a 250 nail in a hospital in the Kalani. What happened? The nail was not going in. And when he saw the lateral X-ray on the thigh, the 250 nail is already hinging against the anterior cortex. So there is no way the nail is going in. And it was not going into such an extent that there was not even a space to put only one lag screw. It was the PFNA that has 2 screws, lag screw and a derotation screw. It was not even in the position so that we can put a lag screw. And unfortunately, the company person has given us only 2 nails, one that is 9 into 250 and 10 into 250. So we had no options but to bang in the 250. But that is always a risk that you might, while banging in, you can perforate the anterior cortex and then can cause a iatrogenic fracture.
With shorter nails, you don't have.
You don't have the percentage of impinging considerably decreases if you use a shorter nail. That's why Synthes has started only 170 PFNA2. This study, the initial study that was done in Chinese population was done on PFNA2 helical blades, and they recommended use a 170 nail and go for a 9 diameter. Even if it is a wide canal, forget about the fit. It is only matters that is the fixation at the trochanter region, whether it is strong or not. The medullary canal diameter doesn't matter.
Okay. Is that applicable for universally in any community or only for the Indian community, people? And what is your recommendation for generalizing?
Exactly, sir. So the thing is that before my study, there were only 2 studies in the literature. One was done in Chinese population, another in Caucasian that was done in Turkey. And the thing is that region-wise morphometry of the femur changes. So I mentioned in my limitation that I didn't study the BMD age and this thing.
So, okay, this session is over with one comment only.
Yes, sir.
Because in this particular competitive sessions, the paper which will be presented, that must be original work as well as before publication. After publication, this should not be presented in such a competitive session.
Okay.
So we invite the next speaker, Dr. Swastik Bhattacharya.
আচ্ছা স্লাইডে কন্ট্রোল কোথায় এখানে স্লাইডে কন্ট্রোল এটা তো ঠিক আছে তেমন দেখি ঠিক আছে
I am handing you the certificate. Next.
Good morning, my respected seniors and my dear colleagues. Today, I'll be presenting a retrospective study on the management of the preaxial polydactyly of foot and their outcomes. I am Dr. Swastik Bhattacharya. Polydactyly is a congenital condition in which more than one toes are duplicated. Incidence is fairly common without sex predilection. About 50% cases are bilateral, with genetics being autosomal dominant with variable penetrance. It is most commonly associated with syndactyly, and it is due to the failure of differentiation of the apical ectodermal ridge. It was first classified in 1969 by Tempany as the preaxial, central, and postaxial types. Preaxial type is when the hallux is duplicated. The central type is when the second, third, and fourth toe is duplicated. And postaxial is when the fifth toe is duplicated, out of which the postaxial type is most common, followed by preaxial. Now we come to the most commonly used classification, that is the Venn-Watson classification in 1976. It is based on the abnormalities of the metatarsals and the phalanges. It is divided into type A, that is the postaxial type, which takes into account wide metatarsal, T metatarsal, wide metatarsal head, and complete duplication. Whereas type B is the preaxial type, which is composed of the short block first metatarsal and wide metatarsal head. Now, why do we operate in a case like this? The most common reason is cosmetic, because the patient comes with a complaint of cosmetic correction. There may also be a functional cause, that is persistent foot pain and gait abnormalities. So the decision for surgery is based on the patient's requirement. The surgery of choice is ray resection, that is done at least after 1 year of age. after identification of the vascular pedicle without injuring the epiphyseal ring. Now we come to the first case, which is a 3.5-year-old female child with preaxial polydactyly with 2 extra digits without any significant family history and no significant anti or postnatal complications. In the preoperative X-ray, we see that it is a preaxial polydactyly with complete duplication of the metatarsals. In the intra-op photo, we see that ray dissection has been done with complete dissection of the metatarsals and the medial most support has been left. Post-op X-rays look good with good soft tissue coverage. However, on 1 year follow-up, we see that hallux valgus has developed due to the loss of medial support. Now we come to the next case, which is a 17-year-old male without any significant family history or uneventful birth history. Patient had a requirement of normal shoe wearing. X-ray shows a complex preaxial polydactyly with 3 separate duplicate metatarsals, with one of them being a Y metatarsal. On post-op, we see that the medial most support has been left and the extra digits has been dissected out. However, the first toe is at a shorter height than the other toes. And on persistent other follow-ups, we see that there is a development of a bunion. The next case is a 4-year-old girl with insignificant birth history, but polysyndactyly of both feet with congenital hallux valgus, as well as syndactyly of both hands. On X-ray, we see that the right foot has a short block metatarsal, while the left foot has phalangeal duplication with wide metatarsal head. On post-operative, we see that the extra digits have been resected out and the short block metatarsal has been corrected using wedge resection and fixed with K-VAS. On 1 year follow-up, we see that on the left foot, the syndactyly has not been corrected and the gap between the first and the second toe is increased. On 3 year follow-up, we see a partial correction of the bullet metatarsal. The next case is a 10-year-old male with both pre and post-axial polysyndactyly of both feet. The X-ray shows left foot with wide metatarsal head and post-axial with Y metatarsal. The right foot has a wide metatarsal head in both pre and post-axial types. Post-op X-ray. On 1 year follow-up, we see that the polysyndactyly of the great toe has not been corrected well and the extra digits remain. The next case is a 5-year-old female. The next is a 2-year-old female with simple preaxial polydactyly with phalangeal duplication also associated with tibial hemimelia on one side. This is the 1 year follow-up with increased toe space. In conclusion, I would like to say, since the surgery is done at an early age, proper follow-up till skeletal maturity is important to look for any delayed complication. Identification and preservation of the vascular pedicle is most important, as well as preservation of the epiphyseal ring. And proper soft tissue coverage is important for the post-op wound management. So the take-home points are that preaxial polydactyly is a fairly common condition and surgical correction is based on the patient's requirement. Proper preoperative planning is necessary to identify the vascular pedicle as well as the epiphyseal ring. Surgical correction is plagued with various complications, hence long-term follow-up is necessary. These are my references. Thank you so much for your patient hearing.
So.
Can I ask?
Yes, yes.
Hey, Mukul, the biggest danger, sorry, the biggest danger of this surgery is vascularity.
Yes, sir.
Okay.
Yes, sir.
In adult, you can easily assess by doing a CT angio. But have you ever done it in children?
No, sir.
I don't know. I feel perplexed of how to assess the vascularity preoperatively in a child.
No, sir. For the first case that we see, case for number 1, we did a color Doppler study to determine the anatomical position of the arteries and thereby the.
Does not identify anterior dorsalis pedis, nothing. It does never identify the position of the dorsalis pedis. That is the crux of this surgery.
Okay, sir.
Because that is shifted somewhere here, there, and you are doing it under tourniquet, whatever you will find, and the entire tissue slumps out. I know this because I had to face this.
Okay, sir.
Then I learned that, but in children, CT angio not allowed. Okay. That's why you are asking him. You have no how to assess the vascularity in a child of a foot.
So we did a color Doppler on the first case, and it determines whether on which ray on which ray the artery, the main vascular pedicle is present, and we can plan from there on.
Is there any more question?
In the second
Yes, yes.
case, I
Yes, sir.
think the second case,
Yes, sir.
the toe, the third toe was way longer than the other toes.
Yes, sir.
So there's something called a focal gigantism.
Yes, sir.
Was it present in any of the other limbs? Because that
So-
causes a lot of problems.
Okay, sir, just 1 second. Sir, are you talking? Okay, so,
I think on the third slide,
on the third slide,
go back.
this one,
No,
this one.
no, no. No, no.
This one.
Go back. On the third toe was much longer. Doesn't matter about the kilometers. Sometimes it is associated with focal gigantism. Did you get any of these cases, other cases?
No,
So one more question is that you have commented that preaxial this kind of deviation, duplication
yes.
is common. Is it so?
No,
Or
sir.
it is the post-axial
No,
is
sir,
commonest?
post-axial type is
So
common.
why you are saying it is common in the preaxial?
No, sir, post-axial type, as per literature, post-axial type is the commonest,
Okay, thank
followed
you.
by
You
pre-axial.
collect
I
your
have got a
surprise.
question.
Hey, it's, it-
Chairman, sir. No.
Thank you, Swastik Bhattacharya. Please collect your certificate.
Take the, all the present here and we'll have to discuss. After the next conference is over.
collect your certificate.
Our next presenter, Dr. Aniruddha Bhattacharya.
Hello. Good morning to the chairperson, judges and learned audience. Myself, এটা চেঞ্জ করতে হবে এটা আমার নয় এখন একটু yes sir yes sir yes sir good morning, sir. Myself, Dr. Aniruddha Bhattacharya, PGT Orthopedics, RGCor Medical College Hospital. My topic today is Eden Hibernate procedure in recurrent anterior shoulder dislocation, a short-term result. As an orthopedician, sir, we get commonly anterior shoulder dislocation, which may be a primary or recurrent cases. For anterior shoulder dislocation, there are various common surgeries in there, and my procedure is Eden Hibernate procedure. And what is the Eden Hibernate procedure? Is just performing an autogenous bone block applied to the anterior rim of the glenoid. And the common indication of Eden Hibernate is till date it is a salvage procedure for failed arthroscopic and open Bankert repair and failed lateral surgery or a significant bone loss greater than 40% in glenoid rim. My aims and objectives of the study to assess the functional outcome of Eden Hibernate procedure in failed previous surgery or as primary surgery. And sir, it's a prospective cohort study and done at RGCor Medical College and conducted for 2 years. And the population of study, the patient who is attending our OPD commonly with previous shoulder dislocation, which may be previously their surgical procedure done or not. And my sample size only 12, sir. And the inclusion criteria for my study, all patient with failed arthroscopic or open Bankert repair and patient with previously failed lateral procedure. And the exclusion criteria with patient with rotator cuff tear and patient with multidirectional instability and which is measured by Batten score greater than 5/9. The study procedure for that, our study sample 12 patient taken for the study purpose, 7 for failed Bankert repair, 3 failed lethargy procedure, and 2 primary cases. Among them, one is the epideptic female and another male with greater than 40% bone loss. And this is that my patient demographic table. For the evaluation, pre-op evaluation, we take a digital X-ray to look for arthritic changes and in-phase 3D CT scan for measuring the bone loss. And pre-op post-op functional outcome measured by ROI score. For statistical analysis, we used Prism software and Mann-Whitney test for non-parametric data and unpaired test for parametric data. Pearson correlation coefficient is used, and the level of significant set as p-value less than 0.05. And there is our pre-op patient with significant bone loss seen in end-phase 3D CT greater than 40%. And for operative stakes, the patient on the B chair supine position, anesthesia will be given GA with combined with interscalene block and incision, as we see on the tip of the coracoid to anterior axillary fold. After through axillary nerve trail, we deltopectoral groove is identified, and this is the open glenoid rim, and we used the bone chunk for the ilia crest bone graft we used. And this is the surgical procedure we seen. And post-op, this is the post-op CT scan of that patient, and follow-up protocol for 4 weeks. First follow-up, second follow-up 12 weeks, third follow-up for 24 weeks, and fourth follow-up after 58 weeks. And this is one of my patient with post-op follow-up. And the result, the mean post-operative ROI score improved to 81.25 plus minus 15.54 with stability and mobility having positive correlation measured by Pearson correlation coefficient. And redislocation does not seen any of my patient. You see the table here. There is no recurrences and no subluxation, only apprehension with in certain position only 25% in seen, and apprehension with instability when 16.67% is seen. And this is the depicting significant improvement in pain function stability, mobility after Eden hibernate procedure. And this is the outcome. 50% of our patient with very good outcome, and 25% with excellent outcome, and 25% with average. The conclusion is in Eden hibernate procedure has the merits of incorporating large bone graft to match the contour of the glenoid defect, ensuring the rigid fixation and conversion of an off-track heel shake lesion into an on-track lesion, with active or active assisted rehabilitating being pivotal in hurling good to excellent outcomes. Glenohumeral arthritis should be ruled out pre-operatively, and the limitation of my study is a short-term study, a less number of patients, and long-term complication like arthritis cannot be evaluated. And thank you.
The audience is invited for
My
asking
question
questions.
is, hello, Chairperson, my question is, with the letter jet, you have the fleeing action which protects. So why in third case letter jet you have done it well, but what is your criteria for doing this procedure over letter jet, and what advantage do you predict?
Sir, actually in the lethargy procedure, we use coracoid transfer, and for significant bone loss, there is coracoid is not such large to make up this, and for dynamic sling action is there, but for better stability we go for letter jet, as because we use large size ilia crest bone graft.
Got it. Next question.
In your series, post-op internal rotation.
Post-op internal rotation, sir. Post-op.
Yeah.
Post-op, sir, only
Did you measure the average internal rotation in all the patients and average it?
Yes, yes.
Because it is mostly internal rotation is restricted in this type of cone block procedure. And
Sir, there is some restriction is there. We found only 85 to 90% of patient there is without any complication. For some patient there is some complication is here, but maximum patient without any complication.
without any complication.
So Aniruddha, no more discussion. Not discuss, do not discuss, question only.
I have a
This is the
question.
question. This was the question. What is the internal rotation? That was the question.
That he has
Yeah.
answered.
Thank
Okay,
you.
I
have
so
a question. I
one
have
more
a question.
question.
I have
That
a
is
question.
regarding, just
Can I?
a minute, just a second. That is you have said that this is a cohort study.
Yes, sir.
And the cohort study, it's to be compared with some method.
Okay.
And the risk ratio would have been the best method of critical analysis of that. Have you done that?
No, sir. Actually, it is for simple study for that procedure.
So actually this is not possible, Putusda.
Yes, sir.
Did you do routine MRI of all patients preoperatively?
Yes, sir. Is there any rotator cuff injury or there or not to exclude our patient?
No, specific answer. Did you do routine MRI in all patients? of this
No,
field?
sir. No,
Then how did you assess the rotator cuff tear?
sir.
You have said that criteria, exclusion criteria is rotator cuff tear. So you have to assess preoperatively whether the patient has a rotator cuff tear or not, and that you can only do by an MRI. If you do not do a routine MRI in all preoperative cases, then how do you assess the rotator cuff tear?
Putusda got it, the question. She has not done it. Okay. There you collect your reactions.
Okay, sir.
Your time is over.
Next is Dr. Parvez Shamim.
Outcome of lateral interbody fusion in patient with moderate to severe lumbar canal stenosis associated with neurologic claudication. So lumbar degenerative disease is the most common cause of chronic low back pain associated with radiculopathy and neurologic claudication. And this disease leads to lumbar canal stenosis with or without spondylolisthesis. Here is an MRI picture showing spondylolisthesis at L4, L5 and lumbar canal stenosis. And sagittal imbalance is the underlying cause in this disease, and maintaining spinopelvic alignment, especially sagittal, is the crucial step for successful outcome of lumbar fusion surgeries. And lumbar fusion surgeries are very effective procedure for lumbar degenerative disease, as it restores disc height, corrects spinal imbalance, and decompress neural phenomena. And direct decompression of neural phenomena done by posterior approach, whereas indirect decompression done by anterior approaches, especially lateral and anterior. Other indications are recurrent disc herniation, spondylodiscitis, etc. Coming on to the lateral interbody fusion technique, failed posterior fusion and degenerative scoliosis are other diseases apart from my current study. And it's a very minimally invasive approach which restores lumbar lordosis, provides large surface area for fusion, and there is a very little incidence of nerve root injury in these surgeries. We studied on 15 patients with moderate to severe lumbar canal stenosis, with mostly associated with low-grade spondylolisthesis, and some patients had multiple level of stenosis in which posterior fusion surgeries were required at L5 and S1 level. Assessment were done by VAS and ODI scoring system, and improvement in lumbar lordosis and pelvic tilt were noted. Operative technique, all patient pair position, right lateral decubitus position, and pre-operative assessment of surgical corridor was assessed using MRI, and that's the plane of our surgery between psoas and aorta. We used minimally invasive tubular retractor system, and by this approach, we inserted our cage followed by posterior fusion, followed by posterior fixation using pedicle screws. And average age was 62 years, and maximum number of levels operated was L4 and L5, and additional L5 S1 level was operated, in which posterior surgery is required in 3 cases. And significantly improvement achieved in sagittal imbalance in almost all of the cases, and progressive improvement in VAS score and ODI score over a period of 1 year. Almost all of the patients were mobilized from next post-op day onward, and almost all of the patients returned to full function within 6 months. Some of the noted complications listed here. Finally, we can conclude that it's a very effective procedure, and a minimally invasive approach corrects spinopelvic malalignment with lesser incidence of nerve root injury and posterior element destruction. Let us review our few cases. First case, 64-year-old male with multiple level of stenosis. We can see on the MRI. Here, we achieved significant angle of lordotic curvature, and patient is pain-free from the second post-op day onward. We can see the spinal canal diameter improvement at L4, L5 and L3, L4 post-operatively. Second patient, degenerative scoliosis with multiple level of stenosis in a 68-year-old female. Here, coronal as well as sagittal plane deformity were present. It's not moving. See, it's the surgical This is a surgical technique we discussed, and correction of coronal as well as sagittal imbalance are noted. Third case, 48-year-old female with grade 2 spondylolisthesis and lumbar canal stenosis. This is the surgical corridor assessment on MRI. And this is the final post-op picture with 100% achievement in the spondylolisthesis reduction as well as spinopelvic alignment. That's all for today. Thank you.
A timer for discussion. Now I invite questions from the audience.
Okay, I'm not questioning you. Just tell me, how is it better than the standard posterior telegraph or whatever?
Sir, we can approach the upper lumbar segments like L3, L4, L4, L5 and L2, L3 level with the same incision rather than opening at different sites. And also it provides better alignment as compared to the posterior approaches.
That is if there is a lateral bending.
Yes, sir.
Technically, much more difficult and much more risky than doing a standard telegraph.
Yeah, yes, sir. But it's a very minimally invasive approach, and time is very less when we do this surgery, sir.
Joshua, please.
I have not gone through your full of the lecture, but what I think that you have suggested that there should not be any laminectomy in these cases, all of your cases.
No, sir, it's an indirect decompression technique rather than direct decompression technique,
Many of the times there is a compression in the lumbar canal is due to thickening of the flava and facet joints hypertrophy, all that. How will you address all those things with this technique?
Sir, it's depending on the surgeon's preference, sir, which approach you are using and which you are not using, sir.
How will, if the stenosis is for the mostly for the facet joint hypertrophy or due to the thickening of the flava, then you cannot achieve decompression.
Sir, if there is facetal hypertrophy and all, then we have to go through the posterior approach rather than anterior
Only
approach.
selective, you have mentioned that this technique is only for the selective cases.
Sir, I have used for lumbar canal stenosis with or without spondylolisthesis rather than any facetal involvement.
For lumbar, involvement and the hypertrophy of the flava. Will also mention.
Yes, sir. Ligament, if isolated ligamentum hypertrophy is there, then you can address through this technique also.
That is my question. How will you achieve the posterior, the broadening of the canal?
Sir, it's,
You can address the foraminal stenosis.
yes, sir.
By this case.
Yes, sir.
But in the canal, how can you achieve?
Sir, I have already shown in the post-op slide that improvement at L3, L4 and L4, L5 level, which I have already shown. Thank you. Thank you, sir.
Thank you, Dr. Parvez. Our next speaker, Dr. Parkavian. Please come on the stage.
Hello. Good morning, everyone. I am Dr. Parkavian, junior resident from North Bengal Medical College. I am going to present my case study paper on functional outcome of arthroscopic management of popliteal cyst and observational study. Popliteal cyst or Baker cyst is enlargement of bursa between gastrocnemius and semimembranous that communicates with the knee joint. It's commonly associated with intra-articular knee disorders such as osteoarthritis, cartilaginous lesions, ligament and meniscal tears. So my aim of study is to evaluate the clinical efficacy and functional outcome of the arthroscopic management of popliteal cyst. And we included 14 patients with symptomatic popliteal cyst, and out of which 3 males and 11 females. Preoperatively X-ray, USG and MRI taken for all the patients. We used Roshning and Lindgren criteria for grading of the popliteal cyst. We included all the patients with symptomatic grade 3 swelling, that is swelling and pain even when resting, and range of movement limitation more than 20 degrees. And we included patient age between 18 and 65 years old male. We excluded the asymptomatic patients and severe osteoarthritis of knee grade 3 or more, and patients with severe rheumatoid arthritis and severe other comorbidities. Materials and methods, we taken preoperative X-ray to find any intra-articular pathologies, and ultrasonogram also taken. MRI is essential. MRI is essential to detect the location and diameter of the cyst. Here, this typically shows the popliteal cyst between the gastrocnemius and semimembranous sagittal section. Axial section also shows the popliteal cyst. So coming to arthroscopic management, after we creating the routine anteromedial and anterolateral portal, we do the routine intra-articular arthroscopic knee examination to find any chondral lesion and meniscal tears or ligamental tears. And then we enter into the posteromedial compartment and we create the posteromedial portal. Then we direct our arthroscope to the opening of the cyst, and we found all the capsular folds and remove the capsular folds and enlarge the valvular opening to drainage the arthroscope popliteal cyst to knee joint. It's a surgical technique. Here, we are, after doing the routine arthroscopic examination, we are entering into the opening of the valve. After entering into the opening of the valve, we enlarge the valvular fold and remove all the loose bodies. Then we are now entering into the cyst. After entering into the cyst, we can do trans-system cystic portal for the debridement of the cystic wall. And we follow up the patients at 2 weeks, 3 months, 6 months, and 1 year follow-up. At the final follow-up, we use the Roshning and Lindgren criteria for the evaluation, and recurrence was defined as grade 2 and more. And MRI at the 1 year follow-up shows there is complete removal of the cyst, and there is no recurrence found. And clinical evaluation of the popliteal cyst, at final evaluation, we used the Roshning Lindgren criteria, and at 1 year follow-up, there was no patients with grade 2 or more. And we evaluate the functional outcome which with the Liscombe knee scoring scale and rationing and Lindgren Kate and visual analog pain scale also. Our result shows there is significance with the clinical efficacy was good with the p-value. And we also compared in this study with the debridement of the cystic wall and without debridement of the cystic wall, and also addressing the associated knee joint disorder like meniscal tears and degenerative osteoarthritis, synovitis, and chondral degenerations. But there was no significance whether debridement of the cystic wall done or not. And discussion in arthroscopic management, we can directly address the cyst and also the main pathology, which is the valvular mechanism, which is connecting to the cyst and the joint. And we can also address the intra-articular pathologies also. The complications were hematoma formation, portal stent infection. There can be persistence of pain and technical error during cyst debridement. And the management options we have for arthropopliteal cyst is we can go for either open excision and repair of synovial opening and aspiration of injection. But in the arthroscopic procedure, we are mainly focusing on the main pathology by enlarging the valvular opening and drainage with or without debridement of the cystic valve. And also we address the intra-articular pathologies also. Here is the anatomical landmark around the popliteal cyst. The schematic diagram shows that the valvular fold which is connecting to the cyst to the gastrocnemius and semimembranous to the knee joint. We excise this part of the capsule to drain the popliteal cyst. And what is the risk of complications with the open excision is in open excision, as we all know, there is high recurrence rate and abscess formation and fistula formation, saphenous nerve injury. So why high recurrence rate in open excision is due to mainly unsolved intra-articular pathological condition like meniscal injuries, ligament tears, and cartilaginous damage, and synovitis, patellofemoral arthritis. So why we have to go for arthroscopic treatment is it's minimally invasive. It's focusing on the main pathology of the disease, and it can address the intra-articular knee pathologies also. And there is minute risk of neurovascular injuries. So we conclude that the arthroscopic management of popliteal cyst with the correction of its valvular opening and treatment of associated intra-articular pathology is effective and safe, and it's minimally invasive, and it significantly reduces the recurrence rate in both clinically and radiologically. The limitations in our study is the follow-up time was short, 1 year. Long-term follow-up needed to know whether cyst occurs over the time, and only 14 cases included in this study. We need more cases to increase the statistical power. Take-home message is arthroscopic management with its good clinical and functional outcomes shows its novel technique as it significantly reduces the recurrence rate by addressing intra-articular pathologies also. Thank you.
So timer, please. And questions are invited from the audience.
Dr. Parkavian,
Yes, sir.
how many patients of popliteal cyst actually need surgery, open or arthroscopic, irrespective?
So only the
Do many patients require surgery in popliteal cyst?
no, so the main management is conservative management, sir, without
What
surgery.
is the significance of this study?
So this study is we included only the symptomatic patients, sir. Symptomatic patients with grade 3 only we included. Yes, sir. Yes, sir. Yes, sir. Sir, that we compared, sir, whether not every patient's debridement was done. Only 8 patients we did compared whether cyst wall debridement done or not. That shows there is no significance, sir, whether cyst debridement of the cyst wall done or not, sir.
Excuse me,
Yes, sir.
if I'm remembering, there was a publication in IGO by Amit and Chajar about the same procedure, arthroscopic debridement. And
Yes.
yeah.
References.
So is there any difference of that procedure and this procedure? Amit and Chajar has published this in IGO. You go back, Indian Journal of Orthopedics, this procedure is already published. So is there any difference? Like
No difference. We have done the functional outcomes, sir. I did not see that that study, sir.
Technique, is there any difference of your technique than that published one?
I haven't went through that article, sir.
Fine.
Thank you, Dr. Parkavian. Please collect your certificate. The next presenter is Dr. Orgho Saha.
Good morning, everybody. I am Orgo and I'll try to justify my topic. So this is a 35-year-old male, sole breadwinner for 7, truck driver by profession, robustly built, pansure, financially crippled, MVA on 28th of January 21. So he visited 4 hospitals before me, all unanimously offered amputation, landed with us 96 hours post-injury, and the pictures speak for themselves. So these are the pictures at my clinic. Ghastly position. The foot. These are the presenting x-rays of the leg and the foot. So it's the problem statement. It's a 4-day post-injury delay. Gustlo Anderson 3B leg, closed foot fractures, 4th toe tip avulsion, mangled limb, exposed bone pieces, shattered both bone fracture, necrotic muscles, foul discharge, attempted suturing or primary closing, sepsis, and lost hopes. So the assessment is Ganga Hospital over injury superiority score, and the score came as 18. We chose to bite the bullet. Limb salvage was planned against all odds, even Gois. Thorough counseling was done. Multiple procedures were contemplated. So this was surgery number 1, where we did a debridement and external fixator was applied. This is all the loose bone pieces were discarded. The length was maintained. We did a CT angio interim to see for the vascularity of the limb, and it was found to be intact, worth salvaging. Surgery 2, 3, and 4, repeat debridements after 24th, 3rd, and 7th day. So this is at the 7th day. And now we plan to apply a WAC. So this is after the first WAC sitting, after the second WAC sitting, after the third WAC sitting. So surgery number 5 was final debridement, split thickness skin graft, fix after 3 weeks of STSG being sheared. Six weeks after STSG. The looks become hopeful. So the present scenario was, it was a healed skin, X-fix in situ, pin tracks were healthy, length, alignment, and rotation were maintained, posterior 1/3 contact in tibia, foot drop with foot fractures. So this was the X-ray. So surgery number 6 was X-fix removal, pin track debridement, above knee POP slab, and cooling off period of 2 weeks prior to final intervention. So final surgery was ORIF of tibia with a nail, shingling, iliac crest CC autograft, foot fractures were fixed in the same sitting, and foot drop was conserved in a splint. So these are the pictures of the leg and foot surgery. These are the post-op X-rays. 1 year post-injury. All things healed. Foot drop recovered completely. No pain, full range of motion, no sign of infection, no limb length discrepancy, and no limp. Walking without support, resumed his job 6 months of index surgery. Happy and thankful. God was gracious indeed. So this was the 1 year video. He was walking, and these are the current video pics 2 days back sent to me by WhatsApp. The patient is comfortable, able to sit, squat, walk without support, has resumed his job. He is able to use Indian latrine, comfortable. And the foot drop has healed. Thank you. Yes.
Timer. So,
Presented this paper here. It is not a paper.
Sir, it is,
Beautiful case, no doubt about that. কিন্তু এটা তো মিটকনের কেস but beautiful.
thank you, sir.
But this is not the fault of Orgo. But this is not the fault of Orgo. He has sent it, the selectors have selected. So what is his fault? But one question to Orgo.
Yes, sir.
How did you fill up the gap of the TVA anteriorly? Did you open the site?
Sir, I opened the site while the name.
Skin grafting.
Yes, sir. No, sir, what
How-
I opened by an anterolateral approach. I opened by an anterolateral skin. My idea was to do grafting. I anyway had to open up. My idea was to do a shingling. I anyway has to open up. So I utilized it.
Although very well managed mangled extremities. Just one question that none of your cases, all the cases are almost gastilo type 3B or something like that. So one, okay, but no vascular injury is there.
No,
So no vascular injury, no neurotoxic there. So why are you talking about the first instance that is thinking of someone is amputation? But no question of amputation.
let me clarify. The patient came to me after consulting 4 hospitals and 4 surgeons. Nobody was bothered to get a CT angio done. Everybody assumed that the leg is not to be salvaged. Even the Ganga hospital score, which does not include the vascularity part, soft tissue, muscle, bones and skin, it was 18. It was against limb salvage. So apart from vascularity, there are multiple issues, including the contamination, etc., etc.
Yes, yes, but
So I did not give idea of amputation.
for vascularity is intact.
Yes.
It's not delayed, but no point of thinking of amputation on the day one.
I was
Another
not.
one is
Yeah.
that before going to CT angio, there is something else that is you can palpate the distal pulses. You can also. Now this is the question that we can examine it or not.
yes, sir. Yes, sir. You come.
Okay, nice case.
Thank you, sir.
What is the conclusion of your case? Do you want everybody to go from here and start salvaging all these cases?
No, sir. My idea is that flukes may not be always the fact. I was lucky. That's why I'm presenting.
I would just request you to see that it might be a fluke for yourself also.
Yeah.
So let's go according to the protocol.
True, sir. True, sir. I said, sir, Ganga hospital score was 18 and it was predicting amputation. But I tried my luck and I was lucky probably. Both me and patient were lucky.
Let us stop here, but one comment, there is a lot of confusion amongst the audience. That is, this presentation should be one study. And obviously, there should have any protocol, one protocol. But this could have been presented like the case series. There no problem. But in that case, a lot of statistical involvement is not there. But he has not done it. He has not mentioned the protocol. There should not have been. This is not fit for a competitive sessions.
Thank you, Dr. Argho Saha. Our next presenter, Dr. Shubhradeep Barai. Please come on the stage. Good morning, everyone. I am Dr. Shubhradeep Barai, junior resident of NRS Medical College. According to SARC data, there is incidence of around 15 to 20 cases per million per year in India of traumatic spinal cord injury. Most of the cases occur because of the fall from height or road traffic accident. Among all the cases, most commonly occur is the thoracolumbar fractures, which consists of about 2/3 of all the cases. Among all the cases, the most common mechanism of injury is flexion distraction type of injuries, which most commonest following the compression and burst fractures, mostly occurs because of the high velocity injuries at the thoracolumbar junction
mostly unstable fractures, prone for neurological deficit, and they can be associated with intra-abdominal injuries. Patient most commonly present with severe back pain, maybe or may not be with neurodeficit. But if neglected, they can lead to late kyphosis and neurodeficit as well. So our goal is to prevent the neurological deterioration in unstable thoracolumbar injury, to prevent provide immediate spinal stability, prevent spinal deformity, as well as early mobilization of the patient. We have evaluated the patient radiologically, clinically, and functionally, and assessed by different scoring systems like ASIA scoring, VAS scoring, ODI scoring, and measure the Cobb's angle as well. We have classified the total all trauma according to the thoracolumbar injury classification and severity scoring system. And we have found that if the score is 5 or more than 5, then there is every indication for going for operation. But whether to go for open surgery or a minimally invasive surgery, there are some disadvantage regarding the open surgery. Like they have a greater risk of intraoperative blood loss in trauma patient, higher risk of infection, as well as there is strong likelihood of an associated systemic injuries. So we can say that minimally invasive surgery can be an effective and a viable option. But we have to keep in mind, for the success of the surgery, there should not be any neurodeficit in patients, no associated comorbidities. Ideally, the patient should be young and active individual with suitable bone healing potential, and the trauma should be of descent within 2 weeks. There should not be severe ligamentous instability or kyphotic deformity or unstable burst type of fractures. So basically, there should not be any indication for open decompression. If you see the X-rays, there is the interspinous distance has been increased in AP view. If you see the sagittal view, there is the anterior, middle, and posterior, all columns have been involved, which can be corroborated in the MRI finding. Here also, you can see the anterior middle column has been involved. The star view shows that there is a hyperintensity signal, which suggested that there is a posterior ligamentous complex injury present, which can be corroborated with the coronal cut, where you can see there is a hyperintensity signal present. The axial cut shows that there is a neural compression has been present here. CT scan have been done and for better evaluation of the anatomy, and you can see there is an abnormal widening of the spinous process, which has been seen in the X-ray as well. We have performed the surgery by Jamshid needle insertion, then K-wire insertion, followed by dilatation serially, tapping and screw fixation, lastly introduction of the rod. Now, if you compare with the post-op, there's interspinous distance has been restored. The segmental kyphosis has been corrected, which can be corroborated with the CT scan finding, which can be better evaluated here. There is no proximal joint violation, which is very important for ruling out the adjacent segment degeneration. We have tried to use the bilateral pedicle screw, but if not possible, at least one-sided pedicle screw has been inserted in the index level, and that is also of optimum size. In the post-op 12-month MRI shows that there is the absence of the hyperintensity signal, which suggests that the PLC injury has been healed. And in the axial cut, you can see the canal remodeling has been occurred beautifully. We have performed the rehabilitation protocol by starting the patient with limb exercise and trunk exercise at the end of the 12 hours. No bracing has been applied to the patient. Sitting has been done by the very next day. Indoor walking started as early as possible within 3 days. Outdoor activities within 1 month. Public transport use by 6 weeks, and forward bending and squatting by after 3 months. We have assessed the patient functionally and seen that the moderate disability of the patient has become now the minimal disability according to the Osweiser Disability Index. So you can say there are some advantages of this procedure, like it has a less blood loss, less operative time, less use of post-operative analgesics, faster rehabilitation, and less morbidity, and cosmetically very good. But the disadvantages are the technical is much more demanding, high radiation exposure, ultra-rich instrumentation is required, and cost is always an issue. So my take-home message is, if there is a flexion distraction injuries with disrupted PLC but without any neurodeficit, can be effectively treated by minimally invasive surgery, which restores the adequate stability and sufficient neural decompression. So patient selection is always an utmost important, can produce excellent clinical, radiological, and functional outcome when properly applied. Further progress is also evolving regarding this regard. Thank you all.
So
Am I allowed? My question is, you have showed most of the cases, 1 level up and 1 level down fixation. So how did you address the anterior column deficit? Because anterior column deficit is present in all of your cases.
Sir, our goal is to show here that if there is not much more bony involvement, bony comminution, then only with posterior fixation by minimal invasive, it can be addressed without any anterior
In
fixation.
your case, most of the cases has bony involvement, anterior column involvement. There was more than, it was actually an unstable pars fracture. You showed it is a stable pars fracture. You are doing in a stable pars fractures, but pictures show most of the cases are unstable pars fractures.
Sir,
You go back your slide.
I have also the same question, the 3-column involvement. The stability is at doubt, and it's very difficult to stabilize it with only short segment fixation.
Sir, the reduction has been achieved by ligamentotaxis here and by patient positioning pronely. So by there is anterior stretching of the anterior column by which the retropulsion of the fragment has been reduced.
Did you have the long follow-up and long follow-up?
Yes, sir. 12-month follow-up present.
12 months follow-up. So
Yes, sir.
what was the?
So there is no sir further complication or no further compression has been present and without any neurological deficit in post-op period.
If this type of fixation only one above, one below, no brace, it is not good.
No,
Then
sir.
you have to brace them.
No, sir. Sometimes we have used the 2 level up, 2 level below according to the bony.
Next day he can walk around, but just one up, one down and allowed walking without any brace. I don't think long term will be good. It will go into kyphosis. Chinmay?
Yes, absolutely.
One up, one.
One up, one level is, if you plan to fix it one level up and one level below, then you have to support anterior column either by cage or something else.
Even the long brace, at least 6 weeks brace. 2 column up, 2 down, immediate walking. But 1 up, 1 down, no immediate walking. Without brace.
Thank you, Shubhradeep Badoi. Please collect your certificate. With this, we came to end of the session of Siliguri best paper. Thank you all presenters.
Those who were not of which Subodhi is there? Subodhi both time. But he is not there. Sorikul Rahman. Is he there? Then Somik Doctor.
Shaunak Datta is here.
There, yes. And
Can I start, sir? Good morning, everyone. Myself Shaunak Datta from Medical College, going to present my paper, Functional Outcome of Double Barrel Fibula Reconstruction in a Case of Aneurysmal Bone Cyst of Distal Femur, a case report. A 19-year-old male patient presented with painless bony swelling over the distal part of the thigh for the last 3 years. No history of trauma or constitutional symptoms was present. No neurovascular deficit was present. On clinical examination, patient was found to be in good systemic general condition with normal systemic examination. A diffuse swelling over the distal aspect of the left femur noted. Knee joint movement was painful with restricted terminal flexion and extension. Non-fluctuant bony swelling with no signs of inflammation and no neurovascular deficit was present. The X-ray showing expansine osteolytic bony lesion with intact cortex. MRI shows multiple fluid level with loculated bony cyst. And transverse cut of MRI section shows no intact neurovascular bundle. The Jamseti needle biopsy was performed and diagnosis was confirmed to be a aneurysmal bone cyst. After various treatment modality have been discussed with the patient relative like curettage bone grafting, curettage with bone grafting by vascularized or non-vascularized fibula graft,
iliac bone graft, iliac crest bone grafting, and other or bone cement. After discussing with all the pros and cons with the party, we tried to reconstruct the void with double barrel fibula reconstruction with the tricortical bone graft. So this was our plan to fill up the void with the double barrel fibula with dead space to be filled up by the iliac crest and supported by a distal femoral locking plate. So then lateral approach was used by biopsy scarred ellipsed out. A round window over the lateral side was created for the curettage. This picture is showing the post curettage bony defect and the curettage material. Adjuvant therapy with the hydrogen peroxide after the curettage was done. Maximum length of the fibula was taken, keeping the 5 centimeter proximal and distal end of fibula. And maximum extent of tricortical bone graft was taken. Then we construct the double barrel fibula reconstruction, and the space was filled up by the tricortical bone grafting. And this is an intraoperative picture. Double barrel fibula reconstruction with tricortical bone graft supported by distal femoral locking plate. This is the resultant bony defect. This is the preoperative and postoperative X-ray. This is our plan, and this is our end result. The patient was given static and dynamic quadriceps exercise from the postoperative day 1, and partial toe touch weight bearing with couch walking was continued for the 12 weeks. Full weight bearing given after the 3 months of surgery. Patient was followed up regularly in our OPD at Medical College, Kolkata for 2 weeks, 6 weeks, 3 months, 6 months, and 9 months. This is the X-ray of at the 3 months of follow-up. This is the X-ray at 6 months of follow-up showing signs of union. This is a video of the patient that walking nicely, no deficit what's there. That is the picture showing. That is a picture showing healthy scar with a good range of functional motion. And in this type of case, we could use intercalary prosthesis or allogenic bone graft or vascularized fibular grafting. But in case of intercalary prosthesis, this was not available in our setup and it is very costly. So we couldn't use that. Allogenic bone graft was not present as there is no support of bone bank, and fibular graft, vascularized fibular graft takes a microvascular expertization and long-term operation time. So we could not do that. This double barrel fibular reconstruction with non-vascularized bone graft can provide a single stage solution for the autologous bony replacement for a large or complex bone defect, less time consuming, less cost effective, less donor side complication, good union rate with better functional outcome. So my take home message is biological reconstruction by double barrel fibula with tricortical bone grafting in benign tumor of femur provides good union rate with less complication. Thank you.
How many cases you have?
Sir, only one.
So this is a case report. This is case report. This should not be in such the platform. Anyway, now the paper is open to discuss. Actually, on this particular method, a lot of articles are there which are on vascularized fibular graft. But he is doing the non-vascularized fibular graft. So some issues are of course there. That is long-term follow-up because the non-vascularized fibular bone graft is supposed to be subjected to refracture. So these are the issues are there. So there are now the questions from the audience.
So two things. Fibula usually takes longer time. Do you think it has taken up sufficient? Follow-up is sufficient to tell?
Sir, no, sir. It's
number one. So number one. Number two, you have mentioned options What about polydoctal? You have but not mentioned for ABC polydoctal injection, which could have been used. What's your opinion about that also? And third thing, fibula, we have excised a long segment with only less than 6 centimeters left there. Screw strap fixation could have been better option. These are the things. Okay.
Sir, sclerotherapy is a good option for the patient who are younger age group, because there is a challenge of there is a chance of pathological fracture with the sclerotherapy with the polydoconal, and we have just a 6-month follow-up, so the patient is following up. So at the time of 6-month follow-up, the patient is showing a good union, but it's not yet completely united. It's not completely remodeled.
Why are you giving so early weight bearing? Double fibula has such a huge gap. After 3 months, you are giving weight bearing.
I have a question.
Fracture, no?
That is the true valid point. Kunal raised that 2 months is 3 months is too early. Can you show the 3 months follow-up? X-ray. 3 month follow-up X-ray.
This is. Acha sir.
This do you consider it a union or callus formation, or it's some sort of recurrence occurring there? Do you have got any post-operative pathology histological report you have not shown here?
Sir, I said biopsy was taken.
No,
And
when you take out the tumor, do you send for the histopathological examination?
no, sir.
No, why not?
Your blade should have been much longer. It should be another 3 or 4 holes proximal.
Okay.
It has been very short liver arm. It will fail.
Absolutely true, you are. And one more thing is the oncologist, oncosurgeons used to use the combination of the that is the after curators, combination of the adjuvant, conjugate. So you are only using the hydrogen peroxide. This is totally inadequate. But the issue is, one is to prevent recurrence, number one. Number two is reconstruction of the bone. You are pressing on, or you are emphasizing on the stability of the bone, but the biological part of recurrence, that is not properly addressed. So you should take care of that, and you make the series, and then you present in the next time. Okay, thank you.
Okay, sir. Thank you, sir.
And because we have finished our session. Yes. So
We request all the speakers to present, to come to the stage.
Some more? We are also included. Yes.
So, let's work on that now and male and apart. If you have any question or doubt, you can ask. Anybody from audience?
Sir, any question, additional question to Gustav? Any
If
additional
there is
question?
any question, you can ask Dr. Kaustav Mukherjee. His presentation.
Leave that. Anyway, now, let me say a few words on. So as I have already mentioned, that in any national or international or state level conferences, your work should be number one, your work should be original one, and it should not, it should be presented before your publications. And the best article probably here, what we noticed is cannot be considered for the prize because that is already published. So that should not be considered here. And the second thing is regarding the rules. We are unfortunate that few more articles were there, but we cannot accommodate them because of their age. This should be addressed by the committee also. Beforehand, their consent should be maybe taken, whether they are presenting or not. And the name of the guides need not be mentioned also because we consider that this is your article, but in the acknowledgement sections you can mention that you are acknowledging your the guide or whatever is the is called guide, who is guiding you in conducting that particular work. Okay, with thanks to all.
I have got something to say on whatever is here. I mean, Pratyush. Amar কথা হচ্ছে, yes, whatever you said, mostly right. But there has been some faults on the part of the committee which had accepted them with their abstract. They have presented the abstracts. And so, but these points need to be discussed, not in public, but in the executive committee.
That's why
They will fix up a stricter criteria for selection. Thank you.
We are identified.
So we are just before time. So we'll about to start our prestigious orations. We have 4 orations back to back. But a small announcement because Dr. D.K. Sinha has to leave because of his family emergency. So we are skipping this D.K. Sinha sir's oration, the K.S. Bose oration. In that place, we yesterday had a fantastic 5 live surgeries. These live surgery cases will be discussed in that time slot. After this A.K. Shah oration. Okay. After the all the orations and the past president's lecture, we will utilize that time, half an hour. So first, I would like to, for the A.K. Shah Memorial Oration, I like to invite our Honorable President, Dr. Chandan Pathak, sir, and Honorable Secretary, Dr. Rajiv Raman, in the dais.
Good morning. Now is the time for prestigious Professor A.K. Shah Memorial Oration, and that is the possibly most prestigious oration of West Bengal Orthopedic Association conference. And for this year, we are lucky to have Dr. Javahir Pachure from Ahmedabad amongst us, and I'd like to invite Dr. Pachure to come up on the dais. And Dr. Mr. Please escort, sir. ওদিকে Dr. Jawahir Pachure, he is a director of hip surgery in Shalby Hospital, Ahmedabad. He was trained by Dr. K.T. Dholakia, and he worked with him at Bombay Hospital for more than 2 decades in various capacities. He had more than 35 publications and numerous presentations and contributions in different book chapters. And he has been faculty members for various national and international organizations and more than 205 presentations, symposiums, case presentations in various conferences. He has given orations, as you can see, in many prestigious, he has orations under his belt, including Dr. K.T. Dholakia Memorial Orations. He has Lifetime Achievement Award as Surgeon received in 2016 by alumni of Science City Institutes. He has numerous social awards under his belt. He is a member of various national and international organizations like American Hip Knee Associations and British Hip Society, and is a founder president and managing trustee of Indian Society of Hip Knee Surgeons, ISHC, and is architect of Indian Joint Registry, and that is still going on. And he is a DNB teacher at Shalby Hospital at Ahmedabad. And many of us, many of you possibly do not know that in arthroplasty world in India, he is commonly termed as Pitamaha Bhishma. So whenever you have any doubt, particularly about hip, so he's a ready reference for that solution. So it's my proud privilege, and from WBOA, we are privileged to have him. In spite of his health issues, he has consented to deliver prestigious Professor A.K. Shah Memorial Oration today.
No. All right. I'd like to thank the West Bengal Orthopedic Association for inviting me for prestigious oration. I'm especially thankful to the president and secretary. It will be my talk on ankylosing spondylitis. Yes, yes. It is there, sir, in the presentation. It is there. It is there, sir. Okay. Regarding many youngster probably in this crowd may not know Dr. A.K. Shah. This is a man with the idea of fixing the purpose. And he had his medical degree in R.J. Kar Medical College in Calcutta. He joined British Army during the Second World War as a surgical specialist. He did a fellowship in Royal College of Surgeons of London and acquired MCH in 1948. So many people in this crowd may not know. There were 5 giant surgeons of the country were in 1948 batch. And Dr. A.K. Shah was one of them. Dr. K.T. Dholakia, Dr. Duraswamy, probably many people will not know Duraswamy. He joined AIMS and he was a great researcher. And Dr. Mukhopadhyay. And there was one general colonel, I forgot his name. These are the 5 giants who did the MCH in 1948. And his thesis was very much appreciated during that time. So look at that time only he had an interest in the shoulder. After coming back, he joined again the college and he was the professor at head department from 1955 to 1963. And he had a great interest in a shoulder and also post-polio surgeries and spinal surgeries. I think that this is most important is the work and his honors were the Hunterian professor lecture, which is a very rare for any Indian to have this lecture. And he was one of them. And he published the article on Giro, that is in 1983. It was in clinical orthopedics. And that's regarding A.K. Shah. And we must respect his contribution to orthopedics. So my talk is going to be ankylosing spondylitis, very young disabled people, and how we can improve their life, how they can improve their life. And we must recognize our forefathers. And this is what the basics were done by Mary Strimble disease. That is the time it was recognized, and the foundation was built up on this by many of us. This is a spondyloarthropathy, axial involvement. Once the peripheral joints involved, there are only 20 to 25%. And if there is a hip is involved, almost 50 to 90% are usually bilateral affection. What about the the hematological markers are ESR and CRP is increased only 75%, 25% is not there. And that's why the diagnosis becomes difficult in early stage. Alkaline phosphatase, creatine kinase has a very poor markers. HLA is definitely a great marker. And there are now 11 subtypes. And now today, the data from our own country, HL is positive in 87% in South India and 94% in North India. That is the difference between the two parts. This is something new coming up as a mean platelet volume under the investigation. It is always low in ankylosing and RA, still it is not proved. The hallmark of the disease, all of us know that the sacroiliac is the hallmark of the disease. And it starts with a fuzziness, narrowing the space, and finally gets a fusion. Unless it is a fused sacroiliac, we just cannot label as ankylosing spondylitis. On the spinal side, it starts with erosions, squaring of the vertebra, periosteal, and finally it lands with a bamboo spine, which is one of the very, very disabling condition. The many of orthopedic surgeons, they miss what is called enthesiopathies. They are always starts with a very early phase. And we must pick up at that point, like an erosion of the ligaments, especially ischial tuberosity and greater trochanter. Iliac crest is not very common. What about the hip radiology? This is what we published under Dr. Dholakia and Saraf and myself. This is the first time we have published that these are the 3 types. One of the type will be a chondrolytic, that is a reduction in the joint space, concentric reduction, looks like rheumatoid. And second is a bony fusion, and third is a protrusio. And chondrolytic is the most common variety, is almost 65 to 70%. Sometimes we do see these lesions, Anderson lesion, and all orthopedic surgeons should know that patient who had a bamboo spine suddenly comes with a pain in your cleaning in the back, which should not happen. And you must suspect something like an Anderson lesion. Many times, most of the orthopedic surgeons have treated like an infective, like tubercle, because in India.
So they are not tubercle spine, they are Anderson lesions, and you must fix them. The short fixation does not work. It requires long fixation. This is one of our own patient. What is the prevalence in this country? It is a prevalence is 0.25 to 1%, roughly 1%. And to a surprise, this is alarming increase in the incidence of ankylosing in very young adults in India. So I think we have to look into this matter. So there is always delay in diagnosis because chronic back pain is very common, and there is a delay in diagnosis almost 8 to 11 years. That's the reason most of the time patients do not come early for diagnosis. And if there is a disease under the age of 15 years, the 15% patient will need THR. And if the disease is after 20 years, only 1% they need THR. This is again a data. What about, this is another thing which we really miss, the medical comorbidity. Most of the orthopedic surgeons will not have an idea. These patients are not a very straightforward. They have anterior uveitis, very common, inflammatory bowel disease. 10% patients have psoriatic arthritis. Please expose them and see the skin lesions. And if you operate them through these lesions, they are in problem of infection. Aortic insufficiency, 3rd-degree heart block, and pulmonary function, as all of us know that there's a reduced pulmonary function. So look at the patient in general, very, very important. This is one such patient landed in my clinic. And this was when I exposed him, it's look at the skin lesion, that psoriatic lesions. Unless they heal, you can't operate this patient. So 10% patients have psoriatic lesion. Please take care of this. What about the treatment? No definite cure, because my boss, Dr. Dholakia, used to always tell me the rheumatoid patient, they will burn out. And ankylosing will never burn out. They will die with minor degree of pain, some minor degree of pain. And this is quite true. DMRD has a good effect on peripheral joint, but poor on spinal. If spinal, they do not have good effect. What about the new drugs, biological drugs? I think there is a good hope that, and because the anti-TNF alpha has really worked on these patients, their pain relief is much better, bone density increases, quite a bit of patients have good functional outcome with this biological drugs. The indications for a total hip replacement, there are two groups. One is non-ankylosed, like arthritic, like chondrolytic variety, where straightforward like other type of arthritis, they are indicated the same way. But ankylosed variety, bony ankylosed, if they are in functional position, we don't want to do very aggressive work on this. But non-functional are the patients who need a total hip replacement. And some of the patient, young patients, they want mobility, and that's why they come for a total hip replacement. These are the difficult conditions. One is abducted, adducted, all varieties of difficult cases we have. And these are very young patients. So they need, even though there is a bony fusion, they have no pain, but they need because of the non-functional positioning. You can see the young boy, just 20-25. Look at the disability of that young boy who has a bony fusion of both hips and both knee, and that's a difficulty. And there's another middle-aged lady, she just could not walk straight. So she has to take a side support and walk. That's the type of disability these patients have. And you must, as a surgeon, you must have a supervised position of the patient, because these are very difficult do the position because the spinal deformity, because of the even a cervical spine, and you have to be very careful in this patient for positioning the patient. People have damaged cervical spine, people have had brachial plexus injuries, but be careful with these patients. Once you are given anesthesia, if the patient is chondrolytic and protrusive, you can see the amount of mobility, whether you will be able to dislocate or not. Even any bony fusion is there, please do not try any general anesthesia mobilization, because you may get a fracture subtrochanteric and you will be in trouble. Don't do that. This is another important message, to look at the lordotic spine, look at this lumbar spine is very important. If there's a lordosis of the spine, we need to increase anteversion. And if there's a kyphotic spine, we need to put the little bit of cup horizontal and less anteversion. And this we learned from AIMS, Dr. Suryaban and Dr. Rajesh Malhotra's paper, one of the benchmark paper, which I'll quote you later. What are the approaches? I think a surgeon should know the varieties of approach depending on the deformity, but we should have a good exposure. So our main is the posterior approach is a workhorse, but those patients with a marked external rotation deformity and flexion, we will try to do what is called dual approach, which is described by my colleague, Dr. Bhosle. Another important thing, when we expose the ankylosing, especially bony ankylosis, we have to take out a 1 centimeter of bone from the neck, and that is called napkin ring osteotomy, which avoids the fracture of the subtrochanteric area. So very important to take out a 1 centimeter of bone from the neck. The ankylosed hips are really challenged because the exposure is a challenge, and identification of acetabulum and placement of the cup is very challenging in this group of patients. Why? The bones are very soft because we feel this ankylosing, the bone should be very good. No, they're very soft bone because of the no stress areas, and difficulty in locating, chance of sciatic injury because of the deformity, and iatrogenic fracture, and damage to the posterior column is very, very important because during the reaming, your chances of posterior column damage is very, very high. Look at the lumbar, and when you place the acetabulum, I told you, depends on the lumbar lordosis or kyphotic. Look at the lumbar spine as a surgeon. Neck osteotomy, which I mentioned. Identification of transfer. In spite of ankylosed hips, you will be able to see the transverse ligament. Transverse ligament, this is a very, very important ligament, and which is described by Beverland from Ireland. And fat sign, my boss described this sign long back, which I'm going to show you in one of the video, that this pad of fat you have to see on the ankylosed hip. That's the most medial wall of the acetabulum, and do not dream beyond that. Another important thing is, if you are not able to getting identification, you put an inferior retractor, that is a caudal extent at the obturator level, and you can start reaming that. This is one of the another identification mark. Very rarely you will require to take the image inside. If you are in any doubt, take an image and see where you are. So don't get shy away from that. So this is another very important message for orthoplasty surgeons, that if the spinopelvic parameters we are looking for a spinopelvic parameter, and especially in a fused spine because the rate of dislocation is high. So one important message for all of us is, when the pelvis, when there is a lordosis, we need to, the acetabulum gets retroverted. So we need to increase the anteversion, and exactly opposite in a kyphotic spine, that we need to reduce the anteversion, otherwise the hip will dislocate anteriorly. This is one of the ankylosed hip. That's a neck cut, napkin ring. You take the gouge and take out a little bit of bone from the center of the head, because the small reamer cannot catch. So you have to take out a little bit of cortical bone, and then you start with the 36 reamer. So very, very gradually, and watch always from anterior and as well as posterior. So the damage, these are usually established, are not too big. So you will have to watch, put the finger on the posterior side, anterior side, and if a little bit damage anterior occur, doesn't matter, but the posterior should not get damaged. Otherwise you will have instability, and that hip is not going to do well in the long term. So that is another important thing of reaming. Gradually go on from 36 onward to every millimeter, and try to get the medial wall. If you do not get that pad fight sign too much, you can take a drill and measure the depth and find out at least 4 millimeters of the depth can be kept, and that is very important as far as the medial wall is concerned. And this is there are 2 or 3 types of fat you get. So sometimes you get only very, very little area. There's a fibrofatty area, but that's enough to get a medial wall identification. Sometimes you may get a very large area of the fat, which you see this on this video, and that will give an idea that this is the most medial wall, and stop reaming that. Don't go beyond that. That is one other important message for all of you. This is one such case of bony ankylosis. You can see a big fat of pad fat. Regarding the anteversion, the tal, I told you, that's the tal with a glistening structure inferiorly, and that once you see the tal, you can actually put your cup according to the direction of the tal, exactly parallel to that. So that is a normal anteversion of the cup. you will get a good stability in spite of this bony ankylosis. But I like to put at least a minimum 2 screws for these patients. Even though I get a primary stability on the table. Regarding the canal on the femoral side, there's nothing major, but one important thing is they are wide canal, that is door type C canal is a very, very common, more than 80% of the patients. And sometimes you might have to use a cemented option. So keep ready cemented option. Can you go back? Can you run that? Can you run that video? Yeah, okay. You look at the protrusive variety, you need to graft on the medial side. This is one such a very disabled patient. I was able to dislocate and just reaming like a normal reaming, only mouth reaming, don't go too much of medial wall, impact the morcellized graft, and you should be able to get the cup. And usually these wide canals that require a broader stem like a couple of stems, or you can use a fully coated stems. And that is the reaction. And then you can see after a couple of years, what is the result of this gentleman was. So acetabulum component is placed. We are putting a acetabulum component in a static position, but we do not know what happens in the dynamic position. And usually in dynamic position only it will dislocate. So we are trying to achieve what is called functional orientation of these cups. So in a fixed pelvic deformity and the spinal deformity, placing acetabulum falling in a Levenick zone also can lead to early dislocation. So when we have to be careful in this group of patients. So what about the post-operative protocol of these patients? Early mobilization, no passive stretching. Please do not send it to physiotherapists. They will do all sort of exercises for these patients. Role of indomethacin is excellent, 25 milligram twice a day for 6 weeks, and this will reduce the amount of ectopic ossification. Single dose radiation is only we give this patient, those who are contraindicated with a renal, those with a renal failure or those who have severe gastritis, we use the single dose of radiation. What this is radiation is, it's a single day radiation and it is called linear accelerator. We have to only do the capsule area. We cannot put this radiation on the implant, otherwise indoor do not take place. And it should be done within 48 hours of the surgery, and 350 from the front and 350 from behind, with only 700 at single dose. What are the complications? In general, the same complication like any other orthoplasty, like infection, DVT. But one is the important is the ectopic ossification and anterior dislocation in this group of kyphotic patients has been reported by Dr. Suryaban and Rajesh Malhotra. And we have learned, and not we have learned, the whole world has learned from this article. So this is one such patient operated by my colleague. One side he did a good job. Other side he had excessive anteversion and he started dislocating. And the anteversion was almost 60 degrees for 35 degrees on this side, 35 degrees on the femoral side. So almost 60 or 70 degrees of anteversion on the CT scan. So the surgeon went and tried to reduce the anteversion, but the cup, he put the cup vertical and he got dislocated. I have to revise both the components. So ectopic ossification is the one greater issue of as far as this is concerned. So how do you minimize a good handling of the tissue as a good surgeon? Avoid trochanteric osteotomy, use pulsatile lavage and indomethacin I just now told you, and avoid sending to the physiotherapist. And if you have to excise, you have to be extremely careful because you have to excise the your markers, hematological markers should come down, and you should have a bony trabeculae and bone scan should be negative. Then only you excise. Don't excise in immature because it will again have a recurrence. And another important message is do a CT scan to find out where the ectopic ossification is. So you can accordingly you can do the approach. And another thing is take an image intensifier inside after excision and see that you have taken out everything possible, and send the next day morning to the radiation department as a linear accelerator. What are the results of this ankylosing spondylitis are? This is a paper coming from Wrightington Institute, Atul Joshi's paper, and this is almost about 27-year follow-up. of all 75. The cups had a problem because they were using 22 millimeter and they had a high rate of loosening and the wear. The other uncemented paper, this was initial paper of 15 years follow-up, around 65% survival, but this was poly was not highly cross poly. Today we have much better probably results. This is Dr. Suryaban's paper, a benchmark in ankylosing spondylitis. What two important message we came out? The anterior dislocation because of the kyphotic spine, and second message came 38% patients had some discomfort of pain in spite of all total replacement. So we should always consider our patient that you will be all right as far as this concern. The gait is going to be a problem and some amount of pain will be there here and there, and they will have to have on analgesic or other drugs are. So that is one important thing which came out from this paper. What is our experience? I'm not talking about experience of Bombay Hospital. We had a huge experience, the largest area of the world. But I'm just talking when I moved to Shelby Hospital. This is my recent data from 2008 to 2020. I operated in this, we operated in this on 165 patients with 223 hips. Average age, look at this, very young patients. And radiologically, almost like the same what Dr. Dholaka described. 10% needed fiber optic. This is one important message to all of you. Your anesthetist must see this patient preoperatively because 10% of the patients are going to need fiber optic intubation, and it's very important. We have heard various stories in this country. The patients have died on the table. So average follow-up of these patients are 8.2 years, 2 years. And some of these patients are, this is young lady, IT engineer, has completely both fused hips and a completely bamboo spine. She was just look at that. She is going on the bed like a log of wood. And you can see the post-op. This lady, after a couple of years, the gait, they do not get normal because there is nothing compensatory at the lumbosacral junction. But they are really good. She can go up and down the stairs without any holding a banister or anything. And her parameters as the parameters of the X-rays on CT and everything was everything was perfect. I never seen this. This is a young boy who was just look at this, how he is able to get the shoes. Look at this adaptation of this. And this is what he had. And you look at the post-op, he was just absolutely not. So this is the type of disability they have. And I told you the gait is a little problem with ankylosing spondylitis, as this is seen this. This is a 10 years follow-up of one of the chondrolytic variety, straightforward, uncemented hips. This is something bony ankylosis, 14 years follow-up of no osteolysis or no implant failures or anything. And this is my very old X-rays. This is almost 24, 25 years. One of the Olympic hockey player, which I did in Bombay Hospital, but this is just to show you one of the longest follow-up of ankylosing. I did had as a surgeon, I did had on my own share of complication. I had one stem loosening, aseptic loosening, and this was sickle with ankylosing, which I just recently reported in the literature. I had one cup loosening. This was a sickle cell, and this was a stem which subside. I did had one dislocation with the protrusio variety. I had one periprosthetic fracture after 6 months, and I had very unusual lesion, which I sent for publication, alveolar lesion. The whole upper femur completely lost because of the either tendinosis or polywear. And I lost this patient. He had developed a chronic renal failure and he expired just about 1 year back. I had one patient, TB, after 6 months, I aspirated and got a culture, and it was a tubercle, and he was only treated with anticox and he healed up beautifully. So in conclusion, these are medical comorbidities are very high. Preoperative assessment of anesthetics must be done. Posterior approach is the preferred approach for this bony ankylosis. Napkin ring osteotomy and look for pad fat sign. Femoral canals are wide. Keep an option of cemented option available with you. Trial reduction is very vital. A lordotic spine, keep more anteversion and normal inclination. And for kyphotic spine, anteversion should be reduced and keep slightly horizontal cup. prophylaxis for ectopic ossification, either indomethacin or radiation, depends on the choice. If the technical considerations are taken into account, one can achieve very gratifying result as these patients are concerned. I like to request West Bengal Orthopedic Association and orthoplasty surgeons, please join joint replacement surgery. We should be able to produce difficult work of such a nature unless we have enough data from across the country. And this is now we are handed over to independent body which is managing the UK registry. So I request all the orthoplasty surgeon and orthopedic surgeon to join IJR. I can't do this type of work without a team. I'm very thankful to my team at Shalby Hospital. Special thanks to Dr. Vikram, who allowed me to do all the activities of this. Thank you for attention.
Now I'd like to invite you, sir, over the center of the stage. President, sir, Chandan Patak, sir, and Dr. J. Pachori, sir. So this is to certify that West Bengal Orthopedic Association, as a mark of reverse, confers the citation to Dr. Javaharanand Pachore for delivering the prestigious Professor A.K. Saha Memorial Oration 2023 during WBOACON 2023 held at BM Grand Hotel, Malda. This oration is given in honor of Professor A.K. Saha, who was the pioneer of modern orthopedic surgery in India. His contribution in the field of orthopedics has revolutionized the management of complex shoulder problems, both nationally and internationally.
Now we are proceeding to the next oration. That is Dr. Shailendranath Bhattacharya Memorial Oration. For this memorial oration, I like to invite our President-elect Dr. Debapi Roy and our Vice President Dr. Kiran Kumar Mukhopadhyay to conduct this session.
Good morning for the prestigious Dr. Shailendranath Bhattacharya oration. Speaker Dr. Naveen Thakkar is the past president of the Gujarat Orthopedic Association and the Secretary General of Indian Orthopedic Association. Worked hard for IOA website development, transparent online elections and free bone and joint surgery. Special award given at IOCON Kochi 2016 for dedicated IOA activities. IOA activities and academic awards, gold medals in innovations of Dr. Naveen Thakkar. Shushruth Award, IOCON 2006, Delhi. IIM Ahmedabad Innovation Gold Medal, Inventors of India Meet 2006 at Indian Institute of Management, Ahmedabad. KT Dholakia Gold Medal, IOCON 2007, Kolkata. SP Mandal Rational Orthopedic Gold Medal Award, IOCON 2008, Bangalore. Gold Medal NailsCon 2012, Udaipur. Silver Jubilee Oration Award, IOCON 2012. IOA Conference Oration, Kochi, IOCON 2016. Presidential Appreciation Award for dedicated IOA activities, IOCON 2016, Kochi. Incubate Center for the Innovation and Incubation, IIM Ahmedabad. And the first Indian orthopedic surgeon who got 2 US patents and many more awards. So this presentation will be online And play the.
Respected Chairman and all the members of WBO Orthopedic Association. I must thank you all for allowing me to present here Dr. S. Bhattacharya Memorial Lecture. We know him. He was a pioneer in arthroplasty and everything in the eastern region. He was just like an institute. And he developed the institute. You can see here the beautiful pictures of his institute here. And he was very much great in record keeping, great academician, always updated. You can see here, presenting here in the Malda, very argumentative. And the fans also galore about him. And he has an unending enthusiasm at the age of 92 also. We have lost him, but he was productive till the end. The physics fades, but the soul and the vision, did he really die? No, he is with us. His vision and his work is still live with us. And we admire him. So I'm starting this lecture. We'll be learning together. I'm presenting it with one case. Male 52, operated in 2016 by this ender's nail and it has failed. Obviously, the surgeon chose a plating and a bone grafting, but the patient had a complaint of cold feeling, heaviness and tingling and numbness off and on. So then he went to the same surgeon and he tried to remove this plate, but failed due to cold welding. You can see here, there is an anterolateral approach has been taken by the surgeon. Right? He could not remove it. Now, patient went to the second surgeon and he also tried to remove, but he could not remove the, and it has failed. What will you do? Imagine yourself that you are the surgeon as a second surgeon and you could not remove it. But what is happening further, it is to be understood that he explained to the patient that it is not removable and further try of removal may damage. The patient was shifted to the room. What is the next? Just imagine yourself. You are a third orthopedic surgeon. What will you do? Everybody say here that the proper instrumentation for removal of implant has to be kept very well. But let us see what is happening. Story continues. Patient complained of the pain and deformity after 3 hours of shifting to the room. And now you can see there is one added extra problem of peri-implant fracture at the end of the plate. So moral of the story is, the first message is, removal of implant is not to be taken as very easily. And you must be prepared for everything. And you must not try till there is a possibility of the damage. So now what will you do at this juncture? What is the option? In one of the place, many people suggested to remove the plate by hollow mill. But then the using the hollow mill here will not keep any bone here. Someone suggested to have Eliza row, someone suggested all different things. But what we did and what I learned from a technique, We use the flexible nail to get it reduced, and we use the anterior breech plate, MIPO. You can see a small incision here. And it was a minimally invasive small incision here. This is the previous scar of the surgery. This is the follow-up. Anterior breech plate with the flex nail is uniting. And you can see it's a follow-up with the flex nail and it's united. And it has given a very good function. So, my subject today is the scientific paper, technique or a case or idea or innovation which change my practice may change your practice. This is exactly the theme we have kept for the CME to be conducted by Gujarat Orthopedic Association at Lucknow WBOACON 2023. And we invite from you all any idea, any technique or a case from a scientific paper you learned and it has changed your practice. So present your innovation. What is the technique if you choose to operate? In these situations, open reduction, interfixation, pleating, posterior pleating, antegrade interlock nailing, antegrade retrograde and Ender's nails or the flexible nails. But what is the problem? Why we are searching for different options in this area? The first problem is the radial nerve injury. And the literature, if you see this Bayesian network meta-analysis of 3 different surgical procedures of treatment of humeral shaft. Rate of the radial nerve, non-union soft tissue, vascularity in the middle of the shaft. These are the problems discussed in the literature. And I came across this minimally invasive plate osteosynthesis. This is the paper or a technique where it is described whether it is possible. The first was the cadaveric study. And then the study of danger zone of locking screw placement in minimally invasive plate osteosynthesis of humeral shaft fracture. And this new technique is developed and used with 2 incisions and the minimally invasive plate osteosynthesis. Here is the case. Extended indication of lower third. And you can do with this very well here without any problem. Another problem is it's keeping it reduced. That is the problem. The literature says either you use the external fixator or use the locking sleeve to hold the plate, to hold the reduction. Another case, male 52, polytrauma. What are the expected problems? How to maintain the reduction? How to maintain the stability? Does it require augmentation? This is again an extended indication. So in this indication, we used a value addition of flexible nails introduced from the lateral condyle of the humerus with a small, very small incision. You can see here in this clinical picture, there is a small incision here and there is an entry of the flexible nails and that keep it reduced and it gives augmentation of the fixation in such an extended indication. And you can see this is the follow-up. And here the patient is very much happy. So this is the value addition which we are doing with this paper. And another example, elbow dislocation with the lower third fracture. Again the same technique. And it has given a very good, beautiful clinical result. Mid-shaft fracture. Difficult to keep it reduced. It changes. Again, 2 flexible nails you can see from the lateral condyle here. And beautiful fixation. And this is the result. We are not disturbing the rotated cuff at all. Here, you can see we are not disturbing it. And that is giving a very good function, as we are not disturbing any soft tissue and it is minimally invasive. Another example, extended indication. You must have at least area to have 2 screws here. That you have to take care. And then the flexible nail and the plate, and again that is also giving a good function. Small 2 incisions. But the second problem came when we had a series how to remove safely. This is the typical problem. There is going to be a soft tissue adhesion here, and it will become the maximally invasive plate removal, blunt and blind. Or you have to choose seen and sharp, open. You have to open up everything for the removal. So, how to solve this problem? Difficult removal. Let us go back to the basics. What we have developing, and we have developed and undertaken a special MIPO plate where you can see the middle part is smooth. There is no entrapment of the soft tissue here. And there is a long oblong hole and one low oblong hole lower down. Here you can direct the screw lower down and can have a more span of the plate. This is under biomechanical testing. So, friends, there is a study of effect of different surgical technique on mid-shaft humeral shaft vascularity, open reduction in internal fixation versus the minimally invasive plate osteosynthesis. You can see how the vascularity is affected. And there is a very good meta-analysis, which I described initially. The conclusion is the current evidence indicates that the MIPO is the optimum choice in the treatment of humeral shaft fracture, and that open reduction in plate osteosynthesis is superior to intramedullary nail. They have compared all 3 in a meta-analysis. So surgeon has to make a balance of reduced risk of the plate failure and the optimum interfragmentary movement to get the callus earlier. So we have to learn from the lecture. Bamboos, you can see, they are flexible, but still they are stable. So the challenge is to remain stable and at the same time remain flexible. So again, this is the paper. We change my practice. It may change your practice also. I have a small appeal. There is a gap between the WBOA membership and the IO membership from the WBOA. So please become the member of Indian Orthopedic Association. And now it is totally online on the website. Just click the join us. Thank you for contributing and sharing in IOCON 2022 at Amritsar and the CME with the full house. Again, we are inviting you with this theme which I am talking now, is the innovation technique paper which changed my practice, may change your practice, and it will be also conducted by Gujarat Orthopedic Association. With the folded hands, we invite you for 2023 at Lucknow. Thank you very much again, and I bow down to you and the legend, Dr. Shailendra Bhattacharya sir. Thank you very much. Thank you very much.
Wonderful speech. On behalf of West Bengal Orthopedic Association, as a mark of reference, I confers this citation to Dr. Naveen Thakkar for delivering the prestigious Dr. Shailendra Bhattacharya Memorial Lecture 2023 during WBOACON 2023 held at BM Grand Hotel, Malda. The oration is given in honor of Dr. Shailendra Bhattacharya, who was the pioneer of modern orthopedic surgery in India. Thank you again, Dr. Naveen Thakkar, and all the audience.
Thank you, sir. Thank you. Thank you, sir. Thank you.
Now we are moving to the next oration. That is Dr. Santosh Datta Memorial Oration Lecture. To chair this prestigious oration, I like to invite our past president, Dr. Golok Bihari Majhi, and Dr. Horipada Giri to come in the dais. I like to invite Dr. Vivek Trika to come in the dais to escort Dr. I request Dr. Kunal Sengupta sir to escort Dr. Vivek Trika to the dais. পিপিটিটা কোথায় আছে বিবেক ত্রিকা কোনটা আছে কোথায় আছে
Good morning to everybody, particularly Dr. Tirke, who is today here, coming from a long distance to give a important lecture in WBA 2023. And my colleagues, seniors and juniors who are present there, probably I am the senior most here. And with due regards and respect to all, I am asking Dr. Vivek Tirka to deliver his speeches on this auspicious occasion. First, I am just reading his profile. Dr. Professor Vivek Tirka, MBBS, AIIMS, MS, AIMS, FACS, FRCS Glasgow, FIM, SA, FICS, MAMS. Professor JP NSC TC AIA MS New Delhi. Medical training and more than 25 years experience from AIMS New Delhi. Regional and national faculty at AO, CCOT and APOA. Courses on orthopedic trauma. Prestigious Balu Shankaran IO Research Oration in IOCON Kolkata 2019. Patient from peripheral limb immobilization devices technology transferred to Government of India. More than 500 talks in various conferences and courses. Ex-AO Trauma India research officer. Over 150 PubMed indexed publications, academic cell in charge of IOA and vice president of North Zone IOA DOA 2022-23. Special interest in pelvic surgery, complex intra-articular fractures, skeletal infection, trauma basics research and trauma education. With this short introduction, I shall like to call Dr. Professor Vivek Tirka to deliver his speeches.
Good morning, everybody, and thank you, Chairperson, sirs, the organizers of West Bengal Orthopedic Conference in Malda, and my good friend, Dr. Rajiv Raman, for giving me this opportunity and this prestigious oration in front of the august audience who is sitting here. I start by saying that what we are doing right now is by standing on the shoulders of the giants who preceded us. And that was spoken by none other than Isaac Newton. One of such giants for whom the memorial lecture I have been honored to be presenting is Dr. Santosh Kumar Datta, who was a son of late Dr. N.C. Datta, born in March 1933 in Birbhum district near Tarapet. He passed his intermediate from Bishnupur High School and joined Behrampur Krishnath College, SKN College, which is popularly known as. He passed his ISC from that college and then joined NRS Medical College as a student of medical sciences. Passed his MBBS in 1957, but before that, he had become associated with the legendary Professor A.K. Saha, whose memorial oration we just heard from Professor Pachore sir, and his work on zero position of the shoulder, which Professor Saha had done. He was also associated with him. Later, he passed his MS in general surgery and then MS in orthopedic surgery as well. And he devoted and achieved his academic qualifications and professional degrees with a lot of determination. In 1998, he went to SICOT Congress in Tokyo for delivering his lecture on total shoulder prosthesis, which he had developed with Professor Saha. He developed many special skills for polio surgeries, indigenous way, what is the innovation and what is the demand of all of us, and used to be the first in the Indian scenario. He also invented the famous NRS splint for the treatment of lower third of fracture humerus and non-unions of the shaft of humerus. He invented the treatment for non-union of shaft humerus fractures with indigenous Datta's compression humerus nail in 94. Besides his professional excellence, he was also a genius sitar artist, and his drawings, for which he was known, can still be found in Campbell's Operation Orthopedics. He had also authored 2 books on biomechanics and elementary and applied orthopedics. And with his work on the shoulder, I felt that it was apt that I should be speaking on the management of proximal humerus fractures in the present scenario. The learning objectives are to understand the fracture morphology of complex humerus fractures, how we reduce them and plate them right now, and how the youngsters out here should be able to achieve good outcomes with the complex fractures. First of all, let's understand what's and how the good outcomes in proximal humerus fracture can be achieved by learning and understanding the personality of the fracture. Try always in emergency to get 2 X-rays, both AP and lateral. Sometimes it may not be easy to do that, but you need to always try for 2 views. The reason for that is this X-ray. Looks like normal, but as soon as you get that, it's a fracture dislocation, which normally many a times gets missed. A simple 2 views X-rays can give you much good results. If you cannot get it, the CT scans will help you and show you what exactly you are dealing with, which might be a fracture dislocation of humerus. Once you know the diagnosis, it's easy to reduce. We know orthopedic surgeons know how to reduce a fracture and fix it to the best of our abilities and get good results. But remember, the point is the 2 views are important. Again, another X-ray, similar X-ray. And remember why we miss these X-rays, the youngsters, please, is because we put most of the patients on an arm chest sort of a bandage, which keeps the head in internal rotation. And the posterior dislocations are exaggerated internal rotation of the humerus. Both the X-rays look very similar. You just a subtle finding of a bulb sign which can be there. Unless you get a lateral view or an oblique view, you will miss out on these dislocations, which are posterior fracture dislocations. The normal X-ray which you have in an arm chest also looks like this. The only thing is a subtle, more exaggerated internal rotation. And once you have this, you can follow the joystick maneuvers, reduce it, fix it to the best of ability to get maximal functional outcomes in such patients. We all know, can proximal humerus be managed conservatively? This landmark paper from Profer trial in UK by Amar Rangan and his colleagues showed us that if you are in a dilemma whether to fix a proximal humerus or not, the results are okay if you treat it conservatively. But what does this mean? Which are the fractures you can treat conservatively, which are undisplaced and mildly displaced fractures? Still, 90% of fractures can be treated conservatively. I am not going against conservative treatment. Fractures like these, which look they are fractured, but actually they are not, because they are not displaced to each other, can be managed conservatively. I'll show you a patient whom I do manage most of my proximal humerus conservatively when they come to me like this. This appears to be slightly displaced, but I'll tell you my criteria for discussing when I do conservative. But just look at the follow-up of this patient, and I have got n number of X-rays which can prove this. 2 weeks, 5 weeks, later on 10 weeks, and see how the muscles as well as the body tone of around it remodels it to this patient. But I have done nothing for him, just gave him initial use lab just to ensure so that he knows that he is having a fracture for first 2 weeks. And then at the end of 4 months, he can see how well the proximal humerus looks. And this is his range of motion. He's still, I can say, a bhakt of me, always saying that I prevented his surgeries and gave him full range of motion. So how you can achieve this patient right from day 1 till day 16th week? Just look at these criteria. Head has to be in front of glenoid. Shaft has to be below the head at least 50 to 70%, and tuberosities have to be lower to the head. You follow just these 3 simple criteria with less than 1 centimeter of displacements, most of these fractures can be treated conservatively and you can get good results. So what am I talking of today? I am talking of these cases. These are the complex proximal humerus fractures where you find that the displacements are horrible, they are very great, or they are having fracture dislocations. And these are the complex humerus fractures which do require surgery to get results. And yes, if you follow the proper pathway, you can get excellent results. Exposure, deltopectoral versus deltoid. There is a big controversy, but the controversy is nothing, because ultimately it is how you want to achieve good results and how you access the fracture. I go through deltopectoral in all my cases, and the world also shows that there is no difference in outcome in blood loss or operative in a randomized controlled trial among these. Mark your image properly. I keep a Mayo's trolley always slide, making sure, because working in a government sector, I cannot put a patient in a beach chair with a lot of anesthesia risks. I keep him supine, make him Mayo trolley, which is movable, so that I can put my image, stand on either side, and let not the body weight affect it in supine position. For me, I can get a lateral view. You can see that I can get a lateral by just holding it and pushing the Mayo's trolley here and there. Let's come to the principles of what is the decides the prognosis. Look at these 2 X-rays, both proximal humerus X-rays, but the direction of displacements are different. One is in valgus, one is in varus. Remember that these varus angulations will be having a bad outcome and a higher complication rate. So your technical expertise and finesse is much more required in these cases. We all know the Hertel criteria, but remember that the Hertel criteria is just a guideline. Even he had in his next paper said that initial displacement and ischemia will not predict the development of necrosis later on, which many of us do not follow. We just see the Hertel's first paper and keep it on that. So how do we avoid failures? Look for the tuberosity alignments, head in front of glenoid. And one thing which I always say is medial cortical continuity. We have always been talking of medial cortical continuity in the lower limbs, for the varus, for the neck, for the subtrochs, but it is as important in the proximal humerus, where the medial cortical continuity, if you can achieve, you will be having excellent results. And I'll be showing you by various case examples right now. Tuberosity reduction, always take your bites from the osteotendinous junction, never from the bone, never from so high into the muscle or the rotator cuff. Look for the fragments. Tuberosities has to be bought and below the head, and they are tied to the plates. I normally tie as a routine in all my fractures, both the lesser and the greater tuberosities, tie them up with ethibond, even if they are not broken, just because I follow a certain protocol for all my complex fractures. Why it is important? It's because these are the three stands, the shaft, the GT, and the LT, on which your head resides. It's a very unstable one. So remember, unless you make them proper, the head is going to fall into varus. Medial cortical continuity, which I am always emphasizing, if it is intact, there is no comminution medially. By joysticks, you can reduce your proximal fragment. Remember, most of our reduction maneuvers in proximal humerus are based on the distal fragment. But if we can have joystick on the proximal one, it will become very easy for us to get the reduction, which we sometimes are not able to get, and we just accept whatever we get in trop. If we do not have medial cortical continuity, we try to achieve it by a graft, by abduction, or by joysticks, like in this position. You can just reduce the joysticks and you can get out of varus. Else, a graft, as I have shown you, or some people are putting an intramedullary fibula or an intramedullary plate as well to get the varus correction and medial cortical continuity. One good thing which we started doing was, this is our paper in JSES or shoulder elbow surgery, where we found that initial bone substitute or some bone graft inside that void helps in complex humerus fractures because it prevents the early collapse and the screws going inside the glenoid and perforating the humeral head, which in our case series has been very minimal because, and I attribute it to putting in the bone substitutes inside, which prevents the early collapse for me. It can be a bone graft, an iliac crest, or a bone substitute, whichever you feel you can put. So a fracture like this, you can see that fracture patient, reduce it with joysticks after opening up just with a ball spike or with a Homans or with a periosteal elevator, and you will be able to get that medial cortical continuity, proper calcar formation of the humeral head, and then the fixation of the plate is just a routine matter for us. Ideal plate placement for the youngsters, make sure that it is less than the tuberosities, around 8 millimeters. Have a good hold in a young patient in the subchondral area. The calcar screw is a must for such cases. Medial cortical continuity, I'll again be emphasizing this, is a must, and good hold down so that you can start early mobilization helps a lot. So these are the attributes of a good plate placement along with the fixation, which you can do in a young patient. If you are doing it in an osteoporotic, just ensure that your superior screws are smaller in size, because if a sectoral avascular necrosis has to happen, it will not pierce the glenoid. Let's start with the examples. A 35-year-old working as a pharmacist looks like this. Displaced, GT above, both the LT is broken. Our aim remains the same, to correct the varus, medial cortical continuity, and GT below the humeral head, just following these three principles. You reduce it by pushing it with a bone punch, and you can see how well you can achieve the medial cortical continuity. Once you have done that, matter of plate fixation, as I've shown, is just a ritual which you have to follow. Always ensure that your plate sits. Make sure that your lateral view gives you an idea how your head has been placed, better in retroversion or anteversion, and the plate placement in the shaft also helps. I normally put in two KYs, one anterior and one posterior, so that I can move my humeral plate up and down, and it does not get into different positions on a lateral view. Once you get this, you start his mobilization as early. I normally discharge my patient on the third day post-op, and he right now with the surgery, you can see the sutures. The very next day, his movements will be started so that he can achieve good movements even after when the fracture has united, full range of motion as you want him to be. Another case, looks valgus impacted, but it's not valgus impacted. It's a valgus fracture, widely displaced fracture with the greater tuberosity broken. See the CT scan, how small the anatomical head is, how the displacements and the combination of the humeral head is. But the treatment remains again the same, pushing in, getting the medial cortical by pushing it with the bone punch, get that medial. All my effort has been done to achieve that medial cortical continuity, which I achieve by getting the rotation of the distal fragment proper and then fixation and getting this position back for that patient. Again, 3 months later, and this guy has got range of motion, 2 years of follow-up, and you can see that his range of motion is as near normal as you can get even in this complex humerus fracture. A head split fracture, the complex ones which we need to operate, not going for an arthroplasty, especially in young patients like these. You can see the head splits in the third view, how that is broken. The head splits are there. And the reduction again remains the same. You can see what I have done, and this is what I normally do for all my patients. Try to rotate it whenever it is in valgus disimpaction. I rotate it start from here, push in my ball punch so that it comes here, and then all my efforts are to maintain that medial cortical continuity. Once I have been able to get that, then this GT is brought to its place by a Weber's clamp and then fixing it without opening the rotator interval even many a times and getting that head split back to its position. Putting in this bone substitute augments my fixation and prevents the early collapse. And then this is the post-op image, his 6 months follow-up along with his range of motion. He is a professor, my senior in AIMS, a very big medical department's professor, around 58 or 55 years of age. And he had a fall at his home during the COVID times. And this is the fracture he had. What do? We salvage him or we replace him? Yes, he wanted that I should not have a replacement. I wanted a salvage for this. And again, all the same principles which I have shown you come into picture and follow, even if the patient becomes very important for you, your relative or your boss even. I'll show you a stepwise manner of how to get that. This is the same patient with the split and the head. First, I have reduced this head portion back to the glenoid, trying to get the accuracy and the varus valgus of the glenoid. I couldn't keep it at that position because it was highly mobile. So what I did was held it with glenoid in the position where I want the humeral head to be. Once I have done that, then I bring the shaft back to the place where I want with a perfect rotational element so that I get the medial cortical continuity. This is what I have achieved with my finger out there and getting the rotational medial cortical continuity. Once I get the perfect medial cortical continuity, which will prevent the varus collapse, I have kept in the screws from the shaft into the glenoid. And then the GTs are trying to be brought back to its place. And then you get a perfect humeral head back to the position. I have also put in, because he was affordable at my hospital, calcium phosphate cement, which I was able to get into that bone augmentation. And this is his suturing of the ethibond sutures. This is his follow-up. This was his intra-op image, which we had started with. And this is what we were able to achieve intraoperatively from that position. Just following the same steps, GT below the head, head in front of glenoid, and medial cortical continuity. This is his post-op image, and this is his 6 months follow-up. You can see the callus and the things getting formed. He's back to his fiber optic surgeries or the pulmonary things which he was doing. Coming to the head dislocations and the fracture dislocations, can they be salvaged? Yes, they also can be salvaged. You just need proper relaxation of the muscles, making sure that you are able to get back the thing without doing any coracoid osteotomies. Flexing the elbow and flexing the shoulder gives you a lot of muscle relaxations. And then following the same principles which I have elucidated beforehand gives you excellent results with excellent X-rays as well. Some of the head splits, again, the posterior dislocations can also be managed in the same fashion. Sometimes in a posterior one, you might require a slight double incision so that you can bring it posteriorly if you are not able to bring back from a deltopectoral approach. And finally, this is one of the cases, my prime case, which gave me that confidence initial years, 2008 or 10 or 9, 2012, when this fracture patient came to me from Srinagar. He was a carpet merchant and he said, I want to get this to be salvaged. I am not going in for a replacement at 32 years of age with this amount of comminution and this CT scan which you had. The anatomical head, nothing at the tuberosity levels, nothing at the medial cortical side. I sent it to one of my best senior people out here in the Delhi, who shoulder surgeons, that they might do an arthroplasty and convince him in private. But they also sent him back saying that we are not going to do, you go back to AIMS. What we're having, anatomical head, severe comminution medially, comminuted tuberosities and bone void. Didn't know what to do. Young patient, he said, I have to hold carpets in my shoulder because I have to sell them like this. And I hold the carpets here. I want to go about back to a heavy demand. Aim was the same. Iliac cortical graft was taken here. And this is what I achieved. I didn't have the confidence. This was one of my initial cases where I went on doing such a complex case. But the principle remained the same. Head in front of the glenoid, trying to achieve the medial cortical continuity by iliac crest graft here, which I got, putting in a longer plate than usual, putting in all screws out there so that whatever hold I can get in the anatomical, GTs tied together very thoroughly with Ethibond. And this is his follow-up at 3 years. I showed it initially within 1 year, and all the seniors told me that you show the follow-ups 1 year, 2 years, so that we see how it goes. It's a very short-term follow-up, as usual. But this is what, it collapsed. I agree, it had to collapse, otherwise it won't unite. But then this is what the collapse started because the iliac crest graft was there. This was his range of motion. This is at 5 years. You can see that it has come here. The screws remains the same. Just watch out the screws. The GT has formed back because of the muscle tone. The LT has formed back. The head remains there, still viable. This is his 6 years follow-up. You cannot differentiate which part of the head or the arm has been operated upon, though the X-ray may not look as good as it is. The screws are still not penetrated the shoulder because they are still remaining after 5 years. And this is his 8 years follow-up. Still the screws remain the same. Everything has been there. And every year comes back in summer to me, just shows me, says hello, and calls me to Srinagar, which sometimes I'm afraid to go there. This is my paper in proximal humerus with the fracture dislocation, which we showed in shoulder and elbow surgery, where we had only 3 failures, and all these failures were in cases, fracture dislocations, 3 and 4 parts, where we had these failures in above 55 years of patients, where these things may not work because of the avascular necrosis which happens. Post-op rehabilitation is foremost, and as I told you, it has to be done as early as possible with the best confidence among the surgeons, because unless you are confident of your fixation and what the results you can achieve, you will not allow the patient to be having good range of motion. Early passive range of motion to be started, active motion after 6 weeks, and strengthening exercises roughly after 3 months or 2 months when you see that the bone has united. My dear friends, I've shown you complex humeral fractures. It does not take away from the fact that most of the fracture of humerus can be treated conservatively also. But once they are displaced, a huge, or they are fracture dislocations, then you need to operate upon them and achieve and good results. Is the key to success remains understanding the personality, good reduction of the tuberosities, head and shaft, with no maintaining the medial cortical continuity as by reduction or by augmentation. But remember, all these things need to be done with a biological approach. on the grounds of Professor A.K. Saha and Dr. Datta, I bow my head in front of all these legends and for this wonderful audience out here to give me the opportunity to present this prestigious oration. Thank you very much.
West Bengal Orthopedic Association, as mark of reference, confers this citation to Dr. Vivek Tirke, who delivered the prestigious Dr. Santosh Kumar Datta Memorial Lecture 2023 during WBOACON 2023 held at VM Grand Hotel, Malda. The oration is given in honor of Dr. Santosh Kumar Datta. He was the pioneer of modern orthopedic surgery in India. Rajiv Brahman and Chandan Pathak, President and Secretary. Thank you.
Now we are going for the past president's lecture. To chair this session, I like to invite our president, Dr. Chandan Pathak, and the organizing chairman of WBOACON 2023, and our past president, Dr. Debojyoti Bose sir, to come in the dais. And Dr. Kanchan Bhattacharya sir, due to his medical issue, he is in online. So, sir, bole din.
So for the past president WBO's lecture, it is my proud privilege to give a short introduction to Dr. Kanchan Bhattacharya. Dr. Bhattacharya passed his MBBS and MS from NRS Medical College, Kolkata, and he's closely associated. He's one of the most he's a pioneer arthroscopy surgeon in West Bengal. So a lot of us and other juniors, they initially they got trained by Dr. Kanchan Bhattacharya, and immediately after that he became president of Indian Arthroscopy Society, and he had been past president of West Bengal Orthopedic Association. He is the immediate past president. So I request Dr. Kanchan Bhattacharya to deliver his immediate past president's deliberation.
Good afternoon, everybody. I hope you can hear me. Am I audible? Am I audible and visible?
Yes, both you are audible and visible. Carry on.
Thank you very much. It gives me a great pleasure to be allowed to speak online on this We have been working back and forth, and Bappada and I had always shared that it was a great pleasure. Looking forward to going to Malda, but things did not work out the way we wanted it to go about. So I'm missing the meeting, missing everybody there, and it's a proud privilege to be allowed to speak there in honor of the chairpersons, the members of West Bengal Orthopedic Association, the delegates, the invited delegates, and my dear friend Vivek Trika, who just gave a beautiful oration on proximal fractures of the humerus. I would like to talk about the changing face of ACL reconstruction as I have seen it over the years. It's more about the arthroscopic surgery and how it has progressed over the years, even though it's been around for quite some time. A lot of people do not know that the first presentation of arthroscopic surgery from India, in India or abroad, was an international conference of SICOT by the late Dr. Ashok Sen Gupta. A sea change of arthroscopy came in about the 70s and 80s. Like in all other endoscopic surgery, with the advent of the camera system, it made it a lot more easier for people to carry out surgery and graduate from the diagnostic thing that was usually being done, because you had to hold the scope either in arthroscopy or laparoscopy or in urology with one hand or sometimes with both hands, and it was hard to do both things together. Ashok Sen Gupta unfortunately passed away in a plane accident in Jakarta, and close to Jakarta, where he had gone to provide some charitable work. But you know how the human mind and the hands work, even in the late 1970s, where UK did not have enough camera system, United States already had them. David Dandy was the first one to produce a paper on ACL done arthroscopically. And you can see in that picture that it was not camera, he was doing it with his eyes only. So we've graduated from the time of Dandy with arthroscopic assisted, where you made incisions and saw with the arthroscope, to a single or double incision. And now it's essentially no major arthrotomy. I was influenced in arthroscopy when I was still a student, or later part of the student life, when the only sports magazine available in India was Sports Star, and Robin Marler, a reputed sports journalist from UK, spoke about Botham's first arthroscopy in the very early days of his career. And he wrote it as keyhole surgery. It kind of piqued my interest. And when I worked in Jamshedpur for some time, Dr. Satish Sinha had learned about arthroscopy because he worked sometime with David Dandy. And incidentally, I had an arthroscope there in Jamshedpur. We tried looking at the eyes and saw the sun and the moon. I had really no idea what this was happening. So my mentor, Professor A.K. Das, said, you should, if you're so interested in it, go for it. Looked around for an opening, and nothing was forthcoming regardless of what it was. And though there were openings in UK, in that part of the time, in late 80s and early 90s, it was still quite rudimentary in the United Kingdom. There were itinerant arthroscopists. So I was introduced by Dr. Das to my mentor, Dr. Dilip Pal, who made it happen for me when he offered a fellowship in Texas, in Lubbock, Texas. Spent about 6 months with him first, and then went back almost every year for a couple of months. And I trained with several other surgeons in that city and elsewhere. While I was doing all this, I was always piqued by the interest of ACL injury, which was not so highlighted during my college days. But when I was doing my postgraduate under Professor D.K. Mukherjee, he was doing a lot of 5-in-1 open Nicholas surgery for ACL reconstruction. And I realized that we needed to do something for those players. As things happened when I went for my training in the early 90s, we found out that in the Western world, especially in North America, the technology had arrived a lot earlier. And that is how they stole a march on us. The infrastructure in terms of endoscopy and camera system and instrumentations, we were a different We were in different planets, maybe in different galaxies altogether. We were so different. We were so far behind. So when I bought my equipments there, and they were secondhand, still very, very expensive, had some help from my friends and mentors and others in getting them across to the country with the customers being so difficult. And my initial days for everybody is hard, but for me, it wasn't that hard because friends and mentors in Calcutta helped me along a lot. They were hovering over me. One of the first cases that I did, or not one of the first cases, one of the earlier cases that we did, Professor Nikhil Demojumdar and Dr. Shukhendu Banerjee had a patient from Ramakrishna Mission, which they brought over, I operated, and they were there all along, and they kept supporting me for several years, even today. Dr. Ashok Sengupta would frequently come over and see what was happening and put in his input. Professor Arun Sharkar, Professor Tarak Sen, Dr. Shomen Mukherjee, Dr. Tapan Moitro, Anjan Pan, and the late Pradeep Banerjee, a good friend of ours. There were many others, and I probably will not be able to mention all of them, but over and above all that, Professor Das was hovering around like a mother hen, taking care of everything and doling out hard common sense when I was going astray. In the WBOACON in Burdwan in 1994, I made my first presentation, and that was on arthroscopic surgery, arthroscopic meniscectomies. The number was somewhere in the 20s in a few months, which raised a lot of eyebrows. But the credibility, I think, remained because most of the cases that I did were referred by senior doctors who were sitting in that auditorium. So the pleasant surprise of that was Burdwan became a great support for me. Professor M.M. Roy, Professor Chinmoy Dey, and the late Ananda Sai reposed their faith and kept a whole number of players from Burdwan coming over. From Malda, it was Bapada, or Onilda, Umalda, Bidduda, Horipoda, and Manibruto Chandra. But the biggest support came from the playing areas in West Bengal, which have now moved from Parganas across the river to Howrah and Hooghly. And Bhaskar Das, Nupurda, Niloyda kept all the players in loop with me, and I could help some of them. And that was a great boon. Money was not the issue those days, but the numbers were so important to keep it going. The other big advantage was arthroscopic surgery society has always been a closed net. And then at that point of time, there were a few predecessors like David Rajan, Anand Joshi, Sripati Rao, Nicholas Antau, who'd started before me and had a good contact. So any problem, they were just a phone call away. The limited inventory around the country meant that the few of us knew exactly what implants was available with, and we could exchange that as well. The early part of the journey where you had to carry everything, the big hospitals like Woodlands and Bay, you had nothing, just the room. They provided you just the room like a hotel. So you had to carry your camera, your monitor, the whole number of stabilizers. I became quite adept at knowing about technology, changing fuses, knowing which was working, which was not working, making sure that the earthing was all right. And it's unbelievable. The price was so exorbitant. It's formidable for everybody. Then the prices have increased only marginally now. When you look at the inflation rate, I would say that it's become a lot cheaper today than what used to be there. The biggest difference today is it's available, but it was not available those days. So we all started with patellar bone, tendon bone, and the implants we used were dictated by what we read in the literature and what we found that we could afford. So the standard interference screw is 7 millimeter and a canceller screw is 6.5 millimeters. So we use a 6.5 millimeter for several years, or press fit in the femoral side. I'm not an innovator. I cannot think on my feet. I rely on things that I've read and seen. So press fit was always there, and I've used a press fit on the femur for several years, not because of non-availability, but because of the ease of press fit rather than putting in an interference screw on the right knee in the femur. Sometimes, and this is one of those when you have one of those interference fit with 6.5 canceller screw, and this gentleman came to see me for a different reason. You will find that it's not exactly what you would love an X-ray to look like. But this was done 25 years ago. He represented the country since then. He's still active. And look at it, not much degenerative changes, and he's in his 50s. And then this was the other kind of fixation that we'd use those days. Coming of age and patellar tendon reconstructions was the advent of interference screws. Soon there were Indian producers of them, which was pretty good for doing it in PTB. But if you're using them for soft tissues, that wasn't so good. You would chew them up. It came in different colors, in different hues, and in different materials, and they still are there. And it's probably the backbone. Late in the 90s, the hamstring became important. Once we got convinced that it is just as strong as the bone patellar bone, we started to induct it into our practice. A very clever fixation founded by Rosenberg was the endo button, and Marcelin tapes were available because the gynecologists used it for Shirotka surgery. So you had Marcelin tapes to make the loop with, and this actually helped with the inventory because with just one Marcelin tape, you could make a loop of any size you wanted to. We also found out that Marcelin tapes without needles cost less, and we sold that as well, and we used it for many years. But I think a very big, important change that has come is with hamstrings. Once the hamstring came, industry came with several implants for that. Transfix from Arthrex, rigid fix from Mytech, Intrafix from Mytech, Tightrope again from Arthrex. So once this came into play, the industry stepped in. A combination of the industry stepping in, a number of industrial surgeons getting in the way, and the increased demand for laparoscopy and neurosurgery and ENT surgery, and even sometimes in neurosurgery, meant that camera systems were available in most of the big hospitals. And that is a big headache out of your way. You only have to need an arthroscope. Everything else is available wherever you're going. Training became easier as more and more people were doing it. The industry stepped into a lot of cadaver workshops. And because arthroscopy has been so warm to induct other people in, we have always had observers stepping in for days, for months, for a longer period, depending on how and when they worked out. As we started to get the equipments, as everything else, the instrumentation became easier. The playing field with the Western world became more and more even. The biggest progress, I think, in the last 15 odd years is the availability of the camera system of arthroscopy, laparoscopy in all medical colleges and government hospitals, which have all the necessary equipments and always this necessary expertise. PG training is a basic training of arthroscopy in the hospital and on several fronts as well. Today, ACL is not novel anymore. It's being carried out efficiently in every corner of my state, and I'm sure in the rest of the country as well. No center is too remote to have an ACL reconstruction done. We rarely have any large number of patients coming in from far-flung areas to get ACL done because it's not being done there. That does not happen anymore. The next winds of change that have come in ACL reconstruction affected the whole world together. Now, we are not so much different from the other parts of the world. Among the first things and the ones that bothered everybody was where to put your femoral tunnel. There's a lot of things going on for over the years, coming from the clock phase to anatomic, and then how you enter it. Started with a transtibial, and then we moved over to the enteromedial or medial portal. This is not novel. Lopinchowski in America and Australia have been doing it for many, many years, but a lot of us discovered it later. And then we found out where you want to put a femoral head, and Freddie Fu came with a double bundle. So about 8-10 years went out double bundle, then you come out with where you want to put your anatomical femoral tunnel. And with that anatomical femoral tunnel came the area when we started to put in low down. And I, like it's shown in Scandinavian registry, had a large number of early failures when I misconstrued the anatomical and kept it too low and kind of reconstructed the PL bundle more than the AM bundle. That over the years we found out that that is not the way it should be done. and we have now hit upon a better area. So we have a better understanding now. Fortunately, there wasn't much change going on in the tibial origin or tibial tunnel, and there may have been few changes about instrumentation, but not a whole lot again. Over the years, this was a change that has always been there. And this is like, we know about everything in orthopedics. Preserve as much as you can. Deal with only the broken parts. And this is where the remnant preservation of ACL is come about. We know that there are two bundles. If one is torn, try to save this and try to reconstruct only the torn part. If it's an avulsion, you want to fix it. This was done many, many years ago at Bosota. The instrumentations were not that good. We tried it earlier, it didn't work so well. It's come back again. It's like exploring new horizons and revisiting older experiences. So my old experiences of repairing wasn't very good. So I haven't really gone back to it, but there are others who are doing it and doing it well. Now I only present this one to highlight one change that has happened. I've done 74 revisions between 2014 and 19, a 5-year period compared to about 1,600 primers in that period. And more than half of them are re-tears. So this is about 7% revision rate, even considering that a few of them have gone away. And the average failure rate of ACL is between 5 and 20%. We want to get better on that. The earlier days, about 2 decades ago, almost 80% of revision because of instability were because of technical errors, the anteriorly placed femoral tunnel. Nowadays, more and more of them are re-tears. And this is exactly the change that has happened. People have become better at what they're doing, and they have a better understanding. Why more than half are re-tears? What about the others? Have I done them very poorly? 2 things have happened. We have again learned that when we have an ACL deficient knee, there may be other injuries as well. And if we overlook those other injuries, we run the risk of having an early re-tear. So the extra-articular procedures of Ellison, of Lemire, of Anderson have come back again. And they've come back again in vengeance, especially when you do a revision, ACL reconstruction. This is today's change. At the turn of the decade, the number of surgeons doing arthroscopy in Calcutta could be counted in the fingers of one hand, and still all the fingers would not have been used. Today, it'll take 2 whole rooms of your conference to take in the number of guys doing arthroscopy and regularly in meetings and in cadaver workshops. And this is the change that I'm talking about. This is the one that has happened over the years. Today, the most significant change is the availability of this service to all and sundry. The surgical technique, expertise of execution of ACL surgery by our surgeons is no different. It's certainly not inferior to anyone, anywhere in this universe. The only area we are lacking behind and we're soon going to catch up on is the publications. We have a whole host of young, bushy-tailed arthroscopic surgeons who are now publishing as much and as often as they're operating. In terms of numbers, we will cross everybody. Maybe not China, but we'll cross everybody and very soon. And we also have a ligament registry, which most countries still do not have. I am sorry I could not attend this, but thank you very much for this opportunity. And I'm sure that this meeting will be is already a great one, and will get even better as today goes on and tomorrow. Thank you very much.
We are very unfortunate that he could not be present in this August gathering, in this memorable conference. Just 2 days back, he called me, Bappada, I'm very sorry I cannot come because I am sick. Anyhow, online, he has explained everything about the newer techniques of ACL reconstruction. Thank you very much, Kanchan, to be here on online. Thank you for your exceptional lecture. Thank you again once more.
Thank you so much, Bapada.
Yesterday in the prize distribution ceremony, some of the prizes were not given because they were been stuck with their NMC visit. So I'll request them to come forward. So I first, for the previous year Siliguri Best Paper Award, I'd like to invite Dr. Arup Kundu to come in the dais to take his prize. Next, for the WBO annual quiz, I'd like to invite Dr. Debangan and Shayok to come in the dais to take their certificate. सामने दिखे देखा सामने. Okay. Okay, Debangan, wait, you have a certificate for your publication also. Thank you. Yes, that's it. Thank you. So now we'll move to the next session. That yesterday we have 5 fantastic live surgeries done. To conduct, some of us missed the session live surgery. To conduct this live surgery session, what was done yesterday, I would like to invite our organizing secretary, Dr. G.G. Kar, sir, to come in the dais and conduct this session.
So, ওদিকে আছে? Okay, fine. তাহলে আমরা তো কে স্টার্ট করবে? স্বর্ণেন্দু will start. So it was a shoulder instability case, and I would like to call Dr. Swarnendu Samanto. He will tell us about the case. Though the PowerPoint was prepared by me, it was a shoulder instability case. And you expect interaction from the people who are presented in the hall. So fire any question to Swarnendu. He'll be glad to answer.
Sure. So yesterday, the best physical clinical meeting award was given to RG Kar. The RG Kar people were stuck with NMC visit. So I like to invite our president and secretary to come in the dais to give the best clinical meeting physical given to RGCR Medical College. And it has been difficult to, they are retaining the prize. So it has been difficult to catch RGCR in clinical meeting now. So RGCR should be, next year RGCR should not be allowed to hold a clinical meeting. So otherwise, other institute would get the chance. Okay, thank you, Jijikar sir.
So Swarnendu, AV people, please show the presentation. AV people, please show the presentation. So it was a shoulder instability case. Swarnendu will explain what was his findings. This was the basic information. A young male, he had a traumatic dislocation for 1 year back. Then since then, 3 more dislocations. Every time he had to consult a doctor to get it reduced. This was the basic information. And this was a apprehension, relief, and surprise test. There are so many tests, but just because of shortness of time, we'll went for this one, only. Okay. So, surprise,
yes,
everything.
he had the classic sign of the apprehension of the Job's relocation was also positive. He didn't have any generalized ligamentous laxity. This was purely a traumatic event, and he had 4 dislocations total. And he's a soccer player. Age is 22. And if we can, you can see that nothing is in the X-ray. You don't find any sort of hill sacks in the X-ray. Do you have the MRI?
I have.
And if you see the MRI, and you see, obviously, first we see whether there is on the back side something or there are not. So here in the top side, you can see this. There is not a very deep lesion on the back. Only here, if you come, there is something on that side, but it's not very deep and medial. And also, if you see this picture, there is some lesion in the front. And when we, if you see also this picture, the axial cuts, you can see that there is classic Bankart lesion is there.
In any other sequence you want to have? This one?
Yes, this sometimes for the Bankart we don't usually see this thing, but for the juniors, this is the view. This is known as the end phase view of the glenoid. What you do in the CT scan, what you see in the CT scan, so that you can measure whether there is any bone loss in the front of the glenoid. So you don't need this classic CT scan. If you want to have, you can have that. But if you see the end phase vision of your glenoid, you can see that there is no bone loss in the front. So this view is also very important to see the face of the glenoid. This is known as the end phase view of the glenoid. And also you see this coronal cuts also. Why? Because if you don't see the coronal cuts, you will never see whether there is a classic J signal, that is the ALPSA, or the Hagel lesion. Even in the axial cuts also, you can see the Hagel lesion, so that you don't miss the Hagel. Because if you miss the Hagel in the front, so that is a day 1 failure.
Right. So it's important to have those 2 cuts also.
So all the 3 cuts has to be seen.
So now you explain what you have done, because you haven't put any video over here for shortness of time.
So yes, video is there with there, but I think those who have attended.
Yeah, it is only for the video was only for those attending.
Yes. So when the classic posterior portal was done, and 2 anterior portals, one anterior superior, one anterior inferior, one is in front of the biceps, one is behind the biceps, 2 working portal in the front. I always do all my Bankart from the posterior viewing portal.
What was the position of the patient?
It is lateral decubitus position with 30-degree posterior tilt. Because if you don't tilt the patient 30-degree posterior, the glenoid doesn't make parallel to the floor. So it has to be 30-degree, it is lateral decubitus, 30-degree abduction and forward flexion of the arm, so that it is 30-30 for the Bankart, 15-15 for the cuff. And it is just we use the visco simple traction kit, and we fix it. We don't use any hi-fi device for that. It is a
And costly hi-fi
lateral decubitation. Remember, you have to protect the eye, protect the ear so that your fluid doesn't leak. The eye has to be protected. The lateral, the nerve on the knee has to be protected. So every body points has to be protected. And the tissue which I find, if we can, I do have, I think probably you will be having the video. When I went inside, the tissue quality was not very good. And it was typically not bank cut. It was basically a alpha lesion. So everything was eroded from the front of the glenoid. So I have to release all in front of the glenoid so that I can see the subscales muscle. So I did the classic 3 anchors, all suture at 5, 3, and 1, as because this is right.
You used all suture anchors.
Always, once it is launched in the market, from that day on, I am using the all suture. I will request all the juniors. The metal anchor is out. Never use the metal anchor for your bank cut. You can still use the synthetic ones, the peak anchors.
Any particular reason for that?
Yes, metal anchors out is that it is very difficult to redo. If there is some proud things with the metal anchor, is a disaster on the front. And if you want to redo, then it is a difficult, because it will come in your path. Second is the bio anchors can be used that way, but the osteolysis around the bio anchors are now a proven fact. So now people are not using the bio anchors. So if you are using any anchor for the shoulder, for the bank cut, it has to be the all suture anchors. It is a single loaded anchor. Only two threads are there with single anchor. So I use the 5, 3, and 1, and I take the bite at 6, 4, and 2, so that it is not only the anterior to posterior shift, it is inferior to superior shift. Basically, it is two-way shift. Exactly. So in that case, I think Bappa assisted me, Orgo was there. I also did the arthroscopic subscapularis advancement, as because it was the alpha, it is a poor tissue, no bank cut, though bank cut, classic bank cut labrum was there. So in the middle stage, I took the leading margin of the subscap, so it becomes the new MGHL. Right. And the study is there, even if you do the arthroscopic subscapularic advancement, at the end of 6 months or 1 year, they doesn't have any sort of restriction of the external rotation.
So it somewhat shrinks your rotator cuff interval as
yes,
well.
Yes. I have also, as because he had 4 times dislocation and he's a young guy, less than 25. So I also closed the rotator interval with the 1 o'clock stage.
Okay, fine. And this is a theoretical question. What is the longest review of suture anchors?
I think suture anchor in India, it has been coming. It has come in the Indian market probably for last 4 or 5 years.
4 or 5 years. So
4 or 5 years. And now people are also using the all suture anchors for the cuffs also.
Any studies on the osteolysis around the invisible sutures?
Even there are a lot many studies in the international literature is there between the metal bio and the suture anchor. There is no osteolysis around the suture anchor.
So that comes from the master that you use all suture anchors always. Not going into the question of affordability for bankers' lesions.
No, I think the affordability, the price of the suture anchor is absolutely equal to your peak anchors.
Not going into that.
Metal is absolutely out. Don't use any metal in the shoulder.
And as expected, the postoperative X-ray will show you nothing, because all suture anchors were used. So it's about the same as the preoperative X-ray. Any difference, Shonendu?
No, I think the question is that you cannot see anything in the front because we don't see the metals here anywhere. Only thing you know that we immobilize the shoulder in the internal rotation position, as because you see the head is internal rotated. Even you can see there is no bone defect. Even I have seen whether the heel sac was coming beyond the glenoid. It was not there. It is a very, very small, shallow lesion. There is no need of remplissage.
Typical postoperative X-rays are always taken in internal rotation.
It is like the Philo's X-ray. It is always like this.
Right. So thank you, Shonendu. Anybody have any question about this complicated surgery?
No, it is not complicated at all.
No, not for you, but for us, it may be complicated.
It is. If somebody was there present, I think, who has seen the surgery, he can ask any question or any comment from the masters, Obijit da, Kunal da, Bappa da, or Soumitra. I think we do these patients, if the patient is really listening to you, they doesn't need any long period of immobilization. So once the pain goes off, like 5 days or 7 days, you just do the pendulum exercises don't allow the external rotation for 3 weeks. You can come to neutral, 0 on day 7, but never allow them to external rotate fully before 3 weeks, because by that way you may land up in trouble, because these people are young, they will overdo the thing. So my exercise protocol is very simple. I just tell them to put the arm sling, or if I am noting that he is not going to listen to my advice, I straightforward put the chest binder for 2 weeks time. Then in the 3rd week, I usually tell them to catch the arm like this, touch the forehead in 3rd week. Then this is 4 weeks and this is 5 weeks. So your abduction, external rotation, everything is done in this way, and start doing the external rotation like this from 3 weeks onwards. By 3 months, they get back every movement back. Kunalda, কিছু বলছো?
Subscapularis, will you repeat? What did you do with the subscapularis after these 3 suture anchors?
না after না, ওটা second suture এর কথা।
ওটা আমি দেখছি যদি আমরা ভিডিওটা আছে এখানে।
There. Video is there in the computer, but time is so short.
না ঠিক আছে, আমি বলে দিচ্ছি, কোশ্চেনটার অ্যানসারটা বলেই দিচ্ছি। When we go inside, basically the middle glenohumeral ligament crosses the subscap absolutely at 90 degrees. So when the middle glenohumeral ligament, the labrum is there, we don't take the subscap. But when the middle glenoid labrum and the labrum is not there, then subscap is basically coming absolutely at 90 degrees from the glenoid. So you just take a bite at the leading edge of the subscap. The subscap just comes on the glenoid face. So this becomes a checkering effect of your external rotation.
Subscapularis is being attached to the
On the glenoid face.
Right.
Yeah, so
Becoming more adherent to the glenoid, another anterior support.
yes. So this is known as the arthroscopic subscapularic advancement, ASA.
Okay, Swanand, thank you for
thank
nice
you.
demonstration, nice talks. Now I move to CTV case. Dr. Devajyoti Bose will present that. Only I have the intraoperative images, not the video images, but still images. Please explain about your case. এটা আমি এখান থেকে দেখিয়ে দেবো, তুমি তোমার কেসটাকে একটু প্রেজেন্ট করে দাও।
Okay.
Because data is with you, not me.
The case was a bilateral CTV and clinical photograph was there.
No, not yet. পাওয়া যায়নি।
Clinical photograph দিয়েছিলাম তো একটা।
না, আমার কাছে নেই। ওরা ভিডিওটা তুলেছিল, ভিডিওটাও খুঁজে পাইনি, so I cannot help there.
So nothing to say much about is a bilateral CTV.
I can have this picture here because I took that picture from the screen.
There was a bilateral CTV case which was plastered 5 times, and after correction only the posterior contracture was there. So I used to do a needle tenotomy most of the cases below 4 months. So this I have done there, and that's the placement of the needle.
What is the gauge of the needle?
Pardon?
What is the gauge of the size of the needle?
It is normally the BT needle, the blood BT needle.
Blood transfusion.
Yes, blood transfusion
around
needle.
16 gauge. I
Yes.
think, 16 or 18.
Is a blood
Or 18 gauge.
16 or 18 gauge.
I don't know.
Sorry?
16 gauge or 18 gauge?
Yes.
Can answer. I was not doing so.
Papa,
Yes,
gauge-টা বলতে পারবে না?
18 gauge most like.
18 gauge.
Yes,
16 gauge হলো too narrow মানে।
16 gauge narrow. It is 18 gauge. This is 16 gauge because 18 gauge was not available there.
Okay.
Normally I do with 18 gauge needle. So my way of treatment is that thinking is that advantage of this minimum bleeding, chances of vascular injury is less. So, but there is a time bound. There is below 4 months. I use this needle. After 4 months, I normally do with a knife.
11 number blade.
Yes.
11 number.
Yes.
Tenotomy knife.
Yeah. So what we do, I feel the tendon Achilles by my finger. So this needs some expertise. Once you start doing it, you can understand that. And then you pass the needle in front of the tendon Achilles and ask your assistant to dorsiflex the foot, and you try to cut the needle beveled end and you see a popping sound, and that will release the posterior content.
This is under general anesthesia or
Below 2 months, I do under local anesthesia.
local?
After 2 months or 3 months, we do under general anesthesia, because general anesthesia becomes very expensive. Ideally, you should do it, but it becomes expensive. So I do under local anesthesia.
And what do you see before putting the, what is your examination under anesthesia?
I see whether I can bring the foot beyond plantigrade or not.
Beyond?
Plantigrade or not, because I can dorsiflex it or not.
Okay. If you can?
If we cannot dorsiflex, then the tendon is tight.
Yeah, in that case, you do the
Yes,
needling.
in that case, I do.
If you can bring it up 5
Yes,
degrees, 10 degrees,
yes,
then you do
yes,
not do
yes,
this.
yes.
Okay, so indication wise, it is that.
Yes,
Any
yes.
other indication, any sagittal plane? Any coronal plane problem, coronal plane criteria?
Not exactly, but before doing this, I must be sure that it should not be
Case of bilateral
more than 2. It should be Pirani 2.
Okay.
That is most important. It should not, if it is above 3, there is chance of recurrence. So 2 or 1.
They are showing the video. They have come up with the video and they are showing. Thank you, Avi, for this. So about 1 minute we have. Just quickly forward this. So this was the you did bilateral?
Yes.
Hello. Any advantage of needle
Over 11 gauge.
Over scalpel.
Scalpel.
The advantage is that it is a
এক মিনিট তুমি এতক্ষণ এটা explain করে নাও.
Yes.
So
yes.
and answer the question later.
You see what I have done? This is my needle.
অডিওটা আসবে না?
This is my needle.
Ask your
audio না এলেও কোনো অসুবিধা
Okay,
নেই।
না এলেও
Everybody understand.
ঠিক আছে।
Can you sir?
এই বাচ্চাটার বয়স কত?
Now you see what assisting holding hold the
now.
foot, and I am feeling the tender Achilles. This is the tender Achilles.
Hello.
Okay. This is the tender Achilles.
Yes, yes.
Okay. Now this is you see my left hand. It is over the tender Achilles. I'm just feeling it. Now you see, this is the medial malleolus. There is a vessel. So in between vessel and the tender Achilles, I'm introducing this needle. Sure.
So your bevel is towards you, towards the skin.
Can you see?
Yes, yes, sir. Clearly seen now.
Now. Okay. Now you see this is when corrected. Can you see?
Our obstruction also.
Can you see this is corrected?
Yes, yes, yes. Now it is seen.
Only a small needle can do it. You don't have to introduce a knife. And there's a minimum bleeding. You just keep it hold here. Now check the circulation. Now the circulation is okay. So you have not damaged the tendon.
The tendon.
Sorry. Okay.
Yes, sir.
Similarly, I have needle also. I have needle. Come here, this side. Come this side.
So it was the repetition of the same on the other side. So I can stop over here. Every people, please stop this.
Can you see it?
No, no.
Every, please stop this because we are just repeating the same thing all over again. So thank you, Bapada. And any questions from the floor?
Bapada, youngest.
Yes, to Bapada, not to me.
2 months.
Pardon?
সবচেয়ে বড় মানে ছোট বাচ্চা কত
Hello.
বয়সে করেছে?
My observation is that when the tendro-Achilles tenotomy is to be done, as you see in this case, the correction of the forefoot is not occurred yet. So it should be more than 65.
I think he has
degree
shown that the
abduction.
forefoot was corrected
Yes, no.
in the video, I think.
Video I saw it, it is going up to 30° or something. It should go up more than 65. As Bonsetti said, it should be 75. But now 70° or more. But it is considered that at least 65° of abduction to occur for the forefoot.
Yeah,
But here it
may I
was
have the-
accepted, number one. Second thing is, the tenotomy can be done by the, I don't have any objection for that. But in case of, in such cases where the stenotomy is being done, but we have one arrhythmia tendon, cut tendon is being paid by the paratenon. So do you have any observation or thinking to preserve the paratenon while you are doing the tendro-Achilles tenotomy?
May I answer him? The first thing is that, the first point, in every case of CTV, after correction of the plaster, you cannot see a foot. If you hold it and see it clinically, focus, there is always a slight amount of adduction. But if you can correct that adduction passively, that is the most important thing. If we can correct that adduction passively, you can think, because there is always an inherent instability, inherent adduction forces moving on the forefoot. So most of the cases I have found, it is my experience of 20 years. Most of the cases we find that in clinical, when you take a clinical photographs of those pictures after 5 plasters, you will find a slight amount of varus, forefoot varus. But that is not a contraindication of tenotomy.
Actually, what I am saying, you are misunderstanding me. That is as Pirani said, the measurement should be at maximally corrected position. So I am not objecting that. So I am not seeing only the passive.
Yes,
position of
it was
the maximally abducted position when it should must.
Yes, it was done at the abducted position, because passively I can abduct that foot, and tenotomy about the paratenon and tenotomy, what you are saying, it is very difficult to justify you are going in
In a
between
blind
that
procedure, it's impossible actually.
It is
In a blind
impossible.
procedure, you cannot see paratenon.
So if you cut the
Differentiate
tendon,
between
the paratenon is also
Very small
also-
children, it doesn't matter at all. Sushant, you have got a question?
Yes. One third, just.
Yes, what is your question?
So that is, you have said that you have said that the indication for tenotomy is the plantigrade position, beyond plantigrade position, maybe 5° or 10° or dorsiflexion.
Yes.
But as it is described, that the recurrence is when it is less than 30°, and when it is coming 15° or so, then it is surely recurrence. So you have to achieve the correction of the dorsiflexion more than 15°, and preferably it is 30°.
Yes, obviously, the dorsiflexion must come up to between 15 to 30°. That's my way of thinking. Not 30°, because you cannot, because if you got a small calcaneum, you cannot get 30°. If you got a small calcaneum, you cannot get 30°. Then you have to get maximum 20°, because calcaneum is small. So my way of thinking is that it must be between 15 to 20°, and there is chances of recurrence. Even if you do up to 30°, there is chance of recurrence. So chance of recurrence is not depending upon the tenotomy. It depends upon the patient, how much the child is wearing the splint. 24-hour sprint, 23-hour sprint is the most cause.
Dr. Bose, even then that can happen because there can be a dissimilarity between the growth of the
Yes.
soft tissues and the bone. It can happen.
Yes.
Okay, Susan, your question, please.
Good afternoon, sir.
That's
Sir,
the last
I just
question.
had a simple question. I come from a place which was not having a lot of anesthetics. So whenever we used to do the tenotomy, we used to use a local cream application. So what is your experience about it? That is the first part of the question. And second is, sir, how many weeks or how many weeks would you actually advise a cast to be kept after a tenotomy?
The first question, I never do a tenotomy without anesthesia below 4 months, after 4 months. Always do after 4 months. We do anesthesia. Below 4 months, we have to go for a.
No, his question was about anesthetic jelly.
I don't have
Anesthetic
any
jelly or-
experience about the anesthetic gel.
Okay.
Look, I don't.
And the duration of the cast.
And number of casts, normally.
No,
it
duration
has-
of the cast after this procedure.
Yes, after tenotomy, you have to keep cast at least for 3 weeks. But normally what happens, the patient party damages the plaster because of this urine trickling or something like that. For that cause, we change the plaster at 2 weeks.
So you call the patient for the follow-up? after
Yes, after we call the patient after 2 weeks, see the plaster is damaged or not. If it is damaged, we change it for 2 weeks more. So keep it for 1 month then.
Thank you very much, Bappada. So, sorry?
Above knee or below knee plaster?
Above knee, above knee.
Time is running out. There are 2 cases more, okay? Just a quick one.
Yeah. So that is actually, as it is advised by Ponseti, that cast should be retained for
Saurabh.
3 weeks. But
Saurabh,
as Bappada
Saurabh
said,
Subro, who will come?
It is very correct that at 2 weeks, if I change, then what happens? In the first cast, there is some contracture of the capsules also. So at 2 weeks, if I change it, and the further dorsiflexion is achievable because of the same principles of the Ponseti, that ligamentous stretching. So that do occur, and that is kept for another 2 weeks.
Yes.
So 4 weeks, 2 weeks, 2 weeks, 4 weeks would be more convenient, and as I do practice.
So this one, the presentation one, I would like to call Dr. Subhro Chatterjee, who did the TKR yesterday. AB people, please put the presentation here. There's a bilateral case of knee pain for more than 8 years, right more than left. 60 years old male, known case of rheumatoid arthritis, taking DMRDs. Cannot work nowadays because of bilateral severe knee pain, and he is very reluctant to put weight on the affected limb, right limb. And this is even standing becomes very difficult for him. These are the still pictures. There is varus, there is flexion, and he will come up with the degrees. And this is the video, painful to look at also, Otherwise healthy man, but this one. Okay, now Subhro will take over. X-ray.
Yes, the first thing is I didn't do the operation alone. Dr. Saurabh Das was there with me. He's
Naturally, it's a
sitting
teamwork,
there.
has to be.
Okay. So this patient had about 50° of fixed flexion deformity and around 15° of
15.
15° of fixed flexion deformity and 15° of varus.
Correction, correctable.
There was no, the varus was partially correctable, but the flexion deformity was not correctable.
Even under anesthesia.
Even under anesthesia, and there was a defect in the medial tibial plateau also that you can see. So we were supposed to operate with a biomet knee, Vanguard. So
any
it is a
design-
standard.
Any design advantages of that particular knee? There are so many variants of knee
There
replacement.
are certain advantages. Number one is biomet is available in smaller sizes, especially for female patients. It is advantageous. The disadvantages with the biomet knee, we cannot use any sort of tibial plateau augments. We cannot use tibial augments with this
Oh.
biomet device. And not also a long.
This is an intraoperative picture I've taken from the live screen. So there is a gross defect of the medial.
There is a gross defect in the medial side.
Medial femoral condyle.
Medial tibial condyle was
And medial
defect, and
femoral
there was
condyle.
also a defect on the medial femoral condyle.
So,
Okay, there was a defect on the medial femoral condyle also.
so how did you place your femoral jig then? Normally we.
No, with that standard way that we use, there was a
It was touching
sort
only
of
the lateral.
erosion of the medial femoral condyle, but there was no bone loss.
Okay.
So we could do it normally. The tibial medial side was deficient.
So what did you?
This was
how
deficient.
Did you, how did you?
So what the minimum insert that the Vanguard knee allows is the 10 mm insert, tibial side. So after we cut with the 10 mm tibial jig, then we found that the defect has considerably reduced. And we thought that we could manage with screws.
Okay.
So
Screw and
we built
cement.
up the medial side with screw and with,
This is the post-operative X-ray.
right,
So you use two
screws
two
and
3.5.
3.5 screws. 3.5 screws we used. And we were able to correct the fixed flexion deformity as well as the varus deformity.
Like a describe for fully threaded cancellous.
Fully threaded cancellous screw, you can give either a 3.5 or a 4.5. এখানে 3.5 না যদি না থাকে 3.5 না 4 point in case if I have given a 4.5 I would have given a single screw, but specifically we had asked for a 3.5 screws. And then I found that the defect was
Posteromedial.
whatever is there, it is screwable. And instead of putting one screw, I put one screw at the back and one screw at the front, check that the tibial plateau was not fouling with the screws, and then cemented it.
Achha. So anybody from the audience has any question to Dr. Shubhra Chatterjee, they can fire.
Yes, sir.
Sir, please.
Screw, that's okay. Screw should not touch your metal part.
Implant.
There, the chances of problem of galvanic and other things are there. So there should be a little bit of cement on the top of the screw. Directly should not touch the metal.
Yes, there is
One
cement, sir.
important thing. Secondly, if you look at the radiologically 3 years, 5 years, you will see some radiolucent lines around this area. Nothing to worry about it. It's just a comment. Nothing.
Around the screws, sir. Around the
screws, yeah.
No, cement bone junction.
Oh, cement bone.
Okay.
Cement bone junction. Because the stress is different.
Yes, yes.
Yes.
Stiffness is different.
That
And
is the reason you will start worrying. So don't get worried.
and your experience says that it is not a point to be worried about.
We have done this from 1970.
Naturally. So your experience tells us that it is not to be worried about.
Naturally,
Fine,
sir. You have been doing so many hips and knees, sir. Sir, routinely we don't do the patella. So when I measured with the vernier caliper, the thickness came as 22 mm. So we are a bit
22.
22.
Okay.
22 mm.
That is a problem.
Yes. So if I remove 8 mm, so 14 mm remains. So
Plus a rheumatoid patient maybe.
rheumatoid.
I'm worried. Usually we try and do it as possible, you know. But 22 millimeter, you will not be able to do it.
Yes, yes. I measured it, sir.
It will not be possible because you require that much amount of.
Yes,
Once
otherwise-
the patella becomes thin, rheumatoid patient.
It's going to fracture, sir.
Very high.
Yes, sir.
The Vanguard knee is quite a good knee. There is no question.
Yes, sir. But the only thing is that I cannot use an augment or even a stem. No.
For
No,
the,
sir.
because of the implant design.
It is the implant design is like that.
Implant design. Otherwise, you would have preferred in this particular case, would have
yes,
preferred a stem. You have. Okay.
See, with this amount of defect, I thought I
Any
can
other
make it
questions
up
from
with
anybody? Any other questions?
screws.
Any other questions? Indruda, any questions? Any comments? Indruda, any questions, comments? Okay. So we get 3 important lessons from the master himself.
Yes, sir.
That number 1, if you get a radiolucent line around this area.
Not to
after
worry about
5
that.
years, 7 years, not to worry about that. Second is that it is a well done surgery. And third is that your screws should not touch the
The
Implant,
base plate
implant.
shouldn't touch.
Should
Yes,
not-
it was not. It was
Okay.
not touching. There was cement mantle. over
Okay,
it.
fine. Thank you, Subro, for
Thank you.
presenting nicely.
Thank-
And now we go to the other one. Anando, you are ready? Anando. You have to be. So this is a knee arthroscopy case, jointly done by, performed by Dr. Anando Mondal and Dr. Biplab Dolui. Anando will.
Actually,
face
I
you.
was not present in the case.
Oh, you were not. But you
Actually, I
are supposed-
don't know the case also.
Acha, okay,
Huh.
happens sometimes. So this is a 26-year-old male, 6 years old injury in soccer, recurrent giveaway. Patient tells that is a false with pain, medial pain and click. Frequency has increased recently, and this was the finding when we did the Latchman. So posterior, reverse Latchman was a positive. With some
Actually,
pain.
what I have heard, as Biplav is not present, I am
He is
here.
substituting Biplab.
I am substituting the Biplav here.
Yeah, do that. And this is the pivot. So how do you grade this pivot?
It is typically it is not the pivot shift is not positive here
Yeah, you see,
because
this is from the other side.
yeah. Yes, yes. Now
Now it
it
is
is now
positive.
it is positive.
Because of the change of the angle of the camera.
Yeah.
So it is a positive pivot shift with a positive anterior drawer with no end point, and it was also positive posterior latchman.
Yeah.
So I take that it was a case of ACL PCL.
No,
And
posterior
this is the
posterior door
intercondylar
also.
area of the MRI.
Yeah. Here we can see that on the tops.
You have a laser pointer.
Yeah. If we see this cut, we can see that on the posterior horn of the medial meniscus, there is a line which indicates that the medial
signal.
meniscus also was torn at the time. And here there is, we cannot identify the ACL here. Here we can see the upper part of the PCL is present, but there is injury at the PCL also. So we can see here that both the ACL and the PCL are torn in this patient.
So what have we gathered?
And also the medial
What we
meniscus.
heard from Biplab was that PLC was also lax. PLC, posterior
Yeah,
corner was also
posterior.
lax. And after stabilizing ACL, PCL, the
PLC,
the PLC became
yeah.
tight. So
Whereas
the-
fast test was
right.
acceptable.
So these are the other medial compartment pictures. So you can see the meniscus better.
Yeah.
Pass on to the
Axial cut.
axial cuts
Yeah.
and the coronal sections.
Yeah.
In the PLC area, there are no marked changes. There are no marked changes.
Yeah, yeah.
Okay.
There is no.
And this is the post-operative X-ray. So
Acha.
just explain the post-operative X-ray. You've
Yeah,
done
yeah.
lots, hundreds of cases. So just explain
So
that. to
This is the
juniors.
in AP X-ray we can see both the graft have been fixed with the loop here, either adjustable or fixed loop, what he may use. And there are two tunnels also here. This is ACL tunnel here, and this is the PCL tunnel here. So, and both the tibial graft have been fixed with the interference screw, bioobservable interference screw. So we cannot detect the screw properly in the X-ray, but there are two endo buttons, one on the outer surface of the medial condyle of the femur and one on the outer surface of the lateral condyle of the tibia.
Suppose you have done this case, such a case, you are satisfied with the X-ray findings, the tunnel positions, the sitting of the endo buttons, you are satisfied.
Yeah. I'm
And what would be
satisfied.
your post-operative protocol?
Actually, this
with
X-ray is not ideal lateral view.
It's not ideal.
Yeah.
lateral view. It's
So-
very difficult to have an ideal lateral view in the immediate post-operative
period.
Period.
Yeah.
That's why I prescribe my post-operative period that within anesthesia, this must be X-rayed and then sent to ward or whatever, cabin.
And if you say the postoperative protocol,
Mhm.
where there are two ligaments, ACL and PCL have been
ACL,
reconstructed,
PCL reconstructed.
and the medial meniscus have been
debrided,
repaired.
not fixed, meniscus debrided, not sutured, and PLC was reasonably okay at the.
Here the meniscus have been repaired, they said.
Okay.
Oh.
So repair means you have to delay everything.
Ah.
Suppose the meniscus was not repaired.
So for this reason, I will ask the patient to use brace for 3 weeks and non-weight bearing
Straight knee brace, immobilizer.
immobilized straight knee brace for 2 weeks, and after that we can use the ROM brace. Range of movement we can allow the patient to ROM brace.
How much?
And
Initially, how much?
initially 0 to 90 degree.
0 to 9.
And so when we usually reconstruct the PCL, we ask the patient to do knee bending exercises in prone position. Yeah, that the weight of the limb may stretch the graft of the PCL sometimes for that reason. And after
Is it assisted by the other limb?
Yeah.
Flexion in prone position.
Yes,
Anti-gravity
assisted by
or
other leg.
Assisted by the other limb.
Other leg.
Assisted.
Yeah.
Okay, fine. Any questions from anybody from the audience?
So 3 weeks rigid immobilization.
3 weeks rigid
Three-
immobilization.
3 weeks immobilization.
This is because of the meniscus repair.
Yeah.
Not for the ACL, PCL.
No, I was asking a
Act-
hypothetical question that meniscus was debrided, not repaired in that particular scenario.
If
Here,
the meniscus is repaired.
repaired,
then 3
so
weeks
obviously
rigid
he has-
immobilization
Yeah,
with ACL, PCL.
yeah.
Okay. Any other questions from the audience? No. So Ananda, thank you. Thank you very much. Subodip, please come over here. আমি দেখিয়ে দিচ্ছি সম্মদীপকে পাচ্ছি না because okay, I'll do that. Just give me a second. So this is a high tibial osteotomy case. Just a very simple pre and post-operative X-rays. Pre and post-operative X-rays. The surgery was performed by Dr. Anindya Sarkar and him, Dr. Subodip Mandal. Anindya is not here, so Subodip will face your questions.
So,
Any questions from anybody? You can start explaining anything.
actually, I am not the primary surgeon, so Anindya is not here.
We all know that.
So from Anindya, what I heard that first we have to draw the mechanical axis. It is from the tip of the hip joint to the mid of the ankle joint, and
You
the
have a
line.
laser pointer over there.
Yeah, and the line is just touching at the lateral tibial spine in a normal view, normal knee joint. So in this scenario, we are planning to make the axis in its actual position. So we plan a osteotomy. First step is to make a two entry point of the LRS, and
These two.
this do not, it's not the entry point. Entry point we should make with the two wear, and the wear should be as much anterior, and one wear should be as much anterior, and one wear should be at as much posterior, for to hold the proximal fragment firmly. And then we, and then we apply the, and then we introduce the proximal two screws, and the direction should be to the tip of the fibular head, and the line, it should be parallel to the upper tibial plateau. It
joint
should
line.
not be the
Should be
parallel to the joint line, but it should be parallel to the upper tibial plateau. And then we make the distal two entry, and make sure we don't advance the screw further because it's a if we withdraw it during operation or per operative, it may loosen. So we should cautious to introduce the screws up to the cortical level, not beyond it. Then we make the osteotomy. So we make the osteotomy, it's between the tibial tuberosity. It should be above the osteotomy side. So we should start our osteotomy from the medial side. It's an oblique osteotomy, and it should also direct towards the tip of the fibula head. And then it's not a complete osteotomy. We don't pierce the second cortex, and always we use osteotome, not the saw. And first we osteotome the anterior cortex, and then we osteotome the posterior cortex.
So it's a one plane osteotomy,
Yeah, one plane osteotomy.
solely made with osteotomes.
Solely with it's a curved osteotomes, and why it is curved? Because at the posterior, while we are cutting the posterior cortex, we should at least we should get touch with the bone, and not if we use straight osteotomy, it may goes beyond the.
Just after completion of the osteotomy,
Yeah.
then you fit the LRS, or it's pre-fitted
No, we already fixed the LRS before the osteotomy.
before the osteotomy. And after osteotomy, you do
After osteotomy, we then start distracting the fracture.
distracting the medial side.
Yeah, distract it up to that point where we get the actual mechanical axis. We check it with a maybe a diathermic cord from the anterior hip joint to the midpoint of the ankle, and in where the point is go through the lateral tibial spine, we just point and measure the
Fix that.
distractor measurement. There is a measurement over the distractor, and then we just note it, and then we get the osteotomy. Then we get the alignment as previous before the osteotomy position. After 7 days, then OT is done. The post-operative protocol is for 7 days, we don't do anything. And this osteotomy, it need hardly a 1 centimeter incision, a very small incision. And after 7 days, we'll start distracting. The last, in this case,
So it's
it
a
was.
kind of calotesis. It's
Yeah.
a kind of calotesis, early callus, but
Yeah.
calotesis.
Yeah. The last case, it was 28 millimeter distraction we will achieve for creating the joint normal. So every day we should make it 2 millimeter. Up to 14 days, we will distract 4 times a day, 180 degree by the Allen key. And it is very easy to demonstrate it to the patient. First 1 or 2 demonstration is enough for the rest of the days.
Then they will learn.
And we'll keep the LRS for at least 6 or 8 weeks. And in between, patient can move. We can move the patient. We can bend the knee. Patient can walk. All these things. And after 6 or 8 weeks, we will remove the LRS. And it's.
No more plasters, nothing, etc. So probably he has answered all the questions beforehand. If and other questions are also coming up in mind, Indroda, please.
Do you fracture the lateral cortex?
No, sir.
Does your osteotome penetrate the lateral cortex, or keeps short of the lateral cortex and then fractures it? Osteoclasis or osteotomy?
Has this fractured the lateral cortex?
Sir, I am not sure about this particular case, but it should not fracture the lateral cortex.
Actually, let us reduce the brightness a bit. Play
Just
with the
one thing
brightness
more.
contrast.
While you are doing the pre-op planning, will you like to have stress view so that how much correction laxity is there, because that will decide on number one thing. Moreover, you have to draw the proximal femoral angle, distal femoral angle, proximal tibial angle, so that the other tibia as well as femur may also contribute to the deformity.
How much hospital how much correction you require, and how much was operation correct?
No, I think it is not been distracted. I think Abhijit, it is not been distracted.
It's not distracted.
It will be distracted after 7 days, as already he has explained.
No, this is because of the view. You see the femur. It is because of the view. It is not because of the.
If it is a whole limb view, it would come the same. But we are just seeing the tibia mainly. That is why our
That's why it is
conception
looking
comes.
straight.
Yeah, yeah.
My question is what I think Subodhip was there. You were there in the surgery.
Yes, sir, I was assisting him.
So what was your plan of correction angle? It's 28-degree you told?
No, sir,
No,
it's not 28-degree. It is a measurement over the distractor. We distract the fracture, creating fracture up to the correct alignment, and then we note the measurement. So if we get it is 24 or 26 or 28, then we will keep in mind that it will take 28 millimeter to correct the alignment, correct the varus to or actual alignment. Then after 7 days, we will distract for that 28 millimeter each day. That means, I mean, 2 millimeter per day.
And total
It-
28 millimeter.
It will take 14 days.
No, that I understood. The question is that because 28 millimeter is the
Too
measurement
much.
that is the on the rod, that is on the.
Yes, sir. On the rod,
Obviously, it is like the same principle what we do in the Elisa rod.
Yes, sir.
The deformity correction.
Yes, sir.
That if you do 28, probably that will be like 14 millimeter on the tibia.
Yes, sir.
Okay. So I'm just asking how much is your correction angle pre of plan? How much of the varus deformity you are going to correct? What was the defect deformity angle?
Sir, only varus we can correct. I'm not sure we can correct it fully, but we try to align it with the mechanical axis as we are planning.
As because from this view, I don't know whether it is a standing scalograph or X-ray, whatever. But this angle
was
is
there
looking-
standing.
It was standing.
It
one.
was standing. The left one
Standing,
is
no, this one, the pre-op one.
Yes,
That
sir.
was a standing one.
standing.
So from there, it is looking like more than 15 degree. From
Looks
more
like.
than 15 degrees, so you have to correct, suppose another 7 degree to make it valgus. So it becomes like 20 degree. So I think this is I think we have to ask Indroda and all seniors whether by doing the LRS we are getting any sort of extra advantage other than using the.
Oh, let us
the
discuss
plate.
that at a later time. Okay,
Actually.
we have already overshoot
As it is
3-4 minutes.
As it is
Already overshoot 3-4
as it-
minutes.
On the lateral side. So when we are distracting, any distraction principles, the other side also to be held in position. Otherwise, there will be a lot of compression and combination on the medial, on the lateral side.
Lateral side.
So when gradually it is medial side is distracted and lateral side is to be maintained in its own position. Otherwise, it will be compressed and go together. Is it wanted or in this method, is there any scope of controlling that?
I think actually only there is some osteoplasticity in the lateral cortex. That's why there will be no compression. So if you do not fracture, there will be no compression. Because of osteoplasticity at the proximal metaphysis, it will allow deformation. There will be no compression.
15 seconds for
So that's the standard.
হ্যাঁ 15 সেকেন্ড ফর স্বর্ণেন্দু কি বলেছে স্বর্ণেন্দু কি দেখাবি দেখিয়ে দেখবেন হ্যাঁ ওদের কাছে দেখানো হচ্ছে তুই জায়গাটা দেখিয়ে দিয়েছিস কোন 15 সেকেন্ড আচ্ছা so this is the subscapularis stitch you are trying to show.
I think we'll run the video for 15 seconds. The white structure that you are seeing, that is the biceps tendon. That is the biceps tendon, the pointer to the So this is the bicep tendon, and this is the rotator interval. And I am putting the third anchor here, and you see, I will show you that. I think Indra was asking also. I am interacting with Indra. Why we are now? You see, I have just taken. This is there was no tissue. This is the number 5. I have recreated the anterior band of the IGHL. Can you see that? This is the new band now. So this is actually this is on the face of the glenoid. So this is the new IGHL anterior band. Then the axillary pouch has been shortened. This is the 6 o'clock. So I have taken the Y from 1 o'clock down, and this white structure is the anterior. This is the leading margin. What I think the Obijita was asking, Kunanda was asking. So now you see there is nothing in front of the subscap, no IGHL. So I have advanced this subscap on the front of the glenoid. Now the center of the humeral head is absolutely central to the glenoid.
Thank you, Swarnendu. So we are concluding this session, and the next session will start right now. Shomo is not here. Announce kore তাহলে এই ধরছি, হ্যাঁ দেখ কোনটাতে হচ্ছে, এখন হচ্ছে না, মাঝে সাজা হচ্ছে।
Good afternoon, everybody. We had a very good academic session since the morning. Now, I would like to start upon our spine session. I would.
This is a time for spine. I may request everyone to stay. I think we will be able to share a good quality academic endeavor with you. First, we'll start with guest lecture by Dr. Dilip Sengupta. I think every orthopedic surgeon in India knows him, but still, may I request Dr. Kunal Sengupta to introduce Sir Dr. Dilip Sengupta, and may I request Professor Chinmoy De, Professor Parthasarathi Sarkar, and Dr. Abrar Ahmed to take the chair as the chairpersons. So please.
This is very difficult task for me to introduce a genius person like Dilip Sengupta. Everybody knows what he is now, very, very big fellow. I'll just tell 2 or 3 words about a much, say 78, 79. Just listen to him. I was the senior house surgeon. He joined me as my intern. Just remember, 2 years junior. He taught me intrinsic plus and intrinsic minus deformities of the hand. And I was amazed to see an intern thinking how the intrinsics are working, what is their axis of work. I can swear nobody could think these things in internship. That was his geniusness. So I started associating with him for a long time. Then he became a big fella. I went to him at Nottingham, and there also, though he is 2 years junior to me, he treated me like a guest, very small age, always looking after me, whether I ate or not, taking food, what I am doing, everything. Now everybody knows what he is, the Dallas. He runs his own spine institute, doing fantastic spine job. Let us now listen to his lecture. So start on. Yes.
Thank you, Kunalda, for a very generous introduction. I would like to clarify, I cannot do a guest lecture because I am no guest to West Bengal Orthopedic Association. So Pratyushda asked me not to torture anything that Pratyushda will not be able to understand. So I'll try to keep it simple. So this is spine session. Here most of the audience belong to the spine discipline. And today my job is to explain how do I plan my surgery to correct a spine deformity. Now, this is little different between ankylosing spondylitis, where the entire spine, the global ankylosis, like from head to sacrum, nothing moves, which is very different from degenerative deformity, where the spine in the lumbar and thoracic spine may be deformed, but they can correct the head part of it. Now, always do surgery for them. Now, this person, you will agree with me, a terribly deformed lumbar spine. I was scheduling her for surgery, and then we do the visual analog scale and Oswestry disability scale, etc., to understand their pain, which is very little to justify any surgery whatsoever at all. And I cancel surgery. So do not always do surgery for them. I did this book chapter for orthopedic knowledge update in AAOS, or Academy publication, for the residents taking their board exam. And I will explain for the global ankylosis, ankylosing spondylitis. The problem is because they cannot correct the head, they cannot extend the head neck, so they have to roll their eyeball to look and talk to somebody in front, because it is not just the sagittal balance, but it is also the visual angle, which is very down. And they tend to sit down with their hips and knees to be able to look forward to talk to somebody. So that's a terrible problem. Now, they hide this problem of the neck and doesn't rotate by bending the knee. They will bend the knee and hip some so that they can lean backwards at the hip, extend the hip, bend the knee to look forward. And to understand what is the true nature of sagittal imbalance, you have to ask them to stand against a wall with the hip and knee almost touching the wall, and that will show you how much of sagittal imbalance the patient needs. And also we measure the chin-brow angle to estimate how much of visual angle should be corrected. Now, this patient has got a global problem, but you see the majority of the kyphosis in the upper thoracic spine, and that caused the visual angle much more difficult to make it correct. And I will tell you how to balance these two. Now, when you do an osteotomy in the spine to make an angular correction, doesn't matter where you do the osteotomy, higher, mid, or the lower part of the spine, but the angle of osteotomy is the same as the angle of visual angle that you can correct. So if it is a 30-degree angular osteotomy you made, the visual angle correction will also be 30 degrees. Doesn't matter where you made the osteotomy. But the shift of the plumb line, it depends on where you make the osteotomy. If it is lower down, the shift of the plumb line become much more, as opposed to if you make the osteotomy higher up. If you make the osteotomy lower, it will make the shift of plumb line a lot more effective, but the visual angle correction remains same. Now, if you make an osteotomy there and make a big osteotomy to make it corrected, then visual angle correction will be the same. So what will happen, say you have determined this is an adequate correction of the sagittal vertical axis, right? Now imagine you made the same osteotomy higher up in the thoracic spine, and now you have to make a bigger osteotomy to correct the sagittal axis. But that will make the person looking upwards and not looking down to the ground in front of him. And I'll show you a problem like that. So what I'm trying to say, that because the angle is the same as the visual angle correction, and if you make it too much of an angular correction, making it higher up in the spine, the patient will be looking upwards and not looking enough forward. Now, sometimes we make the planning by taking a tracing of the spine and cut this tracing paper and see where the osteotomy and what kind of angle you have to do to make an adequate correction. And that's a very age-old way of doing it. And we can do the osteotomy in two different ways. If you do a pedicle subtraction, you can correct a bigger chunk of bone. We usually do it in the lumbar spine, unless it is thoracic kyphosis. And that gives about 30 to 40 degrees of correction by one single osteotomy. Or you can do a smaller osteotomy at multiple level, and that is called polysegmental wedge osteotomy, or SPO. And that gives about 10 degrees correction at each level, but it's a smaller surgery compared to pedicle subtraction. And you can add it up with multiple segments to get some 40 degrees correction. So sometimes what we do, we make one big osteotomy at the bottom end to correct as much as we need. And then final correction we can do with the smaller osteotomies at the thoracic spine. And you can combine the two different kind of osteotomy to get a much more harmonious distraction. Now, this is one case that we actually published. It's a very unusual case. Patient had a big kyphotic deformity, global ankylosis, and the patient had originally an osteotomy there, but now the patient come with a much more bigger hump at the top end, and the visual angle needs to be corrected. Now, because we do not need much of the sagittal vertical, big kyphosis there, but the SVA or sagittal axis is more or less corrected. So we thought, let us do an osteotomy higher up, and that's what we did. And to do a higher up osteotomy about 30 degrees, make the patient looking upwards. And now you can see the patient cannot see in front of her feet. She cannot climb up or down the stairs because she cannot see the steps. So that was a terrible osteotomy. So what we had to do, another osteotomy in the cervical spine to bring the head down, which we rarely do. In the cervical spine, we do an extension osteotomy to correct a kyphosis. But here we had to do opposite. We had to do a flexion osteotomy of the cervical spine, which is very unique. No one ever done it or published it. So it was our publication where we corrected our own mistake. The other surgical crux is that keep the patient position on the table, we bend the table and keep the hump of the kyphosis, whether it is thoracic or lumbar, opposite the maximum bend of the table, so that after osteotomy, you make the table straight, and that will make the osteoclasis to make the spine straight. So if you have a patient where the hump of the kyphosis is lowered down, to position the patient accordingly, so that after osteotomy, you make the table straight, and that will close the osteotomy gap. When it is terrible global kyphotic deformity, the entire spine all the way to the head become like a U, then it is anybody's guess how will you position the patient. Now, how much of lordosis should be corrected? You have the knife, you can cut anywhere you like to do, but there is a measurement that how much you do. What happens if you understand the loss of sagittal balance, where the patient is leaning forward, they will rotate the pelvis backward. I'm sure everybody, at least the spine surgeon, know the lumbar lordosis and the pelvic incidence and sagittal vertical axis and thoracic kyphosis. We all expected to know that. And now what happens? So this is a normal spine. And if the spine become kyphotic, leaning forward, then because they cannot correct the spine itself, so they will rotate the pelvis backward. So, and that will correct the sagittal vertical axis. Now the spine SVA is going to the ideal spot. But as they rotate the pelvis backwards, what happens? The sacral slope, this is the normal sacral slope, that becomes smaller, and the pelvic tilt, is it's tilted backwards, that pelvic tilt is increased. So sacral slope becomes smaller, but the pelvic tilt, which was small to begin with, at least less than 20 degrees, now it can be about 30 degrees, 40 degrees or so. So you have to understand that how much patient is correcting by himself or herself, and you have to take it into consideration, because once you do the lumbar osteotomy, patient should be able to rotate the pelvis, undo it, or back to its normal position and still achieve an upright posture, so that they do not consume extra energy to be able to stand up. And how much we correct, because pelvic incidence is fixed. Say someone has 55 or 60 degrees of PI, that is fixed for their life. But the lumbar lordosis is diseased, and that normally have a 40-degree lordosis. Now it has got a 10-degree kyphosis, so 50 degrees of loss. So how much should we correct the lumbar lordosis? And Frank Schwab did a calculation, and he said, if you know the pelvic incidence and you measure it, then the lumbar lordosis will be pelvic incidence plus 9 degrees. So that much of lordosis you should be creating. Meaning, say this is the kyphotic posture, you make an osteotomy, and then you correct the patient's lumbar lordosis, and from the pelvic incidence you calculate how much weight you need to take out to get the desired lumbar lordosis, which should be pelvic incidence plus 9 degrees. Now, deformity correction in degenerative scoliosis is very different, because the neck can extend. Like this patient has more loss of sagittal vertical axis, but can look forward because the neck can rotate. But in an ankylosing, it doesn't. That's a big difference out there. I did a book chapter in this Professor Yang and Boachi's book on proximal and distal junctional problem, because that is the problem when you do in a degenerative deformity. The proximal junctional kyphosis is less symptomatic, and distal junctional kyphosis is more common and more symptomatic. And the failure can happen in the intervening segment, not at the top and bottom, but in the middle. The rod can break if the fusion doesn't happen well. So let us deal with the proximal junctional kyphosis. The osteoporosis is a common factor. It can cause failure at the top end, bottom end, in the middle, wherever. But more specific factors are either you overcorrect or undercorrect. That will lead to junctional problem, proximal and distal, more often proximal. And the upper instrumented vertebra, meaning the upper end of the vertebra, whether it is T6 or T9 or T10, the further away it is from the sagittal vertical axis, more chances that the proximal junctional kyphosis will happen. I'll show you some example. This is osteoporotic spine. We did all the instrumentation like the top end screws are pointing down. We had a hook, all those things so that the hardware doesn't fail. But even if you can ensure your hardware will stay with the spine itself can break in presence of osteoporosis. And we had to do surgery again. Even if you do a caudally directed screw, as opposed to screws parallel to the vertebral end plate, that is better to prevent proximal junctional failure. But even that can fail and it can become loose. If you undercorrect like this, that can cause the hardware failure and may need further surgery to correct it later on. If you do the overcorrection like here, the patient didn't need much correction, but they did an overcorrection, and that caused the proximal junctional kyphosis that later on needed surgery out there. This is a terrible mistake if you go higher up, close to T3 or higher up, and that's where you end with your instruments, particularly in elderly. They cause more dislocation and can cause neurologic deficit in this patient. And this patient needed 2 years' time to correct their neurologic deficit. So in general, all these points we have discussed, and specific factors to prevent PJK is do not stop at thoracolumbar junction. Do not stop at the apex of kyphosis, either stop below or above the apex of kyphosis, and avoid taking the instrumentation in upper thoracic spine because any neurologic deficit is much more dangerous. Distal junctional failure is more common. It can fail at the bone or disc, or it can fail at the hardware. And I have already discussed these yesterday's talk, and you have already listened to those, so I will quickly go through it. And like here, the sacral fracture, in the previous case that you have seen, the L5 pedicle screw cutting out of the bone. And these distal junctional failure are a lot more symptomatic. Here, this sacral screws pulling out, so we had to go down to pelvis. And sometimes you go to pelvis ahead of time, and even the pelvic screw can break, and you have to redo it. So distal junctional failure, to prevent it, you have to have at least 6 good fixation, 2 screws at L5, 2 at S1, and 2 at pelvis. Anterior column support like an interbody at lumbosacral junction, pelvic fixation, and restore adequately the sagittal balance. And certainly achieve a solid fusion to prevent failure at the proximal or at the distal end. Thank you for your attention.
Thank you, Nilibda. Only one question. In a Young patient with the fused hips and flexion contracture of the hip, should you do the hip surgery first or the spine surgery?
This is a debate that almost never gotten resolved, but the question have been raised endlessly. And we usually refer the patient across. The hip surgeon or the spine surgeon will refer the patient to obtain the opinion. But in general, majority of the people think that spine should be done first before the hip, because it increases the hip dislocation after hip replacement, and they cannot do adequate therapy. Even I took my, we have to take our board exam in part every year. So the last year board exam, we were given some selected article, and one of the article was dealing with this, hip first or the spine first in ankylosis of the hip and spine both. And the overall sense in that article was also, they do the spine first, because there is nothing to dislocate, although it is difficult with presence of the hip, and do hip later so that the hip arthroplasty doesn't get into dislocation or other complication.
Calculation of the osteotomy will be different.
It will be very different. Yes, it will be different. If you know that you are going to do a hip replacement, then you will know the hip will be able to move, but you do not want the patient to retrovert the pelvis at the hip to correct their spine. But you have the calculation of pelvic incidence, regardless of hip or ankylosed or not. Center of the hip joint is in the same place in pelvis, and you can measure pelvic incidence. And if you know pelvic incidence is 40 degrees, and my lumbar lordosis should be 50 degrees. And if the lumbar kyphosis is 10 degrees, meaning you have to do a 60-degree correction. You cannot do it at one osteotomy. So do a 40-degree pedicle subtraction in lumbar spine and do another 20-degree by 4 or 3 small osteotomy in the thoracic spine. That's how you calculate.
Sir, I have a question. Like the same question which sir has asked, like if we have an ankylosed hip, both the hip are ankylosed with
Yes.
angstpond, and he has a FFD type FFD also. So doing the hip first, will it not allow the patient to have an external rotated pelvis? I know the fact that it may dislocate anteriorly. I will keep the cup close anteriorly. If the patient externally rotate the pelvis, then also many of the angles will get corrected because of the external rotated hip. And I think after that, correcting the spine will reduce the level of correction which we do in the spine. Is it the new concept or is it the false notion?
Thank you for asking the question, but there is most part you have understood the subject correct, except the last part of it. What I was trying to say, that you are saying if I make the hip mobile, then patient can retrovert the pelvis on the mobile hip to be able to stand erect. But the problem is, although patient will be standing erect, just by constantly retroverting the pelvis on the hip, they will have to consume more energy. So the pain or the discomfort will continue. The idea of correcting spinal deformity is that the patient can be able to stand erect without retroverting the pelvis. But you understand what I said.
Yeah.
So idea is not to give a hip that they will retrovert it, but you have to give them hip and spine so that they do not need to retrovert the pelvis. Okay? But your first part of the understanding is correct, that if the person has got not a big amount of spinal deformity, but has some loss of lumbar lordosis, say only 10 degrees of lordosis instead of 40 degrees.
Then we can do the hip first and then we can already correct it without.
No, the question is, spinal osteotomy is a big surgery. Hip is also a big surgery if you do both hip. So you can say, hey, if I do the spine first, only 10 degrees of loss, 30-degree loss of lumbar lordosis. And I cannot really know how much of sagittal vertical axis will be changing. So why do the spine first? Because if I do the hip, and once the hip is corrected, the patient may not have enough symptom, although theoretically they may have symptom, but they may not. And the patient at that time, after enjoying the hip is corrected, then they can decide whether they will buy the spine surgery or not, rather than doing the spine first.
May I
Does that
request
answer?
others to, if you have questions, please discuss in the. in
Okay,
between
thank
the
you.
sessions.
Thank you, sir.
Sure. Thank you very much.
So I thank Dr. Dilip Sengupta for enlightening us with this topic, very enlightening and learning topic. The next part of the session will be 3 lectures on different problematic topics and corresponding case discussions. The chairpersons of the session are Dr. Kunal Sengupta and Dr. Dinesh Jaswal. Please, Dr. Kunal Sengupta, please wait at this.
Hello. I'm requesting Dr. Kiran Mukherjee to give his lecture on post-operative discitis, how to manage it.
Good afternoon, chairpersons and the learned audience.
It's very difficult to talk after the master's lecture. It's very difficult. So my talk is on post-op discitis, which is not very uncommon. And I will try to make it as simple as possible. So discitis is an infection and inflammation of the intravertebral disc. So these are the defined stages of discitis after the bacteria lodged inside the disc. So at 2 weeks, there is immature granulation tissue and neovascularization. After 3 weeks, usually there is a granulation tissue and the vascularity increases. And at around 6 weeks, there is a opposing new bone formation, and as well as granulation tissues are seen around the disc. So most of the most common cause of this discitis is the direct inoculation, but there are some heterogeneous spread and there may be some spread of infection from adjacent site. And it has been found that the most of the cases, the causative organism is Staph aureus, and others are Staph epidermidis, gram-negative organism, and also anaerobes. This is the classification of these spinal infections, but we are talking on post-op discitis only, which is mostly caused by Staph aureus. The common sources are skin, GI tract, genitourinary tract, and respiratory tract. But 1/3 of the patients, the source of infection is unknown in all discitis. The typical history is usually a severe recurrent back pain after the initial relief of symptoms following a surgery. So the duration of the postoperative pain relief period is variable, ranging between a few days to 10 weeks after surgery. So the delay in diagnosis may be because of the thought of the physician that the symptoms may be due to recurrent disc herniation, or there may be unsatisfactory outcome surgery due to psychoneurotic disorders of the patient. The early and accurate diagnosis frequently depends on a combination of mainly clinical, laboratory, and also imaging findings. The diagnosis is strongly suggested by persistent elevated ESR and CRP, and there are typical changes in the MOD. Postoperative rise in CRP is usually common, but it comes down by about 10 days, while ESR takes about 3 to 6 weeks to come down. Hence, unexplained rise in CRP values anytime beyond 2 weeks of surgery should be viewed with suspicion. But the key to accurate and early diagnosis of postoperative discitis is the strong clinical suspicion. The plain radiography is insensitive to the early changes of discitis or osteomyelitis, with normal appearance being maintained for up to 2 to 4 weeks. In conventional radiography, if it is present, there will be narrowing and destruction of an intervertebral disc. There will be indistinctness of adjacent end plates with destruction, paravertebral soft tissue mass, end plate sclerosis, but this is during healing phase, beginning anywhere from 8 weeks to 8 months after onset. And there may be bony fusion, which will be seen after 6 months to 2 years of the discitis. In a CT scan, there may be anterior paravertebral soft tissue swelling with obliteration of paravertebral fat planes. There may be fragmentation of urocents of vertebral end plates and paravertebral fluid collection. There is a small abscess. MRI is most distinctive. There is a decreased marrow density on T1 weighted images in 2 contagious vertebra, high signal intensity on T2, and because of the associated edema, disc spaces and the paravertebral soft tissue enhance on contrast MRI. And the mainstay of the treatment of the discitis is a combination of immobilization of motion segment, prolonged administration of antibiotics. Surgical intervention is occasionally necessary in patients failing conservative treatment and or deformity correction if there is any. So the duration of the medical therapy is variable. 6 weeks of intravenous antibiotics followed by an additional 6 weeks of oral antibiotics is a course commonly administered. So after taking the tissue sample, we should start broad spectrum IV antibiotic. After bacteriological diagnosis, we should change the antibiotic accordingly. At least 6 weeks of IV antibiotics monitored by inflammatory markers with general response to treatment, which are clinical radiological, should be done. Depending upon the response, IV antibiotic may be continued, changed, discontinued, or replaced by oral antibiotic for a variable period, typically for 6 to 8 weeks. So the indication for the surgical intervention is post-op discitis is significant bony destruction, abscess formation, deformity if any, increasing neurodeficit or onset of quad equina, failure of non-operative treatment to relieve pain and spasm, and failure to control infection. The options are debridement and evacuation of abscess and instrumental stabilization. So literature supports that the minimally invasive fixation is now a feasible and effective technique to achieve immediate pain relief, and it can avoid long-term immobilization and overcome the disadvantages of a dorsoventral procedure in adult pyogenic discitis. So a high index of suspicion, unexplained pain after 1 to 6 weeks of surgery, persistently raised CRP, corroborative X-ray, MRI or CT features are the important parameters for the diagnosis of the post-op discitis. Rest and aggressive antibiotic therapy, intravenous for 3 to 6 weeks, followed by oral for next 3 to 6 weeks should be the mainstay of therapy and is successful in most of the cases. Following failure of conservative therapy of at least 3 weeks, surgical option is worth considering. Careful re-exploration, debridement, and transpedicular fixation and postolateral fusion is usually sufficient, and spontaneous interbody fusion is the natural outcome within a year usually. But these are the precautions. Be careful regarding theater sterility, because most of the cases there is direct inoculation is the main cause of the postoperative discitis. Be careful regarding the sterility of instruments and start period and antibiotic, and don't scrap the end plates while doing a discectomy. Thank you.
And just a minute. Sir, our next topic of discussion is the same, actually. So I will suggest that we'll take the presentation in panel discussion, then we'll discuss the questions.
Okay, thank you.
Yeah. So Divyanshu, please call upon the panelist.
This topic will continue. So we'll have our panelists on the stage, and then we'll have a discussion among the panelists, and we can also invite questions from the floor. I would like to call upon our panelist, Dilip sir. Kiran sir, please kindly be on stage. Dilip sir. Dinesh sir is already there. Saikat sir. Abhishek sir. Please come up to the stage. And Kunal sir, please stay back on the stage.
Divyanshu, your topic is open now.
Yes. Thank you, sir. So my topic of discussion will be post-operative discitis, which has already been discussed by Kiran sir. I would like to start this topic not as a post-operative discitis, but let us discuss as something which you don't know. Like I'll present the case as a case discussion, and then we'll start to discuss about what comes in mind and everything. Is it? It's not coming on the screen. Excuse me. It's not coming on the screen. Yeah. Thank you. So the patient was a 60-year-old female. She had comorbidities like hypertension, diabetes, ischemic heart disease, bronchial asthma. She came to us with back pain and radiculopathy. So this is the radiology before X-ray. Before the surgery. I'd like to show the parietal image where we can see the lumbar canal stenosis at L4, L5 and signal change and degenerative disc changes. So laminectomy and with decompression at L4, L5 and L5S1 was done outside in October, and radiculopathy relieved. She had a pain-free symptom, a pain-free interval. Again, she came after 1 month with severe back pain and stiffness. She was unable to stand. There was difficulty for her to, turn on the bed. She has no fever, but yeah, patient was looking not well. She was ill. There was also loss of appetite. On examination, the operative site was okay. The back movements were completely lost. It was complete rigid. Neurology was okay. Tenderness was there, and there was also midline gap at L4, L5. SLR on the left side was up to 70 degree, and on the right side was 70, and the left side was 50. The blood parameters, we have ESR 98 was there, TLC total leukocyte count 11,000, and CRP was 63, which is quite high. So from here, let's start what comes in our mind. Like if knowing all these factors, all these histories and pre-op X-rays and what was done, so what comes in our mind? Saikat sir. No, there was wound was not gaping on palpation. We cannot identify the spinous process and for a midline gap.
Very much evident in post-op X-ray also that whether spinous process is removed or not. As you have already mentioned that it was
laminectomy was
so there is the wound apparently looks well. but there is signs of inflammation or something because the all over the lower back is very stiff and paraspinal muscle spasm is there. On top of that, there is all the inflammatory markers.
Yes, it was
that is
raised.
CRP, yes, are elevated. Though no history of fever or something, no?
Yeah, there's no fever.
No fever. So definitely some infection is going on.
Okay,
That
the
much we can tell.
first from the panel we got, there might be some SSI, surgical site infection. Anything else which comes to in DD, what else can we think of?
I will ask like Saikat, why in the first time it comes in your mind that should be infection? It may be something else because count is 11.
It was 1 month post-op. She came again in December. It was done in October, more or less 1 month gap.
And local site is inflamed.
No, there was not as such signs of inflammation. Like what you are thinking of reddening and other things,
Only
it was not there.
stiffness.
Yeah, it was severe stiffness.
Severe stiffness.
Was there any night fever or?
No, sir, there was no as such night cries or something, any constitutional symptoms apart from loss of appetite. More or less, I would like to say she was not looking well as a whole. No.
So what you are asking that the patient has malaise and back pain 4 weeks down the road with the inflammatory markers high, but no frank pus coming out through the wound and no fever. But patient has diabetes and other comorbidities. And you are asking what are the differential diagnosis?
Yeah, what else we can think of? I know this is a session. The question is already out, but
It's 4 weeks post-op and patient comes back after initial pain relief. And patient comes back. It could be a hardware failure. It could be adjacent segment. It could be a recurrent disc herniation. Or you can have other sources like your DVT, not too uncommon. Patients not mobilizing well at 4 weeks. They can have a chest infection, UTI, and all those things in presence of diabetic and
other comorbidities.
conditions. The fever is not always the first thing to come out.
In female patient, maybe some gynae problem or trying problem.
Yeah, that's
The imaging studies at this stage.
so from all this history and the things we got, like there can be recurrent disc. One can be the topic itself, the postoperative discitis. There can be other problems, and with that we can have SSI, which Saikat sir told, and we can have other options, gynecological problems and all. So what I want to say is keep a pain-free interval and the patient coming up. These all things can be there. Though this topic is postoperative discitis, so obviously the patient had postoperative discitis. So this was the X-ray after the first surgery. We can easily see the there is a haziness in the end plates in L4, L5 and L5S1. This was the MR done after the surgery, which shows signal change at L4, L5, L5S1. There was contrast MR also done. L4, L5 and L5S1 shows homogeneous uptake, signal change.
Dibanshu,
yes, sir.
Just one clarification. When you have told that what surgery he has undergone, you have told that some fixation.
There was no fixation. This was only laminectomy done.
Only decompression.
Yes.
That's laminectomy.
Laminectomy and
But you have not
decompression.
told about discectomy. This space
It
was
was done.
untouched.
It was done. It was done.
Yeah, Divanshu.
Discectomy was done.
Divanshu,
without instrument.
Laminectomy, decompression and
just a
discectomy.
comment
Yes,
in
sir.
post-op
Laminectomy with decompression.
And discectomy was done.
post-op discitis. In
Discectomy
post-op discitis, pain is the main symptom with
Yeah.
spasm,
And
but
stiffness.
usually total count is not high, and there is no fever. Usually there is no fever, and the total count is usually within limit or just slightly raised. But the CRP is high, and there is usually fever, no fever. So
Yes,
this is the
she
typical
didn't
history.
have fever.
This is the typical history of a post-op discitis after a certain pain-free period.
Pain-free period and then coming up with all this mark.
Experiences severe pain, crossing over the bed also. They cannot roll over also, but there is no fever and TLC is not high.
My one.
No
question.
neurodepressant.
Just my one question.
Sir.
The MRI changes you are talking.
Yes, sir.
After discectomy,
Yeah.
obviously there may be some infection cannot. It is not specific for infection. Is it always specific for infection?
No, sir. It's this signal change is not specific for infection, but that
It may also occur even over
inflammation.
That's
But we did an contrast MRI because as we have seen from the lecture of Kiran sir, there is an active granulation tissue going on in the paradiscal space. So if there is an active inflammation, there will be uptake. So this is what MRI, contrast MRI shows a homogeneous change in the disc and paradiscal area.
Maybe of overtype or cover type. Cover type, when there is a low incidence of infection, there should be all the symptoms that Kiranda has told that will. But if there is fulminant infection, if there is some overt infection, then the symptoms will be different. There will be fever and all the signs of inflammation and infection will be there.
So I think it is a very valid question as he raised, that 4 weeks post-op, repeating the MRI scan is very difficult to read because it will always show high signal intensity in star images and T2 images. And it's very difficult to identify whether
it's an infection going on.
But did you do any other imaging than X-ray and MRI scan? What else did you do?
Oh, we didn't do anything else. sir.
One minute, Dipansh. Sir,
With the abscess, the MRI scan can overread things. I mean, if you do
can
an
overread.
MRI scan 4 weeks, even in a patient uncomplicated, you may see almost similar kind of.
But sir, the signal changes in the adjacent vertebral body.
That may happen post-op also.
no,
Post-op
sir,
is
sir, about that changes, as you mentioned. Sir, the post-operative changes at about 1 month are definitely there, but I actually spoke with the radiologist at that time. So one thing is like, the question is whether we should get an MRI done at 4 weeks. Probably with the onset of symptoms like the way that was mentioned, with a hike in the inflammatory markers, and MRI is warranted. Now,
What else can you do?
yes, sir. So, but even then,
You've
like.
done ESR, X-ray and MRI. What else?
Yes, sir.
can you do?
So a serous or a serosanguinous collection at that juncture probably cannot be properly discernible separately from a post-op edema in a case of infection, but a frank pus, the radiologists are generally able to comment upon. So in case we find those debris matters, I mean, like, those necrotic tissues there, which they actually look for, or frank pus, which can be separately made out. In case those are present, we are very sure, like, okay, this is a discitis rather than a post-operative.
We can opt for PET CT sort of.
You can do the CT scan also, which may show erosion of the vertebral end plates, and definitely you have to do a biopsy. Without that, you cannot diagnose. You have to do a biopsy.
That's what I was trying to point at, because you have mentioned about clinical parameters, plain X-ray, and then went to MRI with gadolinium. But you have jumped one stage as CT scan, which is a lot more helpful to see if there is something concerning local. It might show if it is a discitis with bone destruction, which may not happen within 4 weeks, you may not see the bone destruction. But if there is collection of fluid, you cannot say it is abscess, but it might be able to see that collection of fluid much more clearly than what MRI scan.
And sir, also series guided aspiration can be done at the same sitting.
That comes next. If you find some fluid collection, the radiologist will say there is abnormal fluid collection. And the surgeon will have to think that how much fluid collection you anticipate, and is it too much, and shall I open it up or put an needle?
What you did next?
So is the messages that a CT scan at 4 weeks will be more helpful than an MRI?
MRI scan, yes. So don't skip CT scan to jump into MRI. Just do MRI scan in another patient who do not have infection. You will find almost similar picture. It is not easy to differentiate. You can argue whatever, but it's not quite easy to differentiate in an MRI scan unless it is 6 weeks down the road when normal post-op inflammation tends to settle down. 3 to 4 weeks MRI is bad, difficult to read.
Okay, sir.
We still do MRI scan to see some degree of neurological compression, and you have to struggle to see it. Say an interbody cage displaced or recurrent disc herniation causing nerve root compression. You do an MRI scan, but it's very difficult to read 3 to 4 weeks post-op.
Sir, can I say something? This was my case. I did it in 2011. It was the case of 2011. It was actually 2 months post-op. It was December.
It was 2 months.
2 months post-op.
Not 4 weeks.
No. The patient came to me in July, I think. I have sent him for center for conservative therapy. Then she got a surgery outside, some other surgeon, and came back in December. From October to December, so it's 2 months. And I did a CT guided aspiration, but I didn't have picture because I have lost the records. Partially records are lost, and it retrieved these things. So CT guided aspiration shows there is pus. I got the culture report. Culture report shows terrible. It was Acinetobacter, which is only happens in postoperative infections, hospital-acquired infection. It was very resistant to all other antibiotics except colistin and TG-cycline.
You have taken all the charm away. He was presenting it nicely.
What did you need?
So the next step we went on to anterior discectomy, retroperitoneal approach at both L5 S1 level. And then this was the post-op X-ray. And the histopath showed no granulomatous lesion against TB infection. The tissue culture showed, as sir already mentioned, Acinetobacter, which was only sensitive to recyclin and colistin. IV was given for 3 weeks. Back pain reduced in a VAS score of 1 out of 10. CRP reduced to, ESR reduced to. And then on third post-op day, she was ambulated and she was doing all well.
One thing I don't agree that CRP goes down to so normalcy after 3 weeks in these cases. Even if the infection is controlled, CRP remains high for long period. This I have got a lot of experience.
Why
In
the-
any infection, not
Why
only
is the first time you went for operation directly?
Right from the front. Why not from the back?
No, why operation in the first time? Why not tried conservatively giving antibiotic for few days?
If it is Acinetobacter, conservative only IV won't work. You have to take out.
He knows the culture, he knows the antibiotic. They should be give a trial.
You have to debride. Acinetobacter, you cannot depend only on the antibiotics. You have to take it, even in long bones, whatever.
The problem from the front is that whenever you go from the front, in L4, L5.
No, that was step, you may wait, but even, I'm not talking of spine. Any long bones anywhere where you get these types of infection, thorough surgical decompression and debridement is a must.
No, we are trying to get the principle. That is if we encounter such discitis on the, say, I think after just onset of the disease, they have picked it up. And after that, they also know the causative organism, also the sensitivity. Then whether we shall go for IV antibiotics or the day one, it will be a surgical thing. Irrespective, whether it is for the treatment changes for Acinetobacter or Staph aureus, is there any guideline for that?
Sorry, what is the question?
Highly sensitive, okay, you can wait. But I don't know, Dilip, how much the experience they have got with all these bugs. This Acinetobacter is, if you go on giving tetracycline, he has to sell his house, he has to sell his everything. You have to debride it.
Kunalda, it's not the question of Acinetobacter. The question is that whether when we know the pathology, when we know the culture, and we know what antibiotic acts upon it, why should not we give a trial of antibiotic?
No, say the standard common things, okay.
No, there is a difference between the discitis and osteomyelitis. Once it is involving the bone, there are very few antibiotics which penetrate the disc region. You have to do the debridement then.
That's that.
So there are very few antibiotics which can reach from the bone to the disc. Because disc is a vascular structure. There is infection there and that is spreading to the bone.
Absolutely agreed with you.
When the patient coming to you with so much of pain, you have to take it granted he has started osteomyelitis also. It's no more just discitis.
As Kunal said, actually for control of infection, the general principle, not for the spine or disc. So general principle is, it is chronic infection is always resistant to the drugs. It is because of the biofilm formation. So in that case, the general principle is the surgical approach is the main approach assisted with the suitable antibiotic. That is the general principle believed in all disciplines of orthopedics.
So regarding all this discussion, I would like to have one question only. Like there are total two disciplines talking about, one giving a trial of antibiotic and one going into directly into debridement. This discitis, whatever be the organism, it is said to have 4 to 6 weeks of IV antibiotics and then going on to the oral. Will the patient of such a back pain and stiffness, will she, should we go for a trial of 4 to 6 weeks of IV antibiotic and then go debridement?
That is after drainage.
There are two issues. One is if you start the antibiotic within 2 weeks. Within 2 weeks of the infection, then the result is very good with the IV antibiotics. Once it is already two months and then you again start the 6-week antibiotic, results are not that good.
So in
After 2 months, you should do
so it's a suggestion, like in this particular case, if we are getting a case after 4 or 6 weeks, then we should directly go into debridement and then.
Why you want to wait for another 6 weeks? It is 6 weeks of antibiotic.
Dr. Ahmed, This,
You have to check the serial CRP and ESR. If that is coming down, then you can continue with that thing.
Doctor,
Second is the biochemical markers and the clinical condition of the patient. If the patient is comfortable after starting the IV antibiotics, CRP is coming down, then you can continue with that thing. But it's already 6 weeks or more than 2 months, and the CRP is rising, and the biopsy is the acinovector, is a hospital-acquired infection. It's very difficult to treat by IV antibiotic alone.
so Dr. Ahmadi, this patient has been rightly debrided and implanted. So how many days of antibiotic will give after this debridement and?
So she was given 3 weeks of antibiotic, 2 weeks institutional and 1 week other than institute.
Now why it was done anteriorly? So my question.
Back I did a case, similar case from the front. And once you go in the front, there's a lot of adhesions between the vessels, vascular structure, and the discs. And there was a tear of the renal vessels there. And the patient lost around 15, required around 15 units of blood. It was taken care by the city-based surgeon. The extensive adhesions there. Why you want to go from the front? In the presence of disc infection? That's my question.
Sir, is it?
If you go from the back, you
It's
can,
much more safer to go from the back side.
Yeah, it is safer. It was safer from the back, but from the back, we can only debride 20 to 30% of the disc. Otherwise, it is difficult. Why I choose from the front? Because it was a very resistant infection, and I have spoken to the vascular surgeon whether they are comfortable with access from the back or not. And then with the help of the access surgeon, I went from back, from front, and then I debrided L5S, L4, L5 and L5S1 disc space thoroughly. I put bone grafts in both the levels. Initially, I didn't decide to put a plate. I kept the plate at for backup, but L5S1 bone graft was coming out. That is why I have put that time Synthesis didn't have, or any other didn't have any anterior plate system, good anterior plate system available. So I had put a cervical plate at L5S1 to put the graft in. I have put a graft in L4, L5 as well, and thoroughly debrided. The patient came back after 3 years. Last night I have seen the follow-up prescription. 3 years, after the 3 years, and patient was well with a thorough fusion with both the two levels. And infection was.
May I request Dr. Amitabh Biswas, I am seeing him. He presented a series of cases of discitis and also published, I think, and they have done on the minimally invasive technique and debridement too.
Our experience is all this discitis, the first and foremost mandatory, we have to have a stamp of evidence of the infection. Now, this is the most difficult part. And possibly I agree with Chinmay that there are a lot of ways to take the biopsy. And I personally take the CT guided biopsy by myself with the FNAC gun. I take, if there is a liquid pus floating around, then it's a no-brainer. You just put a needle and never take a swab. I would like to tell the juniors, never take a swab. Even if the pus is pouring out, never take a swab and send it for culture. It will always misguide you. It's always a commensal, some contaminant or anything. So if the patient comes with a boggy swelling full of pus inside, which is not always true, as we know in discitis, like this situation. If it is like that, you just put a needle inside, a long needle, spinal needle, take an aspirate, even in the ER, and send it for culture. If the culture comes positive, we don't wait for antibiotics. We straight away go for debridement, because we believe debridement is not the only job. Debridement is going to decrease the disease burden.
It does debulking.
It's going to decrease your disease load. That's it. It's not the end of it. So we have a culture stamp, and you start the IV antibiotics for 6 weeks oral, and you do the debridement to decrease the load of the infection.
Sir, but literature says there is
one spectrum of the infection. The other spectrum of infection is what you presented. There is no pus, no swelling, no signs of inflammation local site, only markers elevated, and you have a suspicion. So again, most important thing is prove it by a CT guided. You can take a CT guided biopsy even from the bone. You can take a small sample of FNAB. You can take a sample from the disc space. You can take a sample from any collection which you can see in the MRI, and straight away go localize it with 3 mm, 1 mm cuts in the CT. Get an accurate biopsy. Try to take it out. If you fail to do that, then I am forced to take a percutaneous under local or GA in the OT. a biopsy.
Can you comment anything about the surgical approach? That is his
The surgical part in this sort of second sort of situation where there is no implant in situ, only a discitis to begin with after a discectomy, no implants. We have a series of say 42 patients where we have done just a single segment percutaneous fixation from the back. We have not even opened the site. We have taken biopsy and started on antibiotics, and we've got excellent results. We have published that. So we have not debrided. There were sort of cases like this, no frank pass, only end plate changes, marrow changes. We just did a percut fixation from the back and a percutaneous C-arm guided biopsy with the help of kyphoplastic cannula, which we have again published. With the kyphoplastic cannula, through the working channel, we can take through the small disc forceps, we can take the biopsy and start the antibiotics with the in situ fixation.
Thank you, Dr. Vishwas. Thank you very much. So we will have to conclude this lecture, and our next case is dural tear. I'll request Dr. Chinmanath to come with his lecture and for the next case, the panelists have got Abrar Ahmed and Dr. I'll request you to sit. All the panelists can sit. Abhishek, you can also come. Dr. Abrar Ahmed. Okay.
Thank you very much, and good afternoon to all my seniors, my colleagues, and my juniors. Let us discuss a topic which the spine surgeons and orthopedic surgeons and neurosurgeons may face in their lifetime at least once or twice, but not discussed regularly. That is dural tear. Now, what is dural tear? It is not the planned dural opening for interdural procedures. It is an incidental durotomy, either due to trauma or the iatrogenic injury. A traumatic dural injury may be caused in burst fractures or fracture lamina, especially the green stick fractures of the lamina, which is incidence is high. An iatrogenic dural tear that may happen during spine surgery or the invasive extradural procedures, those are not regularly addressed. That is, epidural injections may cause percutaneous adenolysis, nucleolysis, etc., which are done by the trained physicians. So dural tear can be accompanied by neuro deficit in case of avulsion of the nerve roots and entrapment of the neural elements in fracture site. And there are some surgeries where we should anticipate dural tear. Those are anterior surgery for OPLL, spinal osteotomies like PSO, surgery for multi-level CVL lumbar canal stenosis, discectomy for central or extruded disc, re-exploration or revision surgery, post-radiation spinal surgery. And these are the incidents of dural tear in different surgeries. The anterior surgery for OPLL is one of the most. PSO is the next following. There are different kinds of the results of dural tear. Maybe low morbidity in case of younger patients, and lumbar discectomy, and the surgery, if the surgery is the first time surgery, and is high in OPLL, spinal stenosis, and reoperations. And bad prognosis there are comorbidities like diabetes, steroid use, smoking, and deformities and stenosis, especially the multi-level stenosis. The dural tear may happen in different anatomical segment, like there are central tears which may be at the posterior aspect and it is easy to repair. There are lateral or axillary tear, or anterior tear is impossible, almost impossible to repair directly. If there is pinhole or linear tear, then we can extend the tear and then repair. And what happens if we cannot recognize the dural tear perioperatively, or the dural tear is not properly addressed? There are chance of CSF leak, intracranial hypotension, meningitis, coma, arachnoiditis, and sometimes there are reports of brainstem herniation and death and formation of pseudo meningocele, which will be discussed later in a case report. So if it happens, it can happen in your surgery, my surgery. Don't panic. Don't behave that a tiger has entered in your house. Be calm, take a deep breath, inform your anesthetist, nurse and assistants that their dural tear has happened and we have to do this and address this. Keep everything ready for repair. Then you start the next part of the surgery. Call a fellow surgeon or neurosurgeon if required. There are required instruments, certain required instruments like microscope or loop. Don't do in a under bare eye. Micro instruments like micro scissor, needle holder, bayonet forceps, drill or bar to be used to extend the laminectomy, bipolar diathermy, and some certain required materials like gel foam, 6-0-proline. I prefer 5-0, but 6-0-proline is used worldwide. Duragen or dural patch if available. Fibrin glue, lumbar, arachnoid, subarachnoid drain set should be ready, and neurosurgical patty. So these are the necessary instruments which should be available. And these are the necessary the materials which should be ready, like tissue glue, gel foam. This is a dura patch, and these are lumbar drain. So there are certain principles of dural repair, like patient positioning. You should position the patient so that the repair site is higher up, minimize the abdominal pressure, and prep and drape wider area so that because you may require to extend the area exposure. Clear and magnified visualization under microscope. Try primary repair whenever possible, because primary repair gives good result. Consider enlargement of approach. Look for any interdural bone, hematoma, debris, and remove those debris or materials from the site. Prepare local fat graft from the margin of the wound. Prepare fascial lata graft if the gap is large from the thigh. And in revision surgery, start at normal area of amyotomy. Sorry. So this is a fascial lata graft site. You all know the primary repair should be tried. If there is pinhole tear, enlarge it, drain the CSF, and then primary repair. Tiny repair should be can be repaired by only fat or a muscle graft. And if the defect is more than 5 millimeter and you cannot oppose it, then you put an collagen patch or fascial lata graft 2 millimeter more than the diameter of the rent, and position it inside, and then dural pulse will seal the patch itself into the gap. The primary repair should be done by suction. Suction should be used in such a way that is microsuction tube should not suck the rootlets in. So you suck it on a patty with low suction. Take appropriate dural bites. Use a 6-0-proline. I've already told. The watertight interrupted suture should be used by 1 to 1.5 millimeter apart, and avoid entrapment of the rootlets. That will give bad result. After repair, you should confirm sealing with Valsalva. Ask the anesthetist to raise the pressure 40 millimeter water for 40 seconds and see whether the CSF is coming out even after repair or not. Yeah, and apply fibrin glue, or if it is not available, then fat or blood clot over the repair to seal it. In case of secondary repair, if you have to do, then the source of leak is not identified. When the source of the leak is not identified, then anterior tear. In case of anterior tear, they pack the disc space with the fat graft. You cannot do anything else. And in paracentral tear, do not retract the dura. Instead, enlarge the laminectomy gap to get the access. So this is a dural patch, the left hand side, and this is a video of dural repair. Now, if there is larger gap, then you can take a fascial lata graft, which I have already shown, from the thigh, and put the fascial lata graft inside. And if in a rare case of pseudomeningocele, you have to excise the sac, extend the laminectomy before excision, and repair it with a fascial lata graft. You cannot do a direct repair in case of pseudomeningocele. And if you are not sure that it is very well sealed, then you can divert the CSF with the help of lumbar drain. And it is indicated in case of dural laceration and closure is not watertight. It should be placed higher up at the level of L2, L3. Intermittent drainage of 10 cc per hour should be done, and it should be kept for 3 to 4 days. There is always a chance of meningitis. Wound closure should always be multi-layered. Do not leave any dead space. Watertight closure should be done in 5 layers: dura, then muscle, then fascia, subcutaneous space, and skin. The muscle closure in crossover technique after paraspinal release, and fascia should be done with continuous watertight closure. Post-operative drain there should not be any suction drain, and post-op complete bed rest should be given for 2 days at least, and IV antibiotics for at least 2 days. And the take-home message is dural tear is reality. Address it. Do not panic. Wait arrange everything, then take help if necessary, and then start. And meticulous repair with patience, check it with Valsalva maneuver by the anesthetist, and stringent postoperative care is the necessity. Thank you very much.
Thank you, Chinmay. Please take your seat. I'll call upon Dr. Amitabh Viswas to present his case. Chinmay, you take your seat over there because we'll ask question with you also.
Thank you. So we'll quickly go through one or two cases. This was a 45-year-old lady who presented with low back pain with left leg radiation for 3 months, tingling numbness of the left leg without any bladder bowel symptoms, with a SLR restriction on the left side, no gross neurodeficit with left side ankle jerk lost, had a PID on the left side, L5S1, underwent left-sided L5S1 microdiscectomy. It was done outside, and she did well at 1 and 3 months follow-up. And she presented a year later almost to our OPD. It was surgery was done, index surgery was done from outside, with chief complaints of persistent swelling of the surgical site and headache. So there was a swelling of around 15 to 13 centimeter, quite big swelling, lobular fluctuant and no gross neurodeficit. So this was the MRI picture, the T2 weighted picture, as you can see, and this was the T1 weighted picture. So what should we do now? A question to the panelist. How should we approach a patient who comes 11 months after the index surgery of a microdiscectomy, presenting to us with a clinical swelling and MRI picture like this? So Chinmayda, you can start. How do you approach patient like this? How do you go about?
So this is clearly a case of post-operative pseudomeningocele. So, and the imaging is there. So we have to address this thing. And I think I have to do wide laminectomy, excise the meningocele sac, and put fascia lata graft, and then suture it.
Okay, my question to Dr. Sengupta is how soon should we intervene in an established pseudomeningocele? Should we look for symptoms? Should we look for the duration? So what's your guideline to go in? When to go in, actually?
If there is dural tear with CSF leak and patient has symptom, you have to repair it. It's not going to leave you alone. And if you see a picture like this, you have to repair it. But there was the earlier question is, what would you do first? The first thing I will do, I will obtain the operative note if it was done in another place. Because you do not know what exactly happened. Did the surgeon recognize the CSF leak? Did the surgeon?
Or it was incidental?
How was it? How extensive was the osteotomy? And I will also certainly get a CT scan to see the bony margin.
Okay, so many times.
But the question is why it happened after 11 months.
Yeah, so there was a swelling, possibly not increasing in size, but persisting for 11 months. And patient has come to with the swelling without any major symptoms like that. Should we straight away still go in and explore in an established, suppose the patient doesn't have pain, they don't have, she is not having compressive symptoms also on supine. And the size of the swelling is more or less the same after 11 months. And we don't have the proper surgical notes mentioning a dural repair or any leak. So what should be our approach? Should we always go in and repair inside?
This is almost subcutaneous now.
Yeah.
You are not going to wait until patient develop a coning of the tonsil or develop a meningitis. You have to repair it now. It's not going to stop, it's going to get bigger and bigger. I've never.
Okay, so, and sometimes in the immediate post-operative period, we have a confusion of dural leak versus infection. Not in established pseudomeningocele. There is a mild pseudomeningocele which is collection, CSF collection happening inside. We do an MRI. and some fluid coming out. So we are confused whether it is infection versus a CSF leak. If again, the index surgery done outside. So there, how should be our approach? What should be our approach? Should
Take out the, send it for the.
send it for culture
Send it for culture.
and microscopy to,
If it is a CSF, there's high chances of meningitis then.
right?
You don't expect that thing there. Because if there is an infected CSF, there will be, the patient is bound to have some sort of
So
meningitis.
there also we go in and do the debridement, wash and look for a CSF dural leak and start repair, do the repair. Now, anyway, this is an established case of pseudomeningocele. So the management is quite clear, as Dr. Sengupta said, we should always go in and try to repair it because this is not going to solve the issue by doing any conservative management. She was managed conservatively. Now here, repeated aspirations were done, showed clear CSF. Even after repeated aspiration, she presented with persistent swelling and headache. The main complaint was actually headache and the swelling. So the next line of management is what Dr. Sengupta said, that we had to go and excise the sac and repair it with a muscle patch and a T-cell glue. So here you can see the punctate small dural tear where actually on table we could see the pulsating CSF coming out from that dural margins, which is almost non-healed, that area, and there was an established sac, and this is the sac which we excised. And then with the help of, as Chinmayda said, with proline and here we just use a muscle patch. We didn't use a fascia lata because it's a small hole acting as a pressure valve effect. We just sealed it with T-cell muscle patch and Surgicel and repaired it with an excision of the sac, and lucky to get away with that
For this
situation.
one question I have.
Yeah,
to you.
Dinesh.
So whether this swelling was persisted for 11 months or it appears after 11 months?
There was a swelling which slightly increased in size and slowly increased in size over the last 11 months.
Did you
The
bother
swelling was there.
Did you bother to get a CT scan to know see the bony margins that caused this?
No, we have not done a CT scan. So that's what my question is. What more we can do?
Yeah, we can do a CT scan to know the cause of this late puncture and development of this.
CT scan, like
CT scan will
what
show
will
you
it
the
do?
bony margins, if there is any sharpness. I think that has led to this sort of, because the primary surgeon, I suppose that primary surgeon has missed or he has not seen any leak, otherwise he should have.
There's no operative notes of dural tear which was repaired, or
Still, I assume that he was a competent surgeon and he somehow has not seen any leak at the time of operation. So if it has happened post-operation so late, something must be there in the bony part which has irritated the dura and get this swelling.
so to the other panelists, how useful is a CT scan?
I
Can we
think,
really
CT scan,
appreciate
I don't believe the CT scan is very useful to know the cause, because we have to address the effect. And effect may happen, even the primary surgeon could not, many a times I could not recognize. I had a dural tear, I did the Valsalva, and there was nothing coming out. And then when I turned the patient supine, and then with the drain in a 3-level laminectomy, the drain was the thin, and I just says,
I think the Dr. Dilip Sengupta has the highest experience regarding the lumbar canal stenosis. And in lumbar canal stenosis, many times you see in the post-operative period, there's some CSF leakage which was not there on the table. So what are your experience about that thing?
If it is a CSF meningocele, it's a very different kind of MRI scan you will see compared to infection or just post-operative seroma. It's like a clear sac with a margin. And if we can recognize that if it is very deep and patient has no symptom of headache, we might ignore it, just wait and watch.
And that was my
But
question,
if
right?
it is coming out through the deep fascia, outside the deep fascia, then certainly I will not wait it. It's deep to deep fascia is okay. And that's the rationale of getting a fascia lata graft. And there was one other question. Why would you do a CT scan? Even if you have done the surgery, anytime you approach the dura that you have previous laminectomy done, then it is better to do it CT scan to know
The bony defect.
so that you do not create another dural tear in the process of dissection. Because you want to hit the bone and then dissect from the bone coming out to the osteotomy margin, laminectomy margin. That is the essence of getting the CT scan to make the approach safe. But
So
not
it's like the
those
same principle, like we're doing a redo surgery, we always do a CT scan
any redo surgery
to
with the laminectomy.
know how much is the extent of the previous decompression.
That's the rationale for CT scan.
Okay.
Thank you, Amitabh.
Thank you, sir. Thank you for the panelists.
So our next speaker is Dr. Abrar Ahmed and his lecture. Amitabh, you can take seat over there. Our next speaker is Dr. Abrar Ahmed. He's speaking about the misplaced pedicle screw, a real horror.
So the topic of my presentation is the misplaced pedicle screw, a real horror. As you know, and a lot of these patients, they come to us with these horrible sort of, pictures. In this X-ray, you can see everything has gone wrong, and they can cause a lot of trouble to the patient. You can have a neural injuries, radiculopathy, motor deficits because of these tears. You can have vascular injuries. You may have thoracic duct injury, ureteric injuries, pedicle fractures, screw fractures, and so on. So basically something about the anatomy there is around 4 millimeters safe zone around the spinal cord. Out of that, the 2 millimeter of the space is occupied by the epidural space, and the 2 millimeter space is occupied by the subarachnoid space. So sorry, I'm not coming. No. Not coming. It's not coming on the screen. So sometimes patient may come to you with the X-ray pictures like that, and you can see everything has gone wrong in this way. In this picture, the screws are in the inferior direction, and they are crossing the midline, and you can have a lot of these problems with these misplaced screws. Patient can have neural injuries, they can have vascular injuries, thoracic duct injuries, ureteric injuries. All these injuries have been described in the literature. Basically around something about the anatomy, there's around 4 millimeters safe zone around the spinal cord, out of which the 2 millimeter is the epidural space and 2 millimeters is the space which has been, which is called subarachnoid space. So sometimes you may get away if the screw penetrates in this 4 millimeter region. But once the penetration crosses the 4 millimeter region, there's significantly very high incidence of neurological problems in these patients. Another thing you must know about the, especially around the anatomy of the lumbar spine, that your inferior nerve root, which is just touching the pedicle inferiorly, and the distance is around 1.1 to 1.6 millimeter from the L1 to L5 pedicles. But the pedicle and the superior nerve root distance is 4.12. So if you go inferiorly and your screw penetrates inferiorly, it is in very close contact of the inferior nerve, and you can have radiculopathy. And patient will present in the post-operative period with radicular nerve pain. But if the screw penetrates in the superior direction, you may get away without any complication. Another thing, very important thing, is in the dorsal spine, the dura is much more closer to the pedicle. And if your screws penetrate medially, you may have significant neurological difference in the dorsal spine. You can have a penetration of the medial cortex. You can have the penetration or violation of the lateral cortex, and sometimes the screw may go superiorly or the inferiorly. And depending upon where your screw has penetrated, patient may have different sort of problems. If there's inferior and medial pedicle cortex violation, there will be significant risk of the neurological problems. if there is a violation of the lateral cortex, the risk of vascular and visceral complication that increases. Plus, there's a loss of fixation and violation of anterior cortex. You know, there is a vena cava and the aorta is in front and the vessels are in front. And if it is a very significantly penetration anteriorly, you may have vascular problems. This is the classification which has given by the Gersbein and Robbins. So there's a 4 grades. One is the 0, 1, 2, 3. If the 0 grade is that when the screw is within the pedicle and there's no cortical breach. And grade 1 is 0 to 2 millimeter, that is in the epidural space, and there's minor cortical breach. More than 2 to 4 millimeters is the moderate cortical breach, and if it is more than 4 millimeters, there's a severe cortical breach, and patient may have significant neurological problems. This is an example of the case. This is L4-5 significant canal stenosis. The patient underwent L4-L5 TLIF. If you see in the axial section, the patient has severe left leg pain and the foot drop in the post-operative period. And if you see the CT scan, there's a grade 2 medial, on the left side, there's a penetration of the screw in the middle in the canal. And a revision surgery was done in this patient. And you can see the track of the original screw in there. Another example is a 50-year-old lady was presented to the emergency department of the hospital with the gradually progressive continuous upper back pain, more during the night time, and patient had radicular pain in the chest region. She had a fall injury, minor fall injury at home, and then she presented to the emergency with the weakness of both the legs. There was a power of 1/5 in both the legs, and the patient had upper motor neuron size and diminished sensation beneath the D4 dermatomal distribution. This was the pre-op MRI of the patient. You can see there's a significant compression on the cord. The patient presented with the paraplegia. This was the procedure which was done, D4 to D5 laminectomy, and D2 to D6 level fixation was done, and left-sided posterolateral decompression was done. And that's how the fixation was done. And this is the immediate post-operative X-rays. Post-operative, the patient which had power of 1/5 in both the legs, now the patient had in the left leg 3/5 powers, in the right leg the power was 0/5. Gene expert TB was positive. Patient was put on anti-tubercular drugs and rehabilitation started. In the patient again presented 3 weeks after the surgery in the emergency department. Now patient had complete loss of power in both the legs. There was a complete paraplegia. There was a loss of bladder and bowel sensations. You can see the post-operative X-rays. The whole of the implant is coming out. We did the post-operative CT scan. You can see at the D3 level, there's a grade 3 penetration. At D5 level, again, on the right side, the screw has gone into the canal. At D6 level, almost the screw is going in the center of the canal. This is a post-op MRI in the CT scan. The revision surgery was done. The lower screws were taken out, and particular hooks were kept in place. There's a post-operative last follow-up. The patient power has improved 3/5 in the left lower limb, 2/5 in the right lower limb, but still the patient is having complete loss of bladder and bowel sensation. So patient can have significant problem if you do not take care of the patient, do not do the proper pre-operative investigation and planning. So how to prevent these mishaps to happen? You must always do pre-operative CT scan, all the dorsal and dorsal lumbar junction pathologies. Second thing, you must see what is your alignment. Once you are putting the pedicle screw in the lumbar spine, it should be divergent placement. If you see this, it's not divergent, like in this patient, if you see the screws are converging, and you see in the CT scan, post-operative CT scan, all the screws, they are going to the into the canal, and patient presented with the cauda equina syndromes and the bilateral foot drop and severe radiculopathy. And later on, all of the implant was taken out. You can see, so you should always, your alignment should always be divergent rather than the convergent. Then you must take care of the osteoporosis. Osteoporosis is the enemy of the fixation. And whenever there's a significant osteoporosis, then you should always try to augment the screws with the help of the cement. And what is the cutoff limit? If you're on your bone scan, if the BMD is less than 80 milligram per centimeter cube, then you must augment all those screws. And it has been, there are many studies which has been done in the literature regarding this. So this is an example of severe osteoporosis vertebra plana. We have augmented the vertebra with the and with the screws with the bone cement with a good result. Another very important thing is that whenever you're doing the pedicle screw fixation, you always take the strict AP and lateral view. Your pedicle should not overlap, otherwise you may misplace the place the screw in the different direction and may have complications. Always manually palpate all the 5 valves and do the radiological assessment, and if possible, do the EMG in that patient. You always keep your screw away from the midline. As you see, in this patient, the screw is going to the center. Your screw should never cross the midline. Always see if in the AP view there is a large image, and lateral view there is a small image, you have penetrated your screw has gone midline. If you've seen there's a lateral view, there's a very small screw you can see, but in the AP view your screw is crossing the midline. It means you have crossed the midline. You have penetrated the midline. And regarding the lateral penetration, just 2 minutes more. Regarding the lateral penetration, if the lateral image is a large screw, you can see, but in the AP there is a very small screw, you have gone laterally. There's an inferior penetration, anterior penetration example. So another thing is very important is if you've got a neuromonitoring system, you can do the trigger EMG along with the palpation of the walls of the pedicle. So always use the adjuvant techniques if possible. If you have got the navigation technologies or other technology, you can use them in the complex cases. Thank you very much.
Thank you, Dr. Aman. Please take your seat. I request Dr. Abhishek Rai to present his case. So we have running short of time, so we should keep our discussions in limit here.
Yeah, good afternoon, gentlemen. So my case today will be about a misplaced pedicle screw. Starting off directly, a 14-year-old male patient with a worsening spinal deformity. Significance on examination findings are like a prominent rib hump with no neurodeficit and a bowel bladder being normal. These are a few of the clinical pictures. A radiology was taken. We find these are the AP and the lateral standing views of the whole spine. We find the T4, T8 coronal angle being 23, T8, L1 about 91 degrees, L1, L5, 43. And in the lateral view, the sagittal thoracic angle, Cobb's angle is about 47. To ascertain the rigidity of the curve, we do the bending films, in which we find that the T4, T8 and the lumbar curve almost straightens out, with the T8, L1 segment reducing from about 88 to about 62 degrees. We get an MRI or CT done in order to find the etiology. The MRI shows a syringomyelia between C4 to C7 and a small one between T4 to T5. CT scan does not show any presence of any hemibursts or bony bars. So we come to the planning. We have a relatively rigid curve of a neuromuscular scoliosis, the planning being multiple Ponti's osteotomy with probably a possible thoracoplasty 1 or 2 levels. Arrangement was kept for a direct vertebral rotation, and the overall plan was a T4 to L4 fusion. Okay, so till now, like, is there any we are not speaking about the case in general, we are speaking about the complication, but is there any comment till now? Like, is there anything, or should I just proceed? Okay, so some of the operative pictures in the dissection, the instrumentation, and the eventual picture. So the post-op X-rays show about 90% curve correction. I don't know whether it's a good thing or a bad thing. Probably should have aimed about 87 to 88 degrees. But this is what we have. Have fused from T4 to L4. Okay, a few pieces of information is intraoperatively we had significant blood loss. There was pleural violation while doing the thoracoplasty on the left side, and thus needed a chest drain. On neuromonitoring, we lost complete signal twice on the table. First, during the Ponti's osteotomy on the concave side, at the thoracic level. And secondly, on the second instance, at the time of T4 instrumentation on the left-hand side. So each time the signal came back fully on performing the basic maneuvers like increasing the blood pressure, enhancing the oxygenation. The screws were checked under fluoroscopy. Postoperatively, as we all know, as is already mentioned, there was severe blood loss and thus the EVG was deranged at the end of surgery. There was acidosis. The patient was extubated at about 16 hours. He was made to sit up in bed at about 36 hours and out of bed in about 3 days. Drain was removed. The surgical side drain was removed in 48 hours, the chest drain at about 3 days. But what is interesting in this particular case is like the patient complained of a left medial thigh pain after waking up. The pain was radicular in nature, which was present even at rest, and the pain was severe enough to actually affect his ambulation. However, there was no motor neurodeficit. So this is what the post-op X-rays look like, as I already showed. So based on this, based on the imaging that I have, would you like to, is there any particular screws that are particularly suspicious you feel are misplaced, or what do you think is the reason for the radicular pain? L4, sir. L4.
L4, so it is the left L3 screw.
Goes
looks
right
like-
medial.
Yeah, left L3 and L2, even left L1, but I do not know how much of rotation in the lumbar spine you have, because lumbar spine was not expected to be much rotated.
No
So I don't
rotated because-
anticipate this much of screw, the left L1, L2 and L3
Yes, sir.
are crossing the midline too much.
So even the patient was symptomatic on the left side. The patient was symptomatic with the radicular pain on the left-hand side. And that is where we are also trying to suspect. So yes, I sort of suspected that. So I sort of zeroed in upon those screws, which I thought probably could be grazing the nerve root, or maybe it is too medially placed. I do not have the images, but you'll have to take my word for it. The screws were okay. And somehow, though the vertebral bodies were not much rotated, I think it must be the posture which is making it look like this, because I checked it on CT. The lumbar screws were just fine.
And the patient is standing with the line getting rotated on extra table.
Probably, sir. Probably that is the only reason I could find out. So no definite evidence of the screw misplacement was there on CT scan. So I basically the next step. So is there anything else that the next step? What would you like to do? The patient remains symptomatic, and so I got a CT scan. We ruled out that the lumbar screws are misplaced. But what incidentally I found was this. This is T4. It's the same level. So now retrogradely, when I think back, I had, yes. Yes. So, yes. Thigh pain. Yes, I know, but I'm just presenting it as it came. So this is what I found. I too thought that the thigh pain cannot be explained from this.
What is the city picture of the L2 and L3?
So the screws are well and good. Like they are inside the pedicle. There is no breach either laterally or medially. Okay, so first thing that comes to your mind, damn, should have been a joint surgeon. So we have a day 4 recently stabilized patient medically, because the patient, as I mentioned, had severe blood loss, had post-op acidosis, had required quite a few transfusions. So we have an infraspinal screw at T4, which probably does not explain the symptom, but it is there. The patient, strangely enough, is neuro intact and has a radicular pain to the medial thigh. So based on this, what should we be done?
So it is inside, you have to take it out. There's no doubt. You cannot wait. Even if patient is asymptomatic, you have to take it out.
Neuro signals. Yes. So I had that drop once while doing the Pontes on the concave side. And secondly, while instrument, so the T4 level required a double pass. The first time I put in, and when I was feeling it, it seemed to be outside. Then I put it in again, and that is the time when I had a drop in signal.
Usually when we struggle for a particular screw, and after putting the screw, we definitely check it that after struggling.
Yes.
So after T4, there was a drop.
Yes. So I know I did not reverse my immediate previous
And that
surgical
drop
step.
recovered just after
Yes.
pressure raise.
So that drop recovered very strangely when I put in the T5 screw on the other side. Mani, this is the year of events.
Abhishek,
Fully.
just one question, like very hard to believe that when the screw is in the middle of the canal in the thoracic spine, possibly the T4 to T8 region, you have a screw in the middle of the thoracic spine and the patient wakes up without a neurodeficit. Like, you got the signals back before closure or?
I got the signals back before instrumenting further.
Okay.
So the patient was there was absolutely normal neuro signals.
So signals came back.
Yes, and
That's
this was
very-
at a time duration of about 5 minutes after putting in the
minutes,
tape.
okay.
Abhishek, this cannot be explained.
Sorry,
How will you explain this?
I
Did
cannot.
Did you investigate further EMG, MRI scan?
No, sir.
Did
No,
you
sir.
do-
I didn't. No, sir, I didn't. I did not look for the etiology because so my thought process was more like what now needs to be done. I did not look for the reason why there was no signal drop. Probably I thought the kid is about 14 years, 13 years, 14 years age. Like T4 is one of those, it's one of those very narrow levels at which probably it will not tolerate a misplaced screw. But in this case, I went back to the previous imaging, went to the MRI, and I saw that the cord was actually much, it's inside the canal, inside the vertebral canal, it was much placed towards the right-hand side. So I thought probably I got away with it because instead of piercing the dura, I had displaced it.
No, Abhishek, there is no place at T4.
Yes.
Yeah, no place at T4. T4 is very narrow area of the cord. So if you.
No, Dinesh, sir. So this is, I mean, are we actually, do we need to look for a reason why I did not have a neuro deficit despite that screw, or do I just go ahead and treat the screw? That can be another question.
If the patient doesn't have any motor deficit, and if it is only pain in a radicular distribution in thigh, like L2, L3, you can wait and watch and investigate further rather than being aggressive. Because even if you try to take the T4 screw out, that is not going to address the thigh symptom. And you may upset the dura again, which is you just done the surgery. And this time, even while you are taking the screw out, if it is rubbing against the dura, you can cause another motor deficit in both lower extremities.
Yes, sir. So, but can it be an occurrence that the patient had a right-sided convex thoracic curve with a left-sided lumbar curve, and stretching the nerve root.
And patient also had a cervical syringe.
Syringomyelia, correct.
So there is a cervical syringe, it's a neuromuscular, and you have done a very large degree of correction. There are so many things can go wrong.
Yes,
that
sir.
can cause cord stretching or the nerve root symptom. You have done a very good correction, and
So
congratulations.
question to you, sir. Sir,
My
just interrupting. Can we medico-legally keep the screw like that, even with the absence of a neurodeficit? Now that we have documented the screw is in the middle of the canal.
Because the screw is in, if it doesn't cause symptom, as long as you inform the patient and keep the medical record, then you are okay. But if you try to take the asymptomatic screw out and develop a symptom, it will be very difficult time to justify your action.
As we till now we know that the possible cause of radicular pain may be due to stretching, root stretching. So what to do next? Because you'll have to conclude fast.
Yes.
Okay.
So I went ahead. So I went back to the literature. This is the. So I went back to the literature and I found that. So basically, they have mentioned about there was a recent meta review also, and as well as there were a few studies which actually advise you to go in the early postoperative period to remove of the screw. obviously under neurological guidance, because as you mentioned, the very fact that while we are removing the screw can actually lead on to a spinal cord injury. But the advised, like from what I gathered, was to go ahead and remove it in the post-operative period earlier rather than later.
That's correct.
Okay, sir.
Because the longer you wait, and then you say 6 months later, you recognize and you take it out.
Yes, sir.
And if there is any fibrosis around the hardware, and as you take it out, you may cause neurological deficit.
Yes,
So you remove the screw?
Yes.
You
So,
replaced?
yeah, the T4. So I thought I'll replace it, but when I went back,
Okay.
you can look at the rod length and like, you know, the domino, I had to really go higher up with the domino. So I just removed it. The left shoulder will get a bit higher up, but I'll accept that in this case. I just cut off the rod and
Any,
remove
any
it.
further neuro deficit in this?
No,
person?
nothing, please, thankfully. So
And-
this is one point, the medical legal aspect of a misplaced pedicle and a lateral mass screw in spinal surgery. You can see like amount of litigation in, this is a US study, sir. Litigation resulted in an average payout of about, so that's about more than $1,000, you know, over the last 10 years. This study has been made, so.
So thank you, Abhishek. So we'll have running short of time. We'll have to conclude this session. Very nice discussion, but we are sorry. So I'll next call upon Dr. Amal Basak, Dr. A.K. Saswal, and Dr. Sandeep Chakravarti to chair the session of AOTS. Sharjeel Khan.
Good afternoon, everyone. We are going to start the AOTS session. I will request the chairperson, Dr. I will request the chairpersons kindly hold their chair. Dr. Amol Basak, Dr. A.K. Sasmal, Dr. Sandeep Chakravarti. And for the first, our first speaker, Dr. Vivek Trikha. Yes, I'll call the panelist, Dr. Pratyush Chatterjee, Dr. Shubhro Chatterjee, Dr. Akhilesh Kumar, Dr. Navarun Shah, and Dr. Moinak Chandra. And Dr. Abhijit Sarvadikari, kindly.
We start here. So we'll start and we'll have few cases, 1 or 2 cases in the upper and lower limbs for some not very challenging, you can say, yes. This is a patient who is having a polytrauma with ICU for a few weeks because of his other injuries which he had. He had a dorsal spine fractures and stuff, which was fixed by the neurosurgeons in our hospital. And he came to me as an OPD after 3 months like this. He had some dorsal spine fixation done in August. And when he was fine, he was sent home. And he came to me having inability to lift his shoulder up. And this was his fracture. Just to cut the story short, I'll just give you the CT scans also. This was a CT scan. The problem which I want to highlight is many a times in ICU, what happens, whenever he said that he was complaining of pain, you get a chest X-ray done n number of times in the ICU, but the chest X-ray usually does not involve the shoulders. It just comes till the lateral end of clavicle, and sometimes it is slightly oblique and you do not have the shoulder along with it. Whenever he was complaining of pain, if after ICU and whenever it was being said, your dorsal spine and upper dorsal has been fixed, it is related to that and you will be okay. When finally he came, now this is the picture, which is a 4-part fracture dislocation posteriorly.
Well, my first question is, you said it was a polytrauma case.
Yeah.
Now, how is it that they missed the shoulder?
So let's keep that aside. It's medico-legally, they have missed the shoulder.
So it was the original fracture was at the time of injury.
Yes. The original fracture was time of injury. He had a hip fracture. He had this fracture. He had a dorsal spine fracture. He was under neurosurgery for a few months. And after that, when they discharged him, he was referred to orthopedics OPD and he came to this.
And all these few months, she had a shoulder pain and nobody bothered to.
Nobody, all the neurosurgeons. So that's besides the point. Let's not discuss what are the interdepartment things. It happens everywhere and it will be happening everywhere, sir. Let's discuss orthopedic spine. He has come to us. I wouldn't have even have told you that. I would have just told that it is 3 months old fracture dislocation, which has come to you.
40 years old. 40 years, you said.
40 years old man. He's a bus driver. He's a DTC, Delhi Transport Corporation's bus driver, and he wants to go back to his house.
Sir, first is what is the neurological status?
Everything is fine.
Everything
it just has no caveats, just 4-part posterior fracture dislocation. And this is the CT scan.
Now he is ready for the surgery also.
Yes,
So
he's ready for the surgery.
Sir, as we are seeing, there is the coronal split of the head. And also in 4 part, there is the basically head is split. And as his age is 40 years and he is a bus driver. So actually he do the work below he does not require the overhead work. So we will go for the osteosynthesis in this case. Even it will the ST or go for the AVN, he will carry out his daily activity.
Any other viewpoints?
I slightly differ from Akhilesh. This is a 3-4 months old injury and the head is completely detached from the humerus. There is all probability that the head is no longer alive. So I will, even if at the age of 40, I will go for a prosthesis.
Let's say that he was at 20 years, then what would you have done with the same fracture? Why? At that time also head would have been fully avascular when it was outside without any contact with the shaft. Any and every fracture dislocation which is 4-part in a proximal humerus will be having a head which is not in contact with the shaft. Then why are we conserving them, sir?
So is it possible to get an MRI of the shoulder to assess any vascularity or?
Do you really want to get an MRI in a 35 or a 40-year-old for assessing the vascularity? It's not a femoral head that you want to do it. It's a humeral head.
So in this case, I would like to go for an osteosynthesis.
Okay. So we have less time. We have 30 minutes and 3-4 talk. So we will assume that in most of the younger age group patients, we try to salvage, as has been said. If it fails, let's see the movements and then decide as per his activity level and how it goes. The first thing which we can do by reducing it will be reducing his pain, as well as if we gain the movements, it will be an additional bonus to us. Yes, if we want, we can do a replacement in him. But then I would like to ask the audience as well as the panelists out here, what sort of replacement would you do in a 40-year-old with this sort of a fracture with the greater trochanter head and widely displaced lesser tuberosities? You want to go for a hemi, a total, or at 40 years, a reverse shoulder? So that's also needs to be thought of. It's just not that we are not going to do an osteosynthesis. What is the replacement or an alternative for that which needs to be done? So callus can be seen. You can see the callus all around the shaft of humerus. He was a bus driver. Options available, as we have discussed, were the reconstruction or replacement. The moot point is how to achieve good result in a 40-year-old male. And if replacement, what replacement till he goes till 80, 85 years of age. And if we have replaced and if we want to salvage it, what will be the approach? How do you reduce backups? Nothing. He was not able to move it.
Sir, main problem is the reducing the head part over the soft part. That's all gone above. So we have to do some sort of osteotomy in the shaft part also. So shorten the length. Then after shortening the length, try to reapproach, constitute the anatomy of the proximal humerus, and then put over the osteotomy part. So hand will be shortened, but will not affect the function.
Okay, so what are the maneuvers? This is a posterior fracture dislocation. So how do you intend to bring back that posterior fracture?
Yes. As you shown in morning, do a small approach from the posteriorly, then proceed to the anteriorly, then reconstitute.
Any other viewpoints, sir? Yes, sir.
I still am not very confident about osteosynthesis. 4 months old, plenty of callus formation has already occurred. Small posterior incision will not be able to reduce the head.
No.
I will go for prosthesis.
Posterior incision along with the deltopectoral. That's what he's saying. Prosthesis, sir. What prosthesis you are going to apply then?
40 years, I would prefer hemiarthroplasty.
And the results of hemi with the GTs, these widely displaced, the resorption of humeral head and the tuberosities. Oh, I don't know, sir. Yes, when the audience is so august and expert, we definitely should have audience participation also.
Sir, I think I usually like to, in older cases, I usually like to do an osteotomy, or if the lesser tuberosity appears to be united to the shaft, so do the osteotomy and release the pectoralis major in the upper part as well to get the mobilization of the distal part of shaft, and then cut the rotatory interval to up to the level of coracoid to separate the GT and LT, and then we can probably see the head from that and take it, reduce it with the sand spin sort of thing.
Yeah. Okay. So that's a great point, which he has said that you can do a osteotomy of the tuberosity and then also you can go and access the thing. So as I had shown in the previous in my oration also that I usually go for osteosynthesis. So we opted for not because that I knew it. I knew of what we are doing out there. The second thing was the patient's age of 40. He was a bus driver. Bus driver requires a lot of, it's not a small thing or an automated bus that he's driving. He's driving a Delhi transport bus, which is a huge thing which they have to move. Along with that, the head chunk was quite big. If you see the head chunk, for me, the head chunk was quite big. And I thought that whatever I am able to salvage, if it becomes having some range of motion, which is adequate for him, he will be able to perform. And later on, after 10, 15 years or 10 years, we might go in for whatever we want if required. Based on his age, profession, and as I said, the fragment sizes, and also our experience with ORIF, which I have shown in the morning. We went through deltopectoral. As we went, a lot of callus granulation tissue was there. Lesser tuberosity was tagged and separated. In fact, it was united as callus formation was there. So I had to cut it and I just separated the lesser tuberosity and used it as a trochanteric flip sort of a thing so that I can enter and see the glenoid, because glenoid was full of the callus and fibrous tissue. Then after that, I was able to see the head, which is going posteriorly. And since the head size was big, it was easier to maneuver it behind the posterior glenoid and lift it out. The problem happens if you put in a Homans and then it breaks into multiple pieces, the humeral head, and that causes an issue. So here we were able to bring that out from the head. That GT was tagged. You just had to mobilize. The time here, which was spent mostly was on removing the granulation and the callus, tagging the tuberosities and making way and space in front of the glenoid so that that head could be brought back. It's not only the removal and the taking the head, but you also need a space where it can be brought back. So that is also very much important, which we were able to do. And with the Homans retractor and hinging, we were able to bring back. And this is what we were able to do with the head. You can see the head part, which is so small. And then the GT. Anything, there's a huge void now. What to do with that void?
Sir, you have also got the proximal part of the shaft. Proximal part of the shaft also.
I have not done any osteotomy or shortening of the shaft. It's just by mobilization and removal of the callus, I was able to bring it down. Yes, recovered callus. Anything else would you like to put? or so.
Yes, sir. Now if there is the big void and you also do not have the lateral support, so you need some strut graft like fibular graft, a strong graft.
That's great. And that's what we did. We put in a fibular strut graft out there inside the medullary cavity, as was shown in the morning as well. Repositioned the GT over it. Before, if you see the graft, GT was getting inside that void area. If you see in that image out there, it was getting inside the void. So we filled that with graft, the normal graft, and the intramedullary strut was taken and put in with this fibula, which was autogenous from him. And bone graft was in situ, as you have said. We didn't have to remove an iliac crest graft. All the callus which was around, we removed that and put that. And then it is again what I showed in the morning. And this is what we were able to achieve. This is the medial cortical continuity, which I said was.
Sir, how you address the coronal split?
There was not much coronal split,
everything
sir.
is the
The
sagittal.
coronal split was not there in true
there.
sense. It was the head which was rotated. As soon as we brought back, the GT and the things will come back. There was resorption was there, but coronal split was not there. I normally do not do the biceps tenodesis or so, but in this case, I said I might do it because I was not sure of the rotator of the interval where it has to go, and it would be rough to avoid pain. And the lesser tuberosity, I fixed it with a separate screw out here, which was used as a trochanteric flip or a tuberosity flip. And this was the post image, final image, which we were able to get. Any comments regarding this?
You restored the medial continuity of the humerus and the head by means of the fibular strut graft.
I didn't was able to bring the medial continuity because there was comminution. So to bypass that, I had put in an intramedullary strut graft, which is holding my humeral head and the medulla and the shaft at its place. And that positions the humeral head over the shaft and does not allow to go into varus till the thing is.
And that fibular graft got incorporated.
It usually does, just the same way as we use for core decompression of our proximal femur. This is his post-op image. Comments? Sir? It's relatively, the head is in front, looks up.
It is very difficult to find any abnormality here. Only thing I found, the calcar screw is little bit longer.
Yes.
That is in the subarticular area.
Yeah,
Except that everything is
I
excellent.
normally put in those screws as long as possible here, because I feel that whatever movements we do, the calcar is not going to come into and hammer the glenoid, because we are not going to do a hand going back. And moreover, if you see the head part, which was very small on the lower part, so to get that hold onto that, I had to go very subchondral in this place.
Don't you think there is still a void at the medial?
Yes, there is a void which has filled with graft, which is cancellous or the callus, which has been taken out from the adjacent area. But since I did not use an iliac crest graft here because I was having abundant callus, which was there. I used an intramedullary strut with that.
When did you start mobilization?
I'll show you, sir. Sir, it's 3 months old fracture. So whatever I could get, I had to my aim was to bring the head in front of the glenoid, tuberosities down and shaft down and let the thing and nature do its work.
Still, I have two questions.
Yes.
One, the status of the humeral head.
Yes.
And when did you start mobilization?
Sir, I'll tell you, whatever, I would like the other people also to understand this, that in humerus, I'm not bothered about the MRI or the vascularity of humeral head. It has been proven in my cases of 45 series of fracture dislocations, all fracture dislocations 4-part, which is the head is separate. Avascularity happens only in elderly population above 55. And the head, which is remaining and stabilized by creeping substitution, it definitely gets salvaged. There will be sectoral osteonecrosis, but not complete osteonecrosis in this. And since it is not a weight-bearing joint where the pain is going to happen for you, this patient, it's the soft tissue, it's the rotator cuffs, which are the main things. So you can have excellent movement in spite of not having the head, as we see when we do in tumor surgeries. This is the post-op. This is his 3 months follow-up. 3 months. This is his 6 months follow-up. You can see that the callus on the medial side has also started forming. The head has become intact. Nowhere it looks avascular or a sclerosed. The humeral fibula you can see right in between with the tuberosity, which is lesser there. This is my office room where he's doing these passive range of motion exercises. And this is his 24 months follow-up. The head and the calcar screw has not collapsed, which we were worried. The humeral head, the fibula has nearly incorporated. Now the complete cortical continuity on all round the humerus can be seen in this patient, and even the calcar has formed. This patient has gone back to his daily work. I would certainly honestly confess that I didn't expect that he will have such good movement as such. But this was purely, he was very motivated that I have to go back to my office, and he was able to do these range of motions. But what I mean and what I want to show you a challenging case in that in a young patient, even if he would have attained 50% of what he has range of motion right now, I would have been very happy with my surgery decision, which I had done. And at 24 months, nature sometimes and most of the time helps us to do what we want to do. So that's what is a case of fracture dislocation, which is 90 days old. When I operated him, it was 89 days old from August till October. So adequate stability, which has been given by multiple screws everywhere with a fibular strut, osteoconductive and osteogenetic potential by osteogenous graft, strut graft, along with growth factors which have come with this, which is the diamond concept of any non-union. If you follow properly, mechanics with biology, some things and most other things can be done. Any comments, sir? Okay. Yes, sir. I know it is an outstanding case. Yes, and I fully say that it is not my thing. My job was 50% of it. The rest 50% was his job, and he did it very diligently. I admire him because he got the movements. I didn't get the movements. It was that he. No growth factors. It was autogenous bone graft, which is having the growth factors if it is there. I have not, but this is the diamond concept of using a combination of things which will give you the state. Sir? No, I didn't use iliac crest graft here because I had a lot of callus around the shaft, which I showed in the CT. I removed that mobilizing. So I took that graft and put that inside right there. So that's the thing. From there, I take you to.
Next presentation.
Yeah. This is a. Okay. This is a.
Back.
We come to the lower limb now. A 42-year-old male, motor vehicle collision, has a fracture of the tibia. Your comment, sir. What?
So, this is a proximal tibia fracture, such that there is a split, also a depression. So it is type 3, I will say. And then there is a metaphyseal split also, along with, means type 6, I will say it. Although there is a medial comminution, I cannot find here. So I will, is there any CT scan or any better? Okay, thank you. So there is a involvement of the anterolateral portion, to the posterior column is quite intact from the axial cuts, but from the lateral, the sagittal and the coronal cuts, we can see there is involvement of the anterolateral, the lateral part, as well as the posterior. No, so there is a lateral depression.
You can see that on this portion on the sagittal, it's mostly middle and the posterior part of the depression.
Central
s-
depression.
with a split also out there.
Yes.
So it's a lateral, posterior and central depression. The split is here and the depressions and the things are mostly posterior and central, and has a diaphyseal fracture also. So let's say that we want to manage him operatively. We are not into a discussion regarding non-operative right now because we have very less time.
Yes, sir. Consideration is two things. Either you do it with the one implant or two implant.
Yes. So
I
how do
will-
you decide that?
So I will opt one implant.
Yes.
In first procedure, I will go for the suprafibular approach. So we can go up to the corner of the plateau. Then after elevating the plateau with 4 mm CCA screw, after giving this 4 mm CCA screw, I will use long hockey plate in lipo fashion.
Okay. Anybody else having a different opinion? Sir, mic is in front of you. Mic is not working. No, no.
Just go through the medial cortex, push it
Push it up.
and see, then
Yeah, yeah.
if I'm satisfied, give 2 rafter pins, then a anterolateral standard plate.
As you said, a single one. So the question is, which will be the ideal way of fixing this diaphyseal fracture? How long a hockey stick you are going to take? So it is at least 13 or 15 hole plate, which is. Okay. Yeah.
Before that, I will also like to have an X-ray of the ankle also.
Okay, fine. Let's assume it is okay only. There's no caveats. I'm not, whatever is there evidence which I am seeing during surgery, I'm showing it to you, sir. So there's no caveats or anything which is hidden from anybody. So how to manage? These are the fractures. There are 2 main fractures here. One is a type 2 or a type 3 split depression fracture of lateral condyle, which we normally operate with a plate. As sir has said, with lift elevation, depression has been lifted with bone grafts and plate fixation. And a second fracture, which is there is a diaphyseal fracture, for which the ideal implant is an intramedullary nail. But here we are going to use, for a diaphyseal fracture, a long plate for that. Yes. Okay, so that's a point which is there. So there are 2 options and 2 various things which can be used. I'll also show you another case similar to this. Now this is having a medial condyle fracture with lateral slight depression on the posterior side with a classical diaphyseal fracture of the shaft. Now, how are you going to manage this?
Here, sir, because it is not possible to do medial spanning with so long plate. So now we have to use 2 implant. First reconstruct, do the nailing, then address the medial part.
So which incision you are going to use for the nailing part and for the medial part of the plate?
Posterior medial incision for the medial part, and through that you will approach an anterior tibial splitting of for the nailing.
So your 2 incisions are going to be very close to each other.
Posterior medial, it will almost 4 finger away.
Okay. So I'll show you. This is the fracture. Medial condyle. It is a non-contiguous, as I said. So we'll show you how we try to manage this. And this is the way we are managing nowadays in our place, which is using the ideal implant for both the fractures, which is a nail for a diaphyseal and a plate for the intra-articular periarticular fracture. So we opened up like a standard way of opening up the lateral condyle, just like we operate a lateral condyle with a lateral incision J shape, lifting it up, fixing it with screws, and then we use a suprapatellar nail. A suprapatellar nail gives you an entry which is above the patella. So your incision problems of the skin are not there at all. You don't have to move your leg anywhere. It is in the supine position. And that central entry point becomes very easy, and your imaging becomes so easy as compared to an infrapatellar nail. And that's what has been done. Plating was done from here. These screws we will change later on. And then a fracture which has been fixed can be fixed, and you have 4 holes or 4 screws in the proximal fragment and the 2 or 3 holes in the 2 screw bolts in the distal fragment, which can be held with this.
But there was a medial condyle fracture, tibia.
No, that I've shown you 2 cases. This is the first case. This is the first lateral depression one, which I'm showing you, and the second one was the medial one. So you can see the nail going through between the suprapatellar, between the femur and the patella. The incision is totally away. Your movement of the deformities are totally gone. All those high proximal and high distal or low distal ones can be taken care. And this is what you can get by fixing it the way you want. So this is best of the implants for both the fractures, which you would have done if they would have come isolated to you in the same patient with the same fracture. And the same, yeah, any questions? No, yes, you can have. So if you see, we have put in very less screws first. And once we put in the less screws, you have put in only 2 screws or 3 screws out here. The other screws we are doing, there are 5 screws which you can put. So out of those 5, we have to put only 2 or 3 because this was a mid shaft fracture. So wherever we are able to get, we will put that. If not, we will remove 1 screw and do it. But our aim for making the raft of that is that raft screws not have to be removed.
So anyway, it is not, when you do the locking, it is not hitting your plate. On the medial plate is not coming in the way, as it is little anterior. We have seen it is little anterior.
Yes.
So
you just have to see that whenever you put in the entry point for your nail, your screws which have been put initially are the posterior ones.
Yeah.
And your entry ones are not.
Anterior.
You put in your screws, 1 or 2, because this is a diaphyseal fracture. You do not require multiple screw holes on the top, but you have an option of 5 screw holes. So whichever fits, you put them. Even 1 will be okay for you because this is a diaphyseal fracture.
I suppose this is one.
This is roughly, we put in high. This is, I think, 9.
Sorry. I suppose this is as a result of road traffic accident, and it is expected that lot of soft tissue problems are maybe associated. So one of the alternate method may be that the reconstruction of the proximal segment. Proximal segment means the proximal tibia, and then instead of wrap screw, that can be applied with the Elizarov, and the hybrid Elizarov may be the another option.
I fully agree with you. Even if somebody would have put just 2 raft screws for the tibial condyle and put in a nail, I would have agreed. I'm just showing you a newer way where most of your infrapatellar nails, which we do, most of the patients have some abrasions around the knee joint. With the availability of a suprapatellar nail, which has come up, or a semi-extended nail, you can use both the approaches. Your alternatives for fractures like this have changed immensely now. I can use an ideal implant for the diaphyseal fracture, an ideal implant for the intra-articular fracture, both proximally and distally, and try to get the most stability which I have.
Can I ask?
Yes, sir, please.
Sir, in these fractures, can we use Elizarov?
Sir, it is Elizarov can be used. I have just in the initial times only I said, yes, I am agreeable with all the various options which are there. I am just showing a newer option, and you can see the incisions which we have done. This is the incision for the lateral side, a small one. Your infrapatellar nail would have come here, but the suprapatellar incision is here. And these are the stab incisions for your locking bolts. So it is a minimally invasive way by which you can fix both the fractures. These are his post-op images. This is his 6 weeks follow-up. It's the same nail. It's the same nail which you use. There is nothing different from them. It's only the jig which is different, and you're putting it through the above the patella rather than below the patella. And you can see that range of motion of the same patient, which is here. And this fracture which we were discussing, the same way, a medial plate for it, which is an ideal implant because you cannot have screws for a medial shear. And then you have the suprapatellar nail with that, which is coming, the incision is coming from the top. And then there was having some lateral LCL fibular avulsion also, which was fixed with screw. Okay. So just showing you 2 different fractures, contiguous and non-contiguous. There are options of using a long plate As I said, I normally use what you have said. If there are non-contiguous fracture, like this fracture was separate and this was separate, I would normally use a single implant. And in the previous one, if the fracture is higher up, I would also use 2 long plates if required. But this has given me another option where it can be done in a minimally invasive way. I'll just show you a newer technique. Dr. Naveen Thakkar in his oration had shown an innovation. So let's see this case and discuss what you are going to do. A 66-year-old female, 66-year-old osteoporotic, fall from height, having a fracture like this. And not affording in the sense, I'm not talking of any arthroplasty here, sir. This is a trauma 1 meeting. So I'm saying purely you have to salvage it, come what may. Patient is not going to say that I'm going for arthroplasty. Now what? Even in arthroplasty with a broken olecranon like this would be difficult. A very low fracture. If you see the fracture from the medial side, it is above the olecranon fossa. But on the lateral side, this is the combination of that lateral side, which normally gets totally resolved.
Sir, to define the fracture, I will go 1 CT, and even without CT, I can tell you some outline of the treatment.
Yeah.
Yes. So as the olecranon is already fractured, so I will go through that olecranon, and after fixing the articular fragment, I will use one pre-contoured olecranon ulna plate.
Right, great. But what problems do you anticipate while fixing this intercondylar part? I'll show you the X-ray. You can see it much. You
very
see,
low,
yeah,
very low intercondylar fracture, means the metaphyseal part is almost nil. So means this is an transcondylar fracture like this. So we will get a very difficult purchase for the means the articular portions.
exactly. Very true.
Two parallel here, not 90-90, 2 parallel plate.
Agreed. Two parallel. But
parallel.
even in 2 parallel plates on the medial side, I'm not worried. Medial side looks like a big chunk. My screw can come till here. What about the lateral one? This is all is articular. Your fracture is extending this one and this one. It's your plate is not going to have many of the fixations out here, which is there with the even with 180 degrees.
So headless screw can serve the purpose.
It's a 67-year-old lady Indian with osteoporosis. Just let's understand what means. What is the quality of bone in a 67-year-old lady in India?
Sir, we are having some experiences with this type of osteoporotic fractures. We actually do some TPWs for this, and they are giving excellent results. We have a series of actually 10 to 12 cases. So actually in these cases, we do as the olecranon is already fractured. So we go through that, means the olecranon osteotomy is not required through the posterior approach. Then we fix the with the 2 K-wires from the medial to lateral and from lateral to medial. We actually fix the
and then
fragments as much as possible. Put a screw in the diaphysis with a washer and take 2 figure-of-8 means TPWs, and they are working good, excellent results.
The problem with that only is that if this is too combinated, you might not have with a single K-wire any hold onto the distal fragment. It just will be holding the proximal fragment. I know I have seen those cases, not of yours, but of these technique of a tension band and a K-wire, which is a very good technique, I must say. And that is what we might have to resort in these osteoporotic patients, because the screws and the plates, they require some bone to be putting it, and it is not there in these patients. Any comments, sir?
My comment would be that would be ideal if you had a larger, if you had a larger lateral condyle, that would be very befitting this.
Yes.
And I can understand your hesitation. Once you put in 1 pin, there's no place for
as soon as you put in the wire to encerclage it, this wire will come out from this bone.
Yes, it will cut out.
Because it's so small a bone that as soon as you put it and do a tensioning for that with the encerclage wire above the screw, this will come out.
But
another option is positional screw.
a CT scan might help because this lateral condyle might not be exactly what it is, might be a
So
little larger.
This is the CT scan which you get. For me, intercondylar humerus, I normally do not get a CT scan because I cannot understand a single thing in that. I just open it up and see. That is the most important. I prepare for the worst, but intercondylar humerus with the orientations, it does not give you any idea regarding which fragment you are seeing and which is the what fragment. And I can show you other CTs as well if you can gather something from this. 3D gives it, but 3D bypasses and covers up many things. It will make me look very young also. So the same thing it does in the 3D as well.
So
Yes, sir, please.
actually, there is a fracture, comminuted fracture of the both the lower humerus, olecranon, and the proximal humerus also.
Sir?
Isn't it?
Yes, she also has a
Yes.
proximal humerus
And
fracture.
this is a high velocity trauma, as you know, with osteoporosis, soft tissue should be shared. So I think it is very difficult to make the internal.
And then I would,
fixation. So that
besides,
is
once
why,
we finish up intercondylar, then I want to know what
Yeah,
you are going to do
so
for
that-
the proximal humerus. You will leave it conservative or you will operate it. If you are going to operate it with which plate or which nail or K-wires, and which one will be done first? The proximal one or the distal one?
yeah. So that is why there is one solution which is coming in a big way in the future. So that is the Miro system. The Miro system is now coming in a big way. So in that case, especially we can do the Miro system in the ulna fast. So the ulna become stabilized fast. It is a Eiffel Tower concept. So you introduce the nail. There's a flexible nail. So from up downward, and with they said there's a combination of the intramedullary elastic as also the external fixation. So it would be really easy to maintain the length as also the stability of the fracture. So you'll first have to take the proximal ulna this first, then give traction and give if it is possible to assemble the intra-articular segment with either help of the traction or by the intra-jig by K-wire with the help of this jigsaw puzzles like that. So if it is articular surface is constructed, then we'd make a fixation with a transverse screw, and then one screw should be one elastic nail should be passed from the medial condyle up to the proximal humerus.
Sir, just assume those elastic nails are not going to go into these distal fragments.
No, then in that case,
these fragments, this looks very robust bone.
Yeah.
But remember, she's a 67-year-old.
I don't think I'm telling of the tense nail. So there is in between the tense and the K-wire.
Right.
So basically
I agree to your point that here the basic major screws are not going to work. You will have to use something which is tensile as well as
Exactly.
malleable and which can be used and getting the.
Yeah.
So as I can see my moderator standing right in front of me, I'll have to finish it first. And so I'll just show you a new technique how to manage, which one to choose, which we had all discussed. And this is a new technique which was there. You can see the condyles, how broken they are intraoperatively. I used the same thing. I went with with the intercondylar first. Humerus, I thought I'll do it later. And the major chunk out here was not an issue. It was normally a cakewalk, which we normally do for any intercondylar with multiple screws and stuff. The problem was here. It was entirely, it looks big bone out there, but this is the small bone, which is completely articular. There is a void out here and you cannot restore any of these things. Even if you put in a plate, your plate is not going to come till here because you're going to take out the capitulum, which is split into multiple pieces. And remember that most of these intercondylar fail because of this lateral condyle, because it is a cancellous bone. It does not have hold and it resorbs if it is avascular. Medial side, because of the thick bone, it normally works. So how I did and what I did was I put in multiple K-wires to hold this, which are thin 1.1 to 1.5 mm or less than that, multiple K-wires holding on to this. 4 to 5 K-wires holding on to this fragment and holding it coming out up to the lateral trochlea. And then I bend these K-wires, as you can see, 5 K-wires being bent on the lateral aspect of the cortex of the shaft of humerus. And then over those wires, I put in a plate. If you see this, these are the multiple stacked simple 1 mm, 1.1 mm, 1.2 mm K-wires, which have gone and holding those small fragments. And as long tension band, they are bending it. They are bending to the cortex. I have bent already 3 K wires in this image, and the next 3 I will do now. And once I do that, I took them out through one of the holes of the plate long above. So they are acting as a tension sling for that and acting as a tension band for that with a plate which is bending. Now the screws in this plate are not there in the distal part, but the K wires are coming out and the plate is holding it like a strut. If anything you can see, this is how on the lateral view it looks like. This is the lateral plate, no K wires, no screw is holding it here. All the K wires which were holding those small fragments, long one, have been put and bent along with the cortex, and a plate is now buttressing those wires.
One of these holes through the K wires.
Yes. If you can, this is the plate, multiple K wires, long, I bent them onto the cortex. Now I could have kept them along with the cortex and then put in a plate, but our plates are smaller and the cortexes are smaller. So plate will not be able to hold them. So what I did, I just took them out from one of the holes so that they remain there and do not move, and then put in all the screws except that hole.
Oh, and the plate from above to the.
Yes, sir, because these wires I can bend, and the long wires were there, I can easily stack them.
May I, sir?
Vivek, I think the middle screw is in between the 2 bunches. One bunch is if you see the 2 bunches, and the screw in between, middle screw is in between the 2 bunches. I
Yes,
believe there is a bone in between
yes,
2
yes.
bunches.
Yes.
So it has got bone there. Yeah, this screw. 2 bunches were bent.
The K
so-
wires are here. Their
Okay,
K
I
wires are
understand,
holding.
I understand.
this fracture here. They are getting bent along with the cortex long
Okay.
term, and they are
Sir,
outside.
my-
And this has
okay.
been taken from the plate here. I am trying to put in the screw bypassing the K wires from the top or down.
Hmm.
So I cannot put in these screws because they are not holding anything. So
Hmm.
my wires were holding those small fragments, and I bent them and using them as a long bent screw, which is buttressed by the plate.
So
Yes,
my
sir.
question is, sir, the K wires are not they are very tensile. K wires are very tensile structure, and when you bend it, and there is a stress at the bending point.
I agree.
And
So that is why I said it is 1.1 mm wires, not those 1.5 and above.
Sir, and so when they are just holding the fragments, small fragments, but they are putting stress downwards on the lateral.
No. They're not putting stress on the downward stress. All these wires are going from the lateral condyle right up to the trochlea and the medial side.
Yeah.
So they are holding it as a, you can say, a strut. Just all our constructions are done with the
If you back, then it is more understandable. Yeah.
But at the bending side,
Yes.
there is a quite tremendous.
This is a tension band where we have used, instead of those cortical screws in the diaphysis, a plate which is buttressing those wires and not bending, not trying to make them lift up or push the fragments anywhere. Lateral cortex.
But there is a
It's a lateral plate.
It's just a
Yes.
comment, if I may be allowed.
Yes, sir, please.
So it's just the same, like, you do it in distal radius all the time. It's a fragment specific fixation made of, the pin and constructs. You use the petrous place. So it's a very clever idea. But he has just extrapolated to distal areas. We read with the same problems. So we have very small intraarticular fragments, too small to take a screw. This is a very good bailout, and the same concept has been applied in the elbow. It's a very clever idea. Kudos to you, sir.
No, it's not kudos to me. I'll tell you the same way as he said very rightly, in the distal radius, when you have a fracture which is going at the edge of the bone, at the intracapsular region where it's a very thin rim, you just put in K wires, bend them, and then put in a volar plate over it. So it's a well-known phenomena. I'm just introducing you to this also. This is also a phenomena which is there, not my product. And then you have put in a long ulnar plate with a long screw in this. Not kudos to me, kudos to George Dyer. George Dyer, and this is a paper which he has published in 2021.
My doubt
Sir.
is that the stress that is putting on the small fragments, they are either going to fragment or they are going to necrose.
Whatever they are, but they are holding still some portion out there. They are acting as a scaffold out there. I am not right now saying that it will work all the time. I'm just saying that right now I could not have put in a plate with screws there. The screws wouldn't have anything. I couldn't hold the lateral condyle in combination by any way. So by putting in multiple wires like we normally do to hold it, I'm just trying to bend them and use those wires and use as a buttress plate, which dorsal distal radius you normally do. And it's not me. This is a paper which he is using this thing in America, where they have arthroplasty people and they can do arthroplasty in any case. He has published 20 cases or 25 cases in elderly patients of intercondylar humerus using the same K-wires and doing this fixation. So
very creditable, because in America they would do arthroplasty.
and he says that he has not done any elbow arthroplasty for the last 5 years since I met George Dyer in one of my meetings in America. And from there, I got this idea. And then within 1 month, I did this.
One question. There was a significant void. Would you be considering bone grafting? Did you bone
Yes,
graft the void?
we have taken the bone graft from the olecranon and the stuff. Biology has to be restored, but mechanics is also important.
Yes, by the wires and the biology in the.
It might fail, but the plate is working.
The chances are less.
So it's not me who has done this. I have just used and read the literature, met him and did what the people in America also have done. This is a paper I think you should all read. It's from Skinny Wires, which he says log fixation for comminuted intra-articular humerus fractures. He has done it in elderly population and excellent results without the activity restrictions of total elbow arthroplasty, which he has shown. And that's what we put in a proximal multi-lock nail for that. We had to leave this. We said, whatever it might happen, we are not going to do for the stress. And this is the final picture, how it looks like. So you can see that these wires are going multiply stacked, holding the entire intercondylar region. And then these wires are on the jetting onto the lateral cortex. I took it out from the hole because I could not have any, I was not able to place them. As soon as I was tightening the plate, they will come out of the wire. So in them, they have a Arthrex or Acumed plate, which is curved. In between the plates, the wires can be put. So this is what it looks like. And this fragment, even if it is not there, it is working as a scaffold, which will hold the mechanics for some time. No? If we do not take out the plates, why should we take out the K-wires? If we are removing the plates, then we will remove the K-wires. And to make sure that they do not migrate, I have put it inside the plate hole and also bent them. This is the follow-up at around 2 months. You can see it might be necrosing out here. The wires, the K-wires which I had put for olecranon because it was comminuted along with the plates have slightly come out. The things are moving here and there. But this is her range of motion of the elbow, which I was getting the last. So I just wanted to bring this out because this is a new technique which I also learned around 6 months back when I had gone to US and met George Dyer, and he presented a case like this. And I got this, and I've done yesterday only, while before coming to Kolkata at 3:30 in the evening, I was doing a similar case where I put in multiple K-wires. Again, it was a failed intercondylar where the screws put for the lateral condyle had just come out of that fracture. And that lateral condyle was lying distally now with the plate on the top. No, these K-wires I've used is 1 millimeter. I've used 1.5, but as one of the sirs was saying here, when you bend it, it can cause problems. So that's why I'm using 1 or 1.1 mm K-wires, which are using. Yesterday also, as a revision case for an elbow intercondylar humerus, I have done the same thing. So I'll finish it out here as it is there. Yes. And we do not use nose ply. We use the tap sleeves or something where we use the tap sleeves, and we use the tap sleeve and put the tap sleeve and bend it where we want so that the entire forces are not going onto the K-wire, but rather they are going onto the tap sleeve drill. So that's how we have to do that. And that's what we used yesterday. And it is a salvage method, a bailout method for the youngsters out here. If you have any case, failed intercondylar I have done, and this is a comminuted elderly patient with TAP. Thank you very much for your case.
Thank you so much, sir. Thank you so much.
Thank you for a very lovely session.
His presentation. And now I would like to request Professor Sandeep Ghosh to deliver a speech on newer concept in management of fracture neck opener. And I would like to call the panelists to take their seats. You can sit or you can take your seats also. Yes, thank you.
Good afternoon to all of you. Now I'm here to say about the current concept in fractured neck femur of young patients. Fractured neck femur in young patients is still an unsolved problem. What are the complications? Non-union, implant failure due to loss of reduction, avian, neck shortening, and varus collapse. What is the consensus? Internal fixation is the treatment of choice for younger patients with high functional demands and good bone stock. Patient less than 60 years old and no chronic illness, we all should do early reduction and internal fixation. What are the issues of debate? Method of close reduction, there are various methods. Choice of implant, that's another debate. Time of surgery, when to do. Capsulotomy, yes or no. Open versus close reduction, and time of weight bearing. Usually we all do close reduction, internal fixation under CM guidance, but we should avoid repeated close reduction and vigorous traction. Then fails, we should go for open reduction by either Smith-Patterson or anterolateral approach. You will see fracture neck of femur, close reduction done with the help of CM guidance with traction. Here you will see that perfect reduction was not achieved. There is a varus collapse. Ultimately has gone for replacement. Implants. Mostly convoluted hip screws are the commonly used implants till recent. Usually conventions are 3 screws in triangular configuration. Along, they are mostly placed in parallel to each other. Now the problems. 4 screws also used. Biomechanical data shows 4 screws are more stable in fracture with posterior comminution. Consider dynamic hip screw in cases also in posterior comminution. Cancer screw with fibula graft. Nagy et al. Also showed 2 screws with fibula graft in 26 patients. And all of them have united nicely except one. Dynamic hip screw in posterior comminution in severe osteoporosis and in Powell's 3 is an option. DHS with derotation screw, that is also another option that prevent rotation of the femoral head, achieve good buttressing at the fracture site. Problem in DHS, huge amount of bone has to be removed. Off screw, that is another option with parallel canceller screw. DHS, derotation screw and off screw. So combination is also another option for fracture neck of femur. Medial buttressing, this is another option along with cannulated canceller screw. Tarragon fixation system, that is also mentioned by Parker et al. In their study. Conquest FN system by Smith and nephew, that is also an option for fracture neck of femur. AO also mentioned that femoral neck system for fracture neck of femur. Now capsulotomy. Yes or no? Usual any clinical improvement or not? Obviously, capsulotomy reduces intracapsular pressure from hematoma, but increased intracapsular pressure not associated with AVN. So 80% patient with AVN had low intracapsular pressure. So capsulotomy is not recommended. Now time to surgery, difference and no difference. Dakwit et al. Mentioned that 122 patients of less than 60 years and having 39 complications and more than 24 hours increased failure rates are very high. Now open reduction versus closed reduction. Some recent data favoring the closed reduction. Peterson also mentioned and GEOT 2022 that 234 patients with displaced fractures, 106 patients, open reduction, that is 35 reoperations, and 128 closed reduction having 22 reoperations. So overall, 2.4% increased risk of reoperation in open reduction group. So what is the current consensus? Urgent surgery is required, but not emergency. Anatomic reduction should be there. There should not be in a hurry. Anatomic reduction must be there. And try gentle close reduction first. Low threshold for open reduction. Approach should be positive. And fixation should be stable. And we want compression, but not excessive collapse. Thank you.
Thank you, sir. Now I'd like to request Professor A.K. Pal to deliver his speech on newer concept in minimally invasive management of upper limb fractures.
Good afternoon, everybody, respected chairpersons and delegates. Now I'm going to discuss a newer method of fixation, which will solve the problem even Dr. Trikha has identified. There's a double fracture, triple fracture, everything can be taken in a single way. So this I'm going to introduce this Miro system. It's a system consisting of 3 units. It's the Eiffel Tower concept. This is the first one is a primary the elastic interosseous wires, which is in between the tensional and the K wire. It is much more elastic than the K wire and is much more less thinner and much stronger than the K wire. So the secondary unit is a Prakash clamp. See that this is a special clamp, rounded clamp, and the tertiary is another instrument used for this is the connection. So that will maintain this concept, this Eiffel Tower concept. It maintains the 2 column that may compress if there is a metaphyseal fracture, as also it spans the articular surface. So in there is any articular fracture, that will this configuration is maintained. So see, this is a fracture where the two longitudinal intermediary wires are passed to the one is to the radial styloid process, another through the this junction between the third and fourth in the compartment, extensor compartment. And there is another optional screw. They have the screw is not used, but another optional screw can be used to the metaphysis if you require some compression or the distraction. And this is 35 years old male. It's a closed fracture, high diabetic patient, and so this is the very, very good options. This is another case. As you can see here, the 28 years old male, closed fracture is a deep abrasion, a poor skin condition, severe intra-articular combination. Similarly, two intramedullary rods, which are using the two columns, it is done along with the one metaphyseal rod, and that this is compressed with the specific clamp. And this clamp is almost double or triple stronger than the AO clamp, and is almost 10 times stronger than the biomechanically studied already done. So this is the how much combination it is here. So 65 years old female, severe osteoporotic, arthritic, fall on ground. See, so the article first restrict should be done to the articular process, and by anything with the help of the outside. So with the help of the K-wires, the articular configuration is maintained. And so it is this the first metaphyseal K-wire is put first, and then there is a two column there's two intermediary fixation with the help of the two columns. And after 8 weeks, they say it was removed, and see the function. This is almost. So in another case, the 31 years females fall from height, grade 1 open fracture, same thing can be done. This is a severe combination over here that can maintain. And see, this is the post-op results, and see the satisfactory functional recovery in 3 months. This is the satisfactory recovery. See, the whole unit is united. And see, this is the case. This is the double fracture. This is a fracture over here and fracture over there. So the same thing can be done with the help of this. This is considered fast, the articular configuration, then the two metaphyseal wires. And similarly, this that can be done. That is by K-wire from outside. The reduction is done, and there are 1 or 2, 3 wires, and both the wires are connected with a single clamp. So this is the case. 35 years old fell, 2 sets of proximal above downwards. And see, this is the 2 above downwards, 2 proximal K-wires, and also another 2 sets of distal to proximal wire to engage in the subchondral, not to cross the articular surface, and it is connected with these rods. See, this is another case. This is the adolescent. This fracture is treated with this. Even in the immature bone, that can be done with this. This is my series. I have done this is the fracture over here. This same thing I feel tower concept. See, this is that is done. This is another way of using the suture material I have shown to the Dr. Shujit Nandi. And this is my case. It's a 2 parallel wires passed from above downwards. It's a metaphyseal fracture, and another 2 K-wires from below upwards. And this is my technique. Actually, I've used the clamp, only 2 J clamp, and it is so strong that the movement can be started from initial period. So this is the young lady who is actually the polytrauma patients. This is not in that time we didn't get the long K-wires. It is a 12-inch K-wire I have used in other cases, and ultimately it is united with excellent function. So it's a double fracture in the single limb. You can see here, double fracture in single limbs. It is used in this principle, but not in the actual mirrors. But then it is united. You can see here, it's double fracture. This is my case, another case. See, this is the metaphyseal fracture. This on the metaphyseal screw and the two longitudinal screw, it is united like this. Is a non-spanning fixator. So biomechanics. So basically, it helps. It's based on the fixation of both the terminal columns of the bone. It spreads through the whole of the medullary canal, so maintain the axial length. One transverse metaphyseal wire and assembly with the longitudinal ones that maintains the epiphyseal as anatomy, rotational stability, as on the prevents the pin loosening. Elastic recoil of the longitudinal wears maintain the articular integrity. The stability provides the micromotion at the metaphyseal fracture. The strategic connection of this metaphyseal wear along with the longitudinal, it requires we can maintain either the compression in case of transverse fracture, or if it is a comminuted fracture, we may need distraction. Whatever it can be done, everything can be done. So functional advantage, clamps are far more stronger than the AORGS clamp already. It is highly satisfactory, especially for the metaphyseal fracture along with articular. It is an excellent proposition. I think that in Dr. Vivek Trikha's case, that should be the ideal one. Thank you.
Hello, Anando, it's an excellent new technique. Now I want to have sort of a modified tension band principle. I wanted to know about those special clamps, where it is available, and
Yes,
describe a
it
little
is
bit more
available
about it.
by L Prakash, but it is 5,000 rupees cost. So for my patients, it is not affordable. That is why I modified this technique with the help of the GS clamp. So I used, so what is the characteristics of this special clamp? There are four wires can be accommodated inside that. And another important, if it goes inside, it is very difficult to come out. So that indicates a significant strong fixation. That is the special.
So you use GS clamp always?
I'm using the GS clamp and I've modified the technique. So I have used it. I introduced the K-wire and bend the K-wire. Bend the K-wire so that if it is at all, it becomes our main motto is the early mobilization. Okay, so if mobilization, if it at all loosen, it will not come out because the K-wire is bent at the end. So I have modified my technique like in this way.
And is it the normal ordinary K-wire or it's something?
No, it is. I have used the long, the 12-inch K-wire is not normally available.
Length.
Is not normally available, and I have actually a special order given for this.
Sir, GS clamp for.
Pardon? This is actually it's not abbreviation. It's not abbreviation at all. So it is actually, it is invented by I think there is as per invention, they have turned its name is Miros.
So GS clamps are only for the covering the sharp ends of the cut end of the cable.
For connection. So the two assemblies, suppose in the humerus, two assemblies are connected in significant compression. That is important to prevent the pin loosening. And after introducing the two K-wires, it is bent. And I have started the early mobilization at least 2 to 3 third postoperative day. Our problem is there is a chance of loosening of the screws. It is most often seen in the JS link rock. That is how I modified the technique that I bent it. Once it goes inside, so once it is loose, it will not come out unless it is cut.
Thank you so much, sir. May I call Dr. Saurabh Ghosh to deliver a speech on newer concept in acetabular fractures.
Good afternoon to my seniors, colleagues, and juniors. I will talk on recent advances in acetabular surgery. So to know the recent advances, we have to dig into the past also. So acetabular fracture was unknown till 1818 when Sir Ashley Cooper described acetabular fracture in an autopsy case in RTA patient. Before that, it was thought as a posterior dislocation of a hip. The fracture was treated conservatively long after its description till 1964 when Luternal and Judet came with their concept of 2-column and classified the acetabular fractures and told us about the surgical approaches for open reduction. In 1965, Luternal described the ilioinguinal approach, which is a 5-window anterior approach through which we can address the whole of the anterior column and associated fractures. It was in 1994 when modified Stopak came into this our field, and through which we can address the anterior column fracture. Along with the lateral window, we can access the whole anterior column. Also, the posterior column can be accessible with that. So we are along with this, with KL approach, we can fix the both columns. With time, we are thinking of having single approach to fix the both the columns. So we have magic screws through which we can access the opposite column through one approach. We have anterior to posterior screw and posterior to anterior column screws. We can give the screws through the plate and outside the plate also. So now we are thinking to address the posterior column fixation with stopper approach only. So we are giving 60-degree plate to the pectineal line. We can fix the posterior column with or without screw by buttressing with a plate. We have pararectus approach, which combines the ilioinguinal and stopper approach, through which we have overcome the difficulties of ilioinguinal approach, and we can access the joint which is not accessible in the stopper approach. So now we can access whole of the acetabular fractures through the stopper along with lateral window approach. So the approach of choice for today is the stopper with lateral window. In implants and instrument, we have radiolucent retractors with drill slots, which eases our surgeries intraoperatively to visualize better under C-arms. We have quadrangular plates to buttress the quadrangular surface. We have also a quadrilateral surface plate, which can buttress directly the quadrilateral fractures with or without screw placements. So what is the future? Is it 3D printing, through which we can make a 3D model simulating the fracture? We can reduce the fracture with contouring the plates and replicate it in the patients to get a better fixation. But it is a costly and cumbersome procedure. So is it intraoperative CT scan, which it is helpful to assess our intraoperative joint line steps and reductions. We can give percutaneous screws through intraoperative CT, but what about the radiation exposure? So is it the robotic surgery, which is the future, which uses the optical trackers like in total knee replacements, where we can get the 3D images without radiation hazards, and we can fix the fractures and assess it intraoperatively. So with these advances, we are heading towards more accurate and advanced fixation of the acetabular surgeries. Thank you.
Thank you, Dr. Saurabh Ghosh. As we are running late, may I request Dr. Sajil Khan to deliver speech on recent concepts in AC joint reconstruction.
Good evening, everyone, respected chairpersons and all faculty and delegates. I'm going to be presenting techniques in AC joint disruption and new updates. So this is Rockwood classification, as we are all aware. Type 1 and type 2 are basically treated conservatively, while the type 4 to type 6 are usually treated with surgery. Type 3 is still a gray area where surgery is warranted in some cases, particularly if there is persistent pain and for cosmetic deformity as well. So what are the common surgical procedures that we are well aware of? Hook plate has been around for a really long time. This is one of my own cases done. And the problem, as we are aware about this hook plate, is that it causes some amount of impingement, which may lead to reduced range of movement, and it warrants removal of the implant a few months after the surgery. Next, we have Bosworth screw, where a cannulated screw is passed from the lateral end of the clavicle to hold the coracoid. The problem with this as well is there are chances of implant loosening. So there have been modifications of this where the coracoclavicular ligaments are also reconstructed along with the Bosworth screw. So moving on to the third one, we have the Weaver-Dunn procedure. This is a reconstruction of basically the coracoclavicular ligament with the help of a coracoacromial ligament. The lateral end of the clavicle is cut and the coracoacromial ligament is taken off from the acromial process, and it is inserted into the cut end of the clavicle, and it is basically reconstruction. It's a non-anatomical repair because we are attaching the coracoacromial ligament to a much lateral position than where the native CC ligaments are present. Apart from this, we have K-wire fixations. Of course, many of us have seen it in our clinical day-to-day practice, horrendous outcomes with this because K-wire is very notorious for migrating here and there. So in this particular case, there is a Bosworth screw with K-wire fixation. So moving on. We also have fixation techniques in the form of, we can use sutures, heavy sutures like Ethibond, Marceline tape, fiber tape, and we can use them to fix with the help of some hardware in the form of endo buttons. Endo buttons can be used on both sides. Then we can have combination like endo buttons and suture anchors, and we also have tight rope, right? So these hardwares and heavy sutures, they are used to basically reconstruct the CC ligament. Now, the newer techniques that have been coming out emphasize mostly on biological reconstruction of the CC ligament. Basically, they argue against the use of implants because there are hardware-related issues, and implants have a tendency of giving too rigid fixation. So that is why they don't want it to be very rigid. So that is why these biological reconstruction are favored nowadays in the form of semi-T or gracilis grafts. Apart from that, it is argued that anatomical reconstruction of the CC ligament is important, as opposed to like the classical Weaver-Dunn procedure where the reconstruction was far off laterally, so that there is a change in the direction of forces. So the ideal point is 35 mm medial to the acromoclavicular joint. And if it's not a very osteoporotic patient, 2 drill holes should be preferred so that both the conoid and the trapezoid ligaments of the CC ligament, both are reconstructed. So I would like to point out to this paper, which was published by Babulkar. And he has his own technique. He does this biological reconstruction of the CC ligament using semi-T graft. So the image on the left side is basically Dr. Babulkar's technique, which I have shown over here. And on the right, you can see another technique where there are 2 drill holes made onto the clavicle, and they are tied upon themselves. This is an X-ray taken from his paper. This is an old patient wherein the lateral end of the clavicle is there's an old fractured dislocation. This is a 12-month-old dislocation. So the lateral end of the clavicle is taken off, and using the image on the left side, that was what was performed in this particular case. So the lateral end of clavicle, they are advocating should be removed because there is chondrolysis and basically AC joint arthritis in up to 20% of cases. So the lateral end of clavicle, about 8 mm of it is taken off to prevent this post-operative pain. Finally, we also have newer techniques in the form of arthroscopic reconstruction of the AC joint. Herein, we see this example. I've taken this from YouTube. This is an Arthrex video. So they have this jig through which you can arthroscopically insert the wires through which you can shuttle a dog bone endo button. So this is the dog bone endo button being passed. So it is first anchored onto the lower end, and then from the upper end, after reduction, it is tied and finally cut. So this is a newer technique, which is arthroscopic. So the take-home messages are anatomical reconstruction of CC joint is preferable compared to non-anatomical ones. Biological fixation is favored more because there are implant and hardware-related issues. And arthroscopic method is, of course, a minimally invasive technique, which may provide early rehabilitation and better functional outcomes. But there is, of course, scope for a lot of research on this, whether arthroscopic or biological fixation is the new gold standard. Thank you.
Thank you, Dr. Surgical, for finishing in exact time. Now, may I call Dr. Ravi Bharadwaj to deliver the speech on newer concept in digital radius fracture. Yeah. Yes, sir. You can ask us. You can ask us. You can ask now.
So you have.
We are running late, actually.
One thing, you have included. You have included your cases of type 4 and type 4, type 5 and type 6.
Sir, there was only one of my case, the first one using hook plate, that was in a type 3 patient, type 3 fracture type. The others were not my own cases.
So types 4, type 6 is included. What in your talk? I have noted
So literature is saying that type 4 to type 6 all should be
yes,
fixed.
but my surprise is that type 6 is inferior dislocation.
Yes, sir.
And in that case, how it will help? How your technique will help?
So which of the technique?
In the type 6, in type 6, in the type 4, which is posterior, type 5, which is superior, they may be helped by this technique. But how it is helped when the displacement is inferior?
It's
Then
not
how it
possible arthroscopically. It won't be, sir. No.
Okay, may I start?
is sling, you are making sling, isn't it? There's an endobaton in the coracoid process and also endobaton in
The lateral end of clavicle. We are drilling holes
So
through it
they
and passing the.
They will help in to, or they will prevent to going apart,
Yes, sir.
not closing. But when it is already inferior, then how it will?
Sir, I don't have any experience in the inferior dislocation, so I'll have to look through it. Thank you, sir.
Okay. May I start? So, dear Chairperson, sir, thank you very much for the opportunity. My brief is to talk on newer concepts in distal radius fractures, and I know the time is running. We are running late, so we'll keep it short. So you have to appreciate that distal radius fractures are a very varied spectrum of injury. They are not a homogeneous bunch. So they may range from simple fractures all the way to complex fracture dislocations. This we already know. We know about the radiological parameters for what is an acceptable reduction, regardless of the method of choice of fixation, whether it's a K-wires or an external fixator or internal fixation. These are the accepted generally radiological parameters for reduction. But some facts about distal radius fracture, we know that it is a bimodal distribution with two main peaks. The first peak occurring mostly in females in postmenopausal, these are extraarticular and caused by low energy mechanism of injury with osteoporosis. And the other peak is in mostly male preponderance, less than 50 years of age, high energy, complex intraarticular fractures, which show collapse and they have carpal instability associated. Now, these are entirely two different subsets of injuries, although they come under the common heading of distal radius fractures. And they are as different as apples and from oranges. So we should not confuse the two. So when you talk about newer concepts, we have to understand what has changed. First of all, patient expectations. So what would have been, functional malunion, so to speak of, is no longer acceptable by many patients in today's date and age who want to do this, they want to do this, they want to do this, and they want to do this. So basically it boils down to a case of ye dil mange more. What else has changed in the last couple of decades? Well, we have been using increasingly CT scans more and more to identify fracture patterns, especially the complex ones. Our own understanding of complex fracture patterns as a result of using these CT scans and the deforming forces has changed appreciably in the last couple of decades. And now we have better implants specifically targeting specific fracture patterns. CT, the indication and usage, they're very useful. Intraarticular fractures for involvement of DRUGN, they detect both the approach and the screw trajectory. The three-column concept has been around for more than a couple of decades. From 1996, we know about the role of the radial column, the intermediate column and the ulnar column and distal radius fractures. And more recently, the intermediate column has been sort of studied in greater detail. We know that there are dorsal lunate fossa fragments and volar lunate fossa fragments, each with its own role. And another concept which has come into recently, the last 1 decade, is the concept of Brink et al., the key corner, where they talk about the key corner being studied on the sagittal CT cut of the intermediate column. And it is very important to determine the key corner and fix it usually by using some sort of a buttress, whether it's a plate or some other method. And it is based on the direction in which the lunate is sublux. For example, if you look at this, the lunate is sublux volarly, so the key corner is volar. Here, the lunate has sublux in the intermediate CT. It has more sublux dorsally. So it's the dorsal intermediate column is the key column. So the other important concept recently, which has been drawing a lot of attention, is the importance of the teardrop angle. The teardrop actually represents the volar rim of the lunate fossa, and it's best seen on a lateral view of the wrist in 10 degrees of elevation, somewhat like this. The normal value is 70 degree. What it basically is a long axis along the axis of the radius and one along the center of the teardrop, where they intersect, form the angle called the teardrop angle. So now many a time we get away with a fixation like this and we think we've got good reduction of the articular surface. But unless the teardrop is corrected, you see it's obviously reduced here. It's no longer 70 degrees. Unless this is corrected properly, you might get distal radius is that way a forgiving fracture. But if you compare grip strength and if you do a dash score and everything, that is where you will be caught out and you will see that, you have not done as well as you think you have. So this is a very good paper by Jupiter, Rickley, and a lot of big shots. This has been published in the Journal of Hand Surgery in June 2019. The correlation between teardrop angle and the anterior lunate fossa displacement in plating of distal radius fractures. I will send it on the WhatsApp group. Please have a read when you have time. Now, Madoff has given this classification about fractures, a long time. And this was in 2005. And as a result, a lot of fractures implants have been designed specifically keeping this individual fragments in mind. These are basically very low profile pin and plate systems. The volar lunate fossa fragment dictates not only a separate approach, but a specific implant also. And this implant is very useful for tackling this type of fractures. Volar rim fractures are treated, with marginal rim plates, which extend beyond the watershed line. Distal ulnar fractures, there's always been a dilemma whether you should fix them, the styloid fractures. And there have been papers, which have been sort of pro and against fixation. But in general, rule of thumb is if they're more than 2 millimeters displaced or you have an unstable DRUJ after you fixed your distal radius, and in neck of ulnar fractures, in high demand patients, especially, it is better to fix them. Nowadays, you have a lot of newer implants like hook plates, you have locking plates, and this is by Randy Binder. This is a pin plate you can use to fix these fractures. They have been talking about intramedullary implants, and the industry is trying to seduce us to trying to use this more and more. The logic which they bring out is these are intramedullary, so you don't have any tendon gliding problems. This is a nitinol cage into which you can fire locking screws, and it's entirely intramedullary except this bit here at the entry, and it has a very low profile. The other implant they talk about is the distal radius micro nail, which you can introduce to the radial styloid. This is also an intramedullary device, so it obviates the problems caused by tendon gliding and irritation and rupture, etc. Newer plates, we have a lot of these, and each claims to be better than other. But in conclusion, the bottom line is the take-home message is high energy distal radius mechanism in younger patients require a more aggressive approach. Get a CT scan, use the column concept and key concept for planning. X-fix and ligamentotaxis cannot reduce a die punch fracture. Fragment-specific fixation is very useful. And any newer implant needs to be evaluated very carefully. My boss in Scotland always used to say, many a time, these are all elegant solutions to non-existent problems. We have to be sure that that's not the case with these. So I leave you with this food for thought. As to methods, there may be a million, but principles are always few. And the man who grasps principles can always successfully devise his own methods. Thank you very much.
Thank you, Dr. Rohit. And now may I call Dr. Kaustav Mukherjee.
Good evening, everyone. I'll be sharing my research work on predicting the anatomical location of the neck of femur fractures in osteoporotic geriatric Indian population. So we are very commonly known that neck of femur fractures are very common worldwide, almost 30% incidence. And we have an anatomical classification that divides the neck into 3 zones. There is subcapital, transcervical, and basicervical region. But there is a gray zone. There is no clear demarcation of these zones. So localizing these fractures might not seem important from a clinical or a treatment point of view, but it's just an eager mind that wants to know why it happens. So osteoporosis is generally seen or analyzed by the bone mineral density or DEXA scan. And though it is considered a gold standard, but it generally overgeneralizes the condition. Trabecular pattern in proximal femur has long been used, especially in the form of Singh's index, to see at the osteoporosis in the proximal femur. So this is a pictorial depiction of how you see the trabecular pattern, the proximal, the compressile, and the trabecular patterns. And this is a Sinks index that has been graded from 6 to 1. So the aim and objectives of this study is that to find a correlation of the location of the neck of femur fractures with the degree of osteoporosis and the Sinks index. And we hypothesized our study that Sinks index 4 and above had a propensity for a transcervical fracture, and while Sinks index 3 or below had a more tendency for a more proximal fracture, especially in the subcapital region. So this study was done in Ramchandra University in Chennai and spanned over 5 years, 2015 to 2020. All radiographs, patients over 60 years who sustained was assessed from the PACS. We total analyzed 556 radiographs, and inclusion criteria were hip slip and fall. Exclusion, like any high velocity injury, contralateral hip surgery, renal failure, like all the comorbids that weakens the bone, were excluded from the study. We obtained preoperative AP radiographs and we analyzed the contralateral hip trabecular pattern, which was done independently by 3 orthopedic residents. And ipsilateral hip traction and rotation view were taken to see the location of the neck of femur, and femoral head biopsies were done for all patients. So this is how we have done. We have taken 3 points. One is A, that is at the medial point, just at the point where the neck transforms into the trochanter. C, that is at the inferomedial point of the head and the neck. And the B, that is the point where the trochanter starts with the neck. Now we join these 2 lines, and then we draw a parallel, just parallel to this line. And then we draw a perpendicular which goes through the fovea. Now we get this line, we divide this line equally into 3 parts, and that gives us the 3 zones, the subcapital, the transcervical, and the basicervical zones. So the patients were divided into 3 groups, the 60 to 70 years, 70 to 80 years, and above 80 years. And a control group was also done from the patients in age group of 20 to 60 years, and we obtained the CT scan, and same inclusion and exclusion criteria applied for the control group as well. So this is an example of the control group where a pelvis x-rays and the CT scan were done. Coming to the results, total of 361 patients were evaluated and the mean age was 74.88 years. In the 3 groups, we found that transcervical was the most common fracture, and patients over 80 years had mostly subcapital fracture. If you see at the patient demographics, the female patients are most commonly involved. And if you see at the fracture location, all over the study, transcervicals was found to be the most common type. Now, if we see the charting according to the Sinks index, then we found that as the Sinks index worsened, that is more osteoporosis, there was a shift of fracture from the towards more proximal, that means more towards the subcapital region. So in the control group, if we see, we just saw the opposite pattern. In control group, we had mostly the young patients, and these young patients showed that they have a stronger Sinks, the better bone quality, that means a higher Sinks index, 6 or 5, and mostly they showed a transcervical or a basicervical fractures. So coming to the case example, 82-year-old lady, Sinks index grading 3, sustained a subcapital fracture. Another case example where a 66-year-old lady, Sinks index grading 4, sustained again a cervical fracture. And if we come to the discussion, it has been that there has been a lot of studies, but there is a void to explain the exact biomechanics and the patterns of this fracture. The primary objective of this study is that whether on simple X-rays we can predict the location of these fractures or not. There has been a study by Ogat et al. Who have seen that the biomechanics of the femoral fractures have been a long relation with the bone mineral density and the Sinks index. And Singh already has explained this, and that thing was again stressed by Watcher et al. And Bass et al. In their study, where they have stated they found a good correlation between the BMD and Sinks index. So Sinks index alone is good enough to state the osteoporosis of the patient. In our study, we had we independently analyzed 3 in the radiographic analyzers, and we have found a good inter and intra observer reliability grading the Sinks index, which are all found to be statistically significant. There have been a lot of studies that have stated that according to Tristan et al. And Liu et al., that reliability of the trabecular pattern analysis in predicting hip fracture susceptibility is a good thing. And our study evaluated the proximal femur digital radiographs and utilized the Sinks index to grade the osteoporosis. So in our study, we found that there is a shift in location of the fractures with age. Transcervical fractures being most common in the age 60 to 70 years. And 70 to 80 years, whereas the subcapital being the most common in patients above 80 years. Females recorded a higher incidence of fractures, and comorbids did not play a significant factor in determining the site of the neck of femur fractures. So this is a descriptive study of all the location of the transcervical, basicervical, and subcapital fractures. And we acknowledge certain limitations, like Sinks index obviously remains a question of debate. And we evaluated the contralateral hip for the trabecular pattern. And coming to the conclusion, you say that majority of the neck of femur fractures in elderly had a transcervical location, and transcervical fractures are more common in patients with Sings index 4 and subcapital in the Sings index 3. And thus we come to the conclusion that there is a definite shift of the location of neck of femur fracture with worsening osteoporosis. Thank you.
Thank you. Thank you so much, Dr.
So, Kostov, can I ask one?
Yes, yes.
So what kind of study this is? Is it case control?
This is, yeah, case control. I had a case group, I had a control group.
Okay. And
Yes, sir.
and the second is, what is the clinical relevance?
Yeah, that's I started from front only, sir. There is no clinical relevance. We just analyzed the cases thinking of doing one study. While analyzing the cases, we found this interesting pattern. This was never at all the first go-to intention to do this study. We were analyzing the X-rays in our institution for doing some other study on arthroplasty or neck femur. Then while analyzing this X-ray, we came up to this interesting finding.
Well, that's my question. That was my question.
Thank you. Okay, thank you, sir.
Thank you, Dr. Kostov Mukherjee. May I request Dr. Somendu Nag?
Good afternoon, everybody. My topic will be outcomes of proximal tibia fractures based on CT-based approach. So, as we all know that most tibial plateau fractures are a result of high energy injury. But what is the most important thing is that we have to fully understand the fracture pattern, and that is the basis for a successful treatment. The standard imaging classification is we all know is the AO classification and the Schatzger classification, but the problem with them is that they classification is mainly based on the AP and the lateral views. Okay, so some of these fractures are easy to misunderstand, especially when it involves the posterior aspect of the tibial plateau and also the coronal plane fractures, which are very easy to miss in the AP standard radiographs. So there was a paper by Liu et al. In the Journal of Orthopedic Surgery in the year 2010, in which they described the 3-column classification, which is mainly the posterior column is understood as a single column and one medial column and the lateral column. So in our hospital, we included 24 patients of the age group of 18 to 65. All closed and open up to 3A were included in the study. So every patient underwent a pre-op CT scan, and based on the fracture geometry, approach was done, and the outcomes were evaluated post-operatively by the modified Rasmussen score. So these are some of the cases which we operated. So this first case is a 29-year-old male patient. There was a history of RTA. It was a closed injury, and there was no DNVD. So what we can see that this subtle fracture line is extending here, along with it looks like a kind of an ACL avulsion injury. So a CT scan was done, which clearly shows that there is a posterior medial component in all the 3 slides, and the transverse cut showing. We decide our approach on the basis of this slide only, because it's showing a posterior medial component along with an ACL avulsion injury. So we went with a standard and posterior medial approach, and with a separate midline approach, we fixed the ACL component with an suture disc. So this is the immediate post-op X-ray showing the AP and the lateral, showing the fracture apex is nicely buttressed, and the ACL avulsion, which was previously there, it is nicely reduced. So this is the post-op CAT scan showing the reduced ACL avulsion fragment and the fracture buttressed posterior medial component. So this was one case. This is the second case, a 35-year-old male patient, history of RTA. There was a wound on the medial aspect of the leg, and the skin was not good initially there, and there was no distal neurovascular deficit. So this is the X-ray showing like this. So we did a CT scan. So what I want to show in this CT scan is that in the posterior aspect, there were 3 independent fragments. Okay, so in the posterior 3 independent fragments, and from the anterior there was anterolateral fragment. Anterolateral fragment was there. So this is the transverse section. So what I want to show is that there were 4 isolated fragments at the level of the fibular head. So what we did was that we through a Lobenhofer approach, we accessed all the 3 components separately. We buttressed them. After the fixation was rigid posteriorly, we approached it from the anteromedial aspect and did the buttress plating. So this was the result, AP and the lateral post-op X-ray. And the patient at 6 months follow-up, he's showing reasonably good ROM, full SRI, reasonably good ROM is showing. And this is the 3rd case. This was a 54-year male patient with a history of domestic fall, closed injury. So the X-ray is looking very benign like this, especially in the AP X-ray. And the lateral, there is a chunk, ACL avulsion chunk, it is looking like that. But when we did the CT scan, it's showing one big posteromedial component, which was not seen in the standard AP X-ray. And in the transverse cut section, what I want to show is that there is 2 fracture, 2 fragments were there. Okay, so this is the 1 fragment, and this is the this is the second one, which is shown in the yellow. This one is the yellow, and this is the red one. So what we did was that through this Lobenhofer approach, we accessed the fracture and did the buttress plating of both the components separately. What I wanted to highlight here is that even in far lateral, this fractures also can be accessed by a Lobenhofer approach. We don't have to do that posterolateral approach. That I want to highlight in this case. And this is the 4th case. This was 20-year male patient with history of RTA, closed injury, no DNVD. So this was the X-ray, AP X-ray. So what we can make out is that there is a metaphyseal fracture extending, the beak extending posteriorly, and there is a subtle sign of PCL injury also is there. So we did the CAT scan, and what we found that there was definitely a PCL avulsion injury was there. Along with that, there is the beak was extending posteriorly. So the very unstable and very bad and very unstable fracture. So what we did was that we opened it from the Lobenhofer approach. Posteriorly, we did the screw for the PCL, and with the same approach, we did the buttress plating with the LCP. So what I wanted to highlight that posterior, we did the posterior tibial plating by slowly erasing the soleus muscle and dissecting slowly. We could apply the posterior plate over the tibia, and anterolateral plate we applied. So majority of the patients were of the age group of 31 to 40. And the mean Rasmussen score was 25.0, which was fair. Average, the maximum patient showed good results, followed by excellent and fair, and only 12%, that is three patients showed poor results. So my take home message is that we should not rely on only the AP lateral X-ray, standard X-ray. Even benign looking proximal tibial fractures need to be should be done. We should do a CT scan to avoid any nasty intraoperative surprises. And every column is equally important and requires good fixation individually. And last thing is that even far lateral can be accessed by the Lobenhofer approach. Thank you very much.
Thank you so much, Dr. Somendranath. May I call Dr. Ran Dalal kindly to deliver his speech on the open outcome of bilateral open both bone lobe fracture managed with tibial nail and anterolateral plating.
Good afternoon, everyone. The topic of today's discussion is functional outcome of bilateral open both bone leg fracture managed with tibia nail and anterolateral plating. Coming to the case history, we have a 26-year-old young male who came to our emergency department with history of road traffic accident. In the right-hand side, we can see both bone leg fracture, which is transverse in nature, and on the left-hand side, we can see that there is comminuted distal end of tibia fracture along with fibula fracture. We have done the local examinations and it revealed open GA type 1 fracture in the right lower limb and open GA type 3B fracture in the left lower limb. The vitals were stable in the patient and the chest and abdominal examinations and CNS examinations were within normal limit. We found no distal neurovascular deficits in these patients. We have proceeded to manage the case as with the definitive protocol. The wounds were adequately washed with normal saline and the patient was put on IV antibiotics. The right lower limb was immobilized with long leg slab after proper wound debridement. In the left lower limb, we performed ankle spanning X-fix, and the fibula was fixed with tense nail on an emergency basis. This is the clinical image of the X-fix being done with 3 shunt pin and the calcaneum Denham pin. This is the ankle spanning X-fix of the left lower limb. Then coming to the operative steps, after 2 days of the X-fix being done, close reduction internal fixation of right tibia done with intermedullary interlocking tibia and L, and the flap coverage of the left-sided open 3B GA type 3B fracture was done by the plastic surgery department after 1 cycle of VAC therapy. Then the patient was followed up at regular intervals, and static quadriceps exercises, knee bending exercises were given to the patient. After 2 months, the patient was admitted and the X-fix was removed. He was then put on long extension knee brace for the left lower limb to address the pin tract site infection. After proper wound healing, the management of the left distal tibia was done with 5-hole anterolateral plate and ipsilateral corticocancellous iliac case bone graft. This is the follow-up. We can see on the right-hand side that there is healed fracture with adequate callus formation. And on the left-hand side, we can see that the fracture ends showing adequate callus formation where corticocancellous iliac case bone graft was done. This is the clinical image of the healed wound at 6 months follow-up. We can see that on the right-hand side where puncture wound was present, it healed very well, and there were no signs of any sinus tract infection. And on the left-hand side where flap coverage was done, it healed well. These are the range of movements which shows plantar and dorsiflexion at 6 months of follow-up. And these are the knee movements which we can see at 6 months follow-up. And this is the video showing that the patient can walk, but with some antalgic gait. So coming to the conclusion part, the open fractures, especially around the leg and ankle, are difficult to manage as these are associated with infection, non-union, and poor wound healing. Adequate wound washing and debridement, intravenous antibiotic coverage, and primary external fixation constitutes the damage control orthopedics part. Later, when the wound heals, the patient can be taken up for definitive management, and we have to do long-term follow-up to get good functional outcome. Thank you.
Thank you. Thank you, Dr. Andalan. Now we come to the last talk of the session, Dr. Trinath Nath Sharma.
Good evening to my respected teachers and my dear colleagues. Now I am presenting my study, assessment of outcome in old traumatic fracture neck of femur fixed with dynamic hip screw and iliac bone graft. The management of the displaced fractures are challenging and not a single procedure available practice universally applicable right now. And various studies show that DHS is more stable in the treatment of unstable neck of femur fracture, and the success rate is using autologous bone graft is 73%. Some of the review of literatures are there. Shenzhen et al. Compare bone healing of neck of femur fracture treated with hollow bone graft DHS and standard DHS and found better bone healing scores and trabecular bone volume percentage and BMD assessed on the plain radiograph and CT scans. And Lizzie et al. Compare clinical effort of a short DHS with fibular bone graft and short DHS with cannulated screws in young adult. They found shortened healing time and reduced rate of non-union and head osteonecrosis in bone graft groups. My case, case one, there is a 30-year-old female patient with 2-month old history of injury with mechanism injuries, domestic fall, having this pre-operative X-rays initial when the patient come, and after 2 months. And these are the some intraoperative bone graft are taken from the iliac crest, and the bone graft is being drilled, and bone graft insertion on the intraoperatively, and the DHS was done, and these are the post of follow-up after 12 post-op day and 2 months. Then 3 months, these are the 4-month post-op, then 6 months, and there is a clinical range of motion, good SLR and flexion and squatting. Case 2 is that a 32-year male patient with 3-month-old injuries, mechanism injury, road traffic accident. Intraoperatively, same procedure done. As a 3-month follow-up pictures and 6-month follow-up, and these are the range of motion. The take-home message is this technique of using ICBG combined with DHS gives good and reproducible result. And the advantage of this technique is technically easier than the muscle pedicle grafting and can be done with conventional fracture tables. Thank you.
Thank you, Dr. Tina. Now we are going to end the AOTA session. And I would like to call Professor A.K. Pal to deliver a talk in a novel approach to pain management.
So good afternoon, everybody. So just I am standing between these all you all and also the GB meeting. But I'm just going to discuss a very important topic, which is not only the bread and butter of the orthopedic surgeons, but also the whole communities, all doctors. So basically, it is a novel approach of management of chronic pain. As you can see here, see that the cell level, you have to think of the cell level. It is three gates of to enter the pain perception inside the body, like the astrocyte, microglia, and the stem cells, which stimulate the central neuron to reach the sensation into the brain. Now, the chronic pain produces a vicious cycle. The pain produces muscle tension, reduced circulation, muscle inflammation, and reduced movement. As you can see here, we have to break the cycle, unless it is very difficult to remove that from the body. So basically, it was the motto that is modify the disease rather than the symptoms alone. Now the days has become changed. Now, ladies and gentlemen, now we have to modify the cause rather than the symptoms alone. One step ahead, we have to modify this at the cellular level. And then now it is a supersonic era, so that another step ahead. So we have to find out the genetic level to control the pain management. Now, in this talk, I'm going to describe one chemotherapeutic agent which can completely take care of all this. So it's a breakthrough pain management. So it's a Pinoc-XL. Pinoc-XL is basically, it is a combination of the palmitoyl ethanylamide and the astaxanthin. What is the basis? It is a strong scientific basis. It's a genetic basis of pain perception. Somebody's perceive pain very little, somebody's very high, and there is some congenital insufficiency of pain, congenital absence of pain syndrome. So from that level, it is seen the congenital insensitive to pain in type 1, which is linked to the gene encoding submit of the serine palmitoyl transferase, and it is a gene encoding. And another important study has already come. There is a common sensory stimulation that produces a catecholamine O methyl transferase, and the absence of these lead to the significant pain insensitivity. So that is how the palmitoyl ethanylamide came. It is endogenous amide, belongs to these autocoids, and basically it modulates the pain perception, transmission, amplification, as well as signaling the pathways of the sensory neurons. Not only that, it maintains the cellular homeostasis, so that once there are some inflammatory markers that produce the action potential across the cell membrane, it blocks that, it stabilizes the cell membrane, so that this perception cannot, the pain, that stimulus cannot go inside the body. Not only that, it modulates the pain perception also. So it has not only the analgesic action, but by inhibiting the muscle degranulation. But also, it has an anti-inflammatory action by upregulating the PPAR receptors, which reduce the inflammatory mediators like TNF-alpha and the NF. So there are mode of actions. Basically, it not only reduces the pain, but also it reduces the inflammation. So it's a suitable drug which can modify the cause rather than the disease, ultimately leads to the symptom-free. So the dynamics of the palmitoyl ethanylamide, it reduces the activation of the spinal cord microglia and the astrocyte. It is a significantly this is a change. It is a newer candidate in our armamentarium. it facilitates the regeneration. So if there's a neuropathic pain, it is a very, very highly effective neuropathic. And all of you know the chronic pain is at two components, nociception and then the neuropathic component. And it is a very, very highly efficacious for providing the neuro regeneration. Another is the entourage effect. It enhances the anti-inflammatory, the anti-nociceptive activity. So it is very, very suitable for the chronic pain. Now, justification of this combination. So palmital ethanolamide, it is a cause modifying therapy rather than the symptom modifying, as I first described. And as astaxanthin, remember this very, very important slide. It works against the free radicals. It provides the electrons or take out the electrons or take out the energy from the free radicals to make it inactive. It prevents the cell damage to the DNA. And last importance, very, very important, just ladies and gentlemen, find out this. It activates the longevity gene. Longevity, I think everybody we want to have the longevity, and this is the only drugs in our earth which activates the longevity gene of FOXO3A. So astaxanthin, it is a lipophilic end and also the hydrophilic ends. It is the unique characters, the lipophilic and the hydrophilic ends. So that is how it stabilizes the cell membrane. As you can know, the cell membrane it is a polar heads, it's hydrophilic, and the polar heads is hydrophilic, but inside it is a hydrophobic. But it has by two ends that binds with each other that stabilize the cell membrane. So that blocks the gate, so that any inflammation which outside any inflammatory markers that cannot open the gate, so that the pain perception cannot go inside that body. But not only that, what I highlighted, it inactivates the free radical by providing the electron or taking out the electron or taking out the energy, which is known as the quenching. So this method that neutralizes the free radicals, which is basically it's the essence of the aging process and the degeneration. So astaxanthin is the king of antioxidants. As you can see here, just I highlight, it spans the cell membrane, so it stabilizes the cell membrane. It quenches the singlet oxygen and scavenges free radicals, which is the basis of these the degeneration and the aging process. Not only that, the astaxanthin never turns into the pro-oxidant. It acts acts in the front in the war. It doesn't act as a pro-oxidant like vitamin C and other products. So mechanism is acts as a COX-2 inhibitor, and then not only that, apart from all the anti-inflammatory actions, it suppresses the inflammatory gene expression by suppressing the kappa B kinase dependent. So that is in the gene level it acts. So the past trial, there are several trials, not going into detail. It is a highly efficacious and proved to become effective. So this is the last slide. This controls the basic basal thresholds of both the inflammation as also the pain. It preserves the peripheral nerve morphology. There is no adverse side effects. It is effective and a safe option for the elderly patients with chronic pain and the multiple modality. So there are several multiple mechanisms, and it is effective in osteoarthritis, rheumatoid arthritis, carpal tunnel syndrome, as also the sciatica. Dosage is very convenient. That is 1 tablet twice daily for at least 6 weeks, 6 to 12 weeks. So thank you. So this is the novel armamentarium. I think it will be helpful for the all orthopedic, not only the orthopedic surgeons, but also the all health investigators and also the clinicians. Thank you.
Thank you, Professor Park, sir. And I thank all the chairpersons of the OTA session. It was a wonderfully organized session, and we will take a tea break for